of the overall anatomy. And around 6 months later, and in August 2017, he suddenly developed a sudden onset of left upper limb numbness and slurring of speech, and also facial asymmetry, which has a gradual improvement after 2 hours. And we gave the diagnosis of a transient ischemic attack, and we started the patients on double antiplatelet agent and also lipid-lowering drugs. However, on the next day morning, he complained of a sudden onset of right eye total vision loss, and fundoscopy showed that there is a cherry red spot with a surrounding pale disc, which is compatible with central retinal artery occlusions. So we perform a CT angiogram, which shows a new luminal thrombus in the right common carotid artery with almost total complete occlusion. However, the external carotid and internal carotid arteries remains opacified. So we can see this luminal thrombus extend quite a segment. However, the side branch of the innominate artery is actually still patent. We did a duplex ultrasound showing that there is a reverse flow. Basically, the right internal carotid artery is being supplied retrograde from the right external carotid artery. So we gave ourselves questions: what is the cause of the thrombosis? And actually, he had 2 thromboses. The first one is thrombosed carotid subclavian bypass 4 months after surgery. And the second one is a symptomatic thrombosis of the right common carotid artery 6 months after the arch branch TIVA. We think about the potential causes of mechanical or hematological. Mechanically, there is no evidence of kinking or abnormal anatomy. And hematologically, we only figure out there is a temporary thrombocytosis right after the TIVA procedure with a platelet count up to 700. Which may be secondary to the inflammations after the surgery. And it is actually very temporary, and it's gradually go back to normal. And after extensive workup, there is no evidence of thrombophilia, and we started the patients on low molecular weight heparin. And to prevent future embolies, we perform a right common carotid artery thrombectomy with extension of the innominate side branch. Soon after the diagnosis, we assess the right common carotid and also the right brachial arteries. We perform the thrombectomy from the carotid with Fogarty catheter, and afterwards we suspect there is a stenosis at the stent graft side branch in the innominate arteries, and therefore we extend the innominate side branch with 2 centimeters distal extensions. We started on dual antiplatelet agents afterwards. So this is the on-table angiogram showing the complete blockage of the common carotid arteries over the right side. And we performed the thrombectomy. Actually, we can see quite a segment of thrombus retrieved, and there is a good blood flow afterwards. And after the thrombectomy, on the left side, we see that there is a suspicious filling defect just distal to the side branch, and we add on with another extensions. And this is the post-op investigations, which shows that the arteries are patent. After the operations, we still have a follow-up CT scans on these patients, which shows that similar findings with a prominent fenestration at the abdominal aorta and a partial false lumen thrombosis over the top part of the descending thoracic aorta. And gradually, however, in September 2019, we found that there is an interval enlargement of the aortic set size at the distal aortic arch from 7 centimeters to 7.4 centimeters, which signifies that the aortic arch is actually pressurized by the persistent retrograde perfusions from the secondary tear. So we gave the patients considerations of false lumen occluder with a distal extension to the TIVA to the celiac artery level. So this is the measurement. This now measures 7.4 centimeters. And however, the patients was not keen for treatment, and we continue follow-up on these patients. And this is the latest CT scan in November last year, which showed the development of a new stent graft-induced new entry, and there is increase in the false lumen perfusions. However, the distal aortic sac size is similar, around 7.2 centimeters. So we can appreciate on the left-hand side, the filling in the false lumen is actually increased and extending more high up in the thoracic part. And on the right side, we can see that the sign. So this is for the appreciations of the overall anatomy in these current situations. So in summary, this is a 51-year-old gentleman with uncomplicated type B aortic dissection started on medical therapy. He developed chronic the dissected aneurysms 3 years after presentations with an inadequate possible landing zone. We decided to put in an arch branch device, which is complicated with a bypass graft thrombosis and also the right common carotid artery thrombosis, which requires re-interventions. The current problem now is he has a persistent false lumen retrograde perfusions, enlarging size of the thoracic aorta, and also a newly developed sign. Thank you.
Thank you very much. I think this case is a very nice case, and I think Victor will agree with me that it illustrates a lot of the challenges that we face as an aortic or vascular surgeon. First of all, insufficient landing zone of the arch, when to do arch branch. Secondly is in complicated, complex chronic type B aortic dissection, how do we define success and how to tackle the distal reentry? Victor, any comment?
Wow, it's a pretty complicated case.
Yes. Right.
I missed it. How many days before your main procedure did you do your bypass?
I think 4 years. 4 months, sorry. 4 months, according to the Jackie. Yeah, that's. I think we can have leave all the discussion. So we welcome all our friends around the world to put their question online. Then hopefully we can utilize the final 20 minutes to discuss all the question. Do you agree, Victor?
Sounds good.
So why don't we move to the next speaker? Next speaker is Professor Wurawong Silsakkorn. So actually, Professor Wurawong requires no introduction. He is one of the pioneers of aortic intervention in Thailand. He received his training in Utrecht and also Cleveland Clinic, even day back in 2005. So he has personally performed more than 200 thoracic aortic and more than 100 abdominal aortic operation at Sarira aortic team. So today he's going to give a talk on the total arch replacement and frozen elephant trunk challenges and durability. Professor Wurawong. Thank you very much, Professor Wu Wong, and I think he will be online with us in the discussion session. So if you have any question, reminded to submit it through the online platform so we can discuss and share with all of you. Victor?
Hi, so I'm here to introduce your next speaker, Mr. Dr. Kensuke Ozaki. He's a graduate of the Yamanashi University, Japan, and completed his training at the Kawasaki Aortic Center in cardiovascular surgery, where he has worked for 8 years and has accrued experience in over 900 aortic surgeries as operator. He's currently serving as the Vice Chief of the Kawasaki Aortic Center. He's here to talk to us about the aortic arch replacement via left thoracotomy. Uh, thank you, Mr. Dr. Ozaki, for that really great talk. The results are pretty amazing. We'll save the questions for you for later. Let me introduce to the next speaker, who's actually our symposium chair, Dr. Randolph Wong. He's currently the consultant and chief of cardiac surgery at the Prince of Wales Hospital and clinical associate professor of the Chinese University in Hong Kong. His interests include complex aortic surgery, hybrid aortic interventions, as well as minimally invasive cardiovascular procedures. He's contributed over 123 publications in peer-reviewed journals, 7 book chapters, and more than 90 invited talks, and is editor of quite a few journals such as Chest, Heart, etc. And is also involved in many societies such as the American College of Chest Physicians, EACTS, as well as ASCVTS. He's here to speak to us about the importance of second stage interventions for frozen elephant trunk.
Thank you very much, Victor, for your kind introductions. And in fact, I'm very happy here to share our experience with you all after listening to the very great talk from 2 prior speakers. So today my topic is the total heart frozen elephant trunk, the importance of the second stage intervention. So this is the volume of our hospital, the Prince Edward Hospital, and in every year we have around 70 to 90 cases of aortic intervention, and there's a gradual increase in the overall volume in our center. And also, especially in type aortic dissection, we are doing around 30 to 40 cases per year. And so far last year, we have 0 mortality. That, of course, the reason comes with multiple reasons why we can achieve this result. But I want to share with you one of the reasons is we believe it's the introductions of the total heart frozen elephant trunk. It was first introduced in 2014 in August. In our center, the indication of total heart frozen elephant trunk is similar to what Professor Wong just mentioned. We actually have a similarity with the EACT vascular domain guideline, which include type aortic dissection when the tear is at the distal arch or the distal malperfusion. Type aortic dissection patient when we want to treat multiple segments and in one stage, single stage. And in type aortic dissection without good landing zone in the arch. So in fact, the first case that we have done, actually we have published in CTSNet and in previously. And you're welcome to visit it. So today my role is to share with you, after the 4 years ago we present our first case, what about a midterm outcome? I think for aortic or vascular surgeon or cardiac surgeon, we are indebted to our patient that they allow us to tackle complex aortic problem of theirs. So we should be able to show them what is the long-term or at least midterm to long-term outcome of their disease. So this paper is published in Seminar of Thoracic and Cardiovascular Surgery. Basically, it's a retrospective review of prospectively collected data from 2014 to 2020. All patients with 4-flex implantation were included. So this is the data. We have done 41. Now currently we have done 47, but that was during the publication. We have done 41 cases. So far, 19.5% of our patients have malperfusion. And also 36.6% of our patients with type A aortic dissection. And around 14.6% of our patients have prior aortic intervention. So in this cohort is included also our early experience with the total heart frozen elephant trunk. So you might notice the overall hypothermic circulatory arrest time is slightly longer. It's around 89 minutes. And I agree with Dr. Osaki and also Professor Wong's presentation just now from large-scale analysis showing that from Japan, showing that actually the circulatory arrest time and hypothermia itself may not have a significant implication of the SCI after the procedure. That's why we take our time to perform circumferential reinforcement with 3O-plagiated proline during the distal anastomosis, as we believe hemostasis is of paramount importance in this group patient. As you can see from our data, the average transfusion requirement of red cell is only 4 units. And as I just mentioned, the emergency, we have 40% of our patients, actually the indications of emergency procedure. We also have 24% of our population have concomitant procedure, including CBG, Bentor, AVR, TIVA, ECMO. So in our outcome, in fact, the in-hospital mortality is 9.8%. If you count the recent one, it's changed or improved further. But I want to highlight the two emergency mortality. One is, at that time, we try to be indiscriminative with all the patients. So basically, one patient presents with pre-op stroke with confusion. And we proceed with the procedure, and finally, patient with persistent stroke and die. And the other one actually is one of, I think the indication is wrong because it's a ruptured descending diverticulum of Komarov, and unfortunately the frozen elephant trunk is unable to exclude the rupture origins of the diverticulum. That's why I think we have two mortality in the emergency setting. But one point to note is overall the ICU length of stay is only 1.5 days, and also the post-discharge survival is 94.6%. And we have 4.9% patient with restenotomy for hemostasis. In fact, for the past 1 year, for the 90 cases that we have done in Principal Hospital, we have no restenotomy for hemostasis for all aortic procedure. We have 4.9% patient with stroke, and spinal cord ischemia for the permanent SCI is only 2.4%. We also have 7.3% vocal cord paralysis. And in the recent few cases, in fact, we don't have many cases of vocal cord paralysis because we almost moved from zone 3 to zone 2 anastomosis. And this is the 3 years post-discharge survival. As you can see, we published in the Seminar Thoracic Cardiovascular Surgery. In fact, we have 100% 3-year survival. That, thanks to the vigilant surveillance, we actually performed CT aortogram in 1 week, 3 months, 6 months for 2 times, and then yearly. And to our surprise, because of our initial experience, 32% of our patients required second stage procedure. But this is the key, how we can achieve a good midterm to long-term survival, I believe. So 5 cases require endovascular second stage, and 4 with open second stage include 2 descending replacement and 2 Crawford Extend 2. So as we all know, there are many ways to tackle aortic ascending, arch, and descending pathology. But the key, especially in aortic dissection and chronic aortic dissection, is how to tackle the persistently perfused descending false lumen. I think Jackie have previously just illustrate his case and the challenges in tackling the chronic type aortic dissection. The limitation that we have now is we can confidently close the front door with Floraflex or other elephant trunk devices, and we can make sure there's no type 1A endoleak, no type 2 endoleak. But how do we close the back door? The following are illustrations. To us, there are 3 ways. One is open descending aortic replacement, or thoracoabdominal replacement is definitive. But a lot of time, patient may not accept that because it's a highly invasive and procedure with a massive transfusion, long procedure time. The other option is if the descending and the upper abdominal aorta have a big communication, and if the false lumen also big, we can consider the candy plug device to occlude the false lumen. The third option is if the supraceliac portions of the abdominal aorta is within the normal size, less than 4 centimeters, we can consider aortic fenestration to create a common distal sill. So these are the diagrammatic illustrations of how do we choose the different devices to achieve false lumen occlusions in the descending, persistently perfused descending aneurysm, dissecting aneurysm. So this one way, we can use the communication, access to the false lumen, and implant stent graft. And also we need to extend the proximal sealing, distal sealing, by extending the true lumen stent as well. The other options we also publish in Nanosothoracic Surgery is we can use the RF ablation to fenestrate the aortic septum around 2 cm above the celiac axis and gain access to the false lumen, and then like this. So using these RFA catheter, puncture the septum, access to the false lumen, and then we can use balloon to create a common landing zone so that the stent can sit on a common sealed zone to reduce any type 1B endoleak. So this is one of the case that we have done and also published in Nanosothoracic Surgery. The options to us, which is most definitive, is the open descending thoracic aortic replacement. And we also have published in the EJCTS about how do we do the anastomosis, thanks to one of our former Kawasaki Aortic Center colleague, Dr. Fujigawa. He is very talented in not only operation and also in medical illustration. And this illustration is done by him. The key is to take small bites, an even bite, and a 1-to-1 size graft. And this is the postoperative CT scan. And we have another Crawford extent to after Foroflex that have shown no endo leak. And subsequently, patients actually don't need contrast CT scan. And that would lead to less contrast aortopathy. So to conclude, ladies and gentlemen, I think Foroflex is a good hybrid option to treat ascending arch and proximal descending as one-stage approach. And now, of course, we have other options of a total arch frozen elephant trunk device. And regular postoperative imaging is essential to identify who need a second-stage treatment. And open and endovascular options are now available after post-total arch frozen elephant trunk cases, and the results are promising. Thank you.
Thanks very much, Randolph. That was an excellent talk. We'll leave the questions to later. So, we go to the next speaker, who is Professor Stephen Cheng, who actually doesn't require any introduction. He's actually the chief of the Division of Vascular Surgery and director of the Francis Y.H. Tian Vascular Disease Center and the Vascular Laboratories since 1992, and currently the Serena H.C. Yang Professor of Vascular Surgery at the University of Hong Kong. Professor Cheng has played a key role in the development of vascular and endovascular surgery in Hong Kong, and he's a distinguished member of many societies such as the Society of Vascular Surgery, Australia-New Zealand Society of Vascular Surgery, and the European Society of Vascular Surgery. He has authored over 200 publications in peer-reviewed journals and book chapters. He's here to talk to us about the arch endograft, lessons and tips.
Thank you very much, Victor, for the kind introduction. So we have had several very good talks from prominent cardiac surgeons addressing areas in the aortic arch. So maybe I can change a little bit. Need to take the mask off. We can change a little bit and move on to endovascular options of treating diseases in the aortic arch. I'd like to share with you some of our lessons and tips that I've learned, and to show you what the trend is in this relatively new technology. There are various methods, as you know, in treating the diseases of the aortic arch using endovascular means with their own unique issues. The branching has significant complications. Chimneys has seals and endoleak problems. Fenestrations has long-term fixation issues. In situ fenestration may have durability questions. And finally, the branch endograft, which I'm going to address, has issues with stroke. So I think the next talk, Dr. Stephen Howlon is going to tell you the intricacies of how the technique is going to be done, and to be followed by several, again, key speakers on various other technology like fenestrations and in situ fenestration. So I'm concentrating on addressing the diseases of the aortic arch using branch endografts. So these are the three usual pathologies that we need to address: the disease or aneurysms in the distal arch, residual dissections or dissecting aneurysms, again in the distal arch, or pathology in the aortic arch involving the side branches itself. One of the interesting developments is that we are starting to have the nexus or endospan graft, which uses usually a one single branch with a module in the ascending aorta. We haven't had much experience in using this device because I really don't like the single branch idea, and also having the weakling in the ascending aortic region. But I know that there are some hospitals in Hong Kong that has done a few of this technology. So what we are concentrating on is two other competing devices, the Coke device like this one, which can be made into a single custom side branch with an integrated side branch, addressing a patient who already have a debranching in the neck, or the double side branch. This is one of the relay or Terumo relay double branch, where you have a large 5 centimeter long recess accommodated by two 12 and 10 millimeter parallel side branch, again arranged anticipatedly in front. So with this very large recess, you can make sure that you have perfusion of the cerebral vessels while you perform the cannulation in itself. The design is also very good. It has an outer sheath and also has a inner flexible sheath that negotiate the aortic arch very well. I think the deployment is very, very accurate in this situation and make for a very good landing. So this is a very short video to show the double branch where the outer sheath is here and then the inner sheath is advanced through a stiff wire into the left ventricle. We use the IVC occlusion balloon technique to reduce the blood pressure. And you note that the marker is very, very accurately deployed. So once the graft is deployed, you have time to cannulate the two side branches side by side. The only downside of this graph, as I believe, is that the branches are a little bit stiff. They use the trio side branches for the two arch vessels, and also because of the parallel design of the side branches, sometimes it's a bit difficult. You have to turn to an anterior-posterior position to find that you have actually cannulated the correct side branch. So the other design, of course, is the Coke A branch, which originally was the two inner side branch technique design, where you have two staggered side branches, 10 and 8 millimeters, arranged in a staggered manner. So the first one is for the nominate, and the second one is for the left common carotid artery. And there are two designs using one or two proximal seating stents. There are additional requirements. The greater curve should be either 50 to 70 millimeters. The diameter should not exceed 38 millimeters in diameter. And also the curve of the inner curve or the lesser curve, the diameter of the curve should not be more than less than 20 millimeters in diameter. Otherwise, the graft may open in a relatively less predictable position away from the coronary. So this is something that we have also learned to notice. Just some of the examples. If you use a two-branch design, you need to do a carotid subclavian bypass, usually for us in a staged manner. So the beauty of a staggered side branch is that in case of a problem, like in this patient where the second branch was actually rotated, this is the only time that we have a side branch rotated, that we cannot cannulate the side branch from the left common carotid artery. So actually we can deploy a graft from the subclavian through this side branch and then leave the perfusion of the brain from the carotid subclavian bypass, and then we plug the left common carotid artery. So this is one of the potential bailout situation where you can use for this. The direction we are moving now is to move on to a complete or so-called complete endovascular solution to not use the carotid subclavian bypass, but instead using a third retrogradely placed side branch where you can access from the groin. So that is the design for a three side branch arrangement, 1, 2, and then you add a third branch where there is a preloaded catheter that is coming in from the femoral artery that you snare from the left subclavian artery, and through this you deploy the graft into the subclavian. So that is the usual A branch or the arch branch coming in from the bottom, again using a stiff wire in the left ventricle crossing the aortic valve, making sure in the coronaries he has a prosthetic replacement, previously IVC balloon occlusion, the main body being opened, and then you cannulate the two side branches in the usual manner, puncturing the carotids, the innominate side branch using a short tip device, deploying the custom-made innominate side branch. And then that is the left common carotid cannulation from a puncture of the left common carotid, and then a fluency on the left side. And then the third, this is the stiff wire into the preloaded catheter, and then the device is withdrawn. And on this preloaded wire, we will advance a sheath into the third side branch, and then use a side puncture to cannulate the left subclavian artery. And once we establish this through wire, it's a very stable system, and we can actually put in whatever covers that, in this case a fluency, to bridge the gap and effect a complete endovascular repair without the need for a neck bypass. So that is the completion of a three branch device. So what are we moving? So there's another patient, I believe, for a coronary dissection. So there are two designs. One is using a 70 millimeter distance, and then the second one is the third side branch is away from the two main side branches, both at 90 to 110 millimeter design. So the experts in Europe have examined these different plans, 1, 2, and 3, and they found that most of the time this one would fit 80% of the patients, at least in Europe. Also, the Terumo is also looking to this, so they're coming off with the relay 3-branch that we haven't tried. The results of the endovascular repair of the arch, I think the Achilles heel is still the issue with stroke. So single center experience from the Cook A branch and also multi-center from Terumo double branch, similar rates of stroke. Sometimes can go to 20%. All strokes, again, for the initial results for the Terumo side branch is not that good. But for the overview for relay experience, again, 10%, 7 to 10% mortality, about 7 to 10% stroke, and then some disabling stroke, non-disabling strokes. So these are Queen Mary Hospital results. We've done 24 so far using a variety of different graphs. So relay and so Coke, and then the Coke 3-branch devices. And you can see the results on the right side where the orange is the stroke. Deep orange is intraoperative or perioperative stroke, and then there's some late stroke, as Jackie has reported earlier, and there are 2 hospital mortalities and 2 late mortalities. So there remain an issue, the strokes. That's just a summary, 24 patients. These are old patients. 1/4 of these patients are dissections, so we can do this on dissections, and overall 8% operating mortality and 12% procedural stroke rate. So, and we've seen this occlusion issue that has happened in 2 patients, usually on the left common carotid branch. So in summary, I believe the technology is there. There are certain things that we already addressed. Delay, we can pretty much do this as an off-the-shelf device. Crossing aortic valve is no longer a problem. Blood pressure control, we can use an IVC occlusion balloon, which works very well. Cannulation, I don't think that's an issue, but stroke and durability is something that we've yet to address in future. Thank you very much for your attention.
Thank you very much, Professor Chang. I think this is a very informative talk. And we have learned a lot from the new technology, including all total endovascular treatment for even arch disease. So it's my honor and pleasure to introduce the next speaker, Professor Stefan Holon. In fact, Stefan knows introductions. He's currently the co-director of the Paris Vascular Insight Meeting, Critical Issue of Aortic Endograft Expert Symposium, and also the annual Charing Cross Symposium. Is also the current president-elect of the European Society of Vascular Surgery for the 2019 and 2020. Today, he's going to share his talk, Total Percutaneous Arch Branch Repair, with us. Stephen.
east. We will then use a 12x4 balloon to make sure that we have a good seal at the level of the overlap between the branch and the bridging limb. And do a selective angio to check and that we have a good seal and that the carotid and axillary are both patent. At this stage, we advance a 6 French sheath from the brachial approach. We close the proglides and then inflate a short big raft covered stent to make sure that we have no leak at the level of the puncture site. Now the delivery system of the branch endograft is retrieved, and over a wire that has been pushed through the preloaded catheter, we advance a large sheath from the groin and then a 5 French sheath here all the way through the branches and back into the endograft lumen. This is a rim catheter. A wire is pushed down and snared here from the larger femoral sheath, and then over this through and through wire we advance an 8 French 90 sheath here. It's going to be pushed into the ascending aorta and then pulled back into the left common carotid branch. You can see here the tip. Selective catheterization of the left common carotid is straight forward. Angio checking position of the wire, and then a big graft plus is advanced from the groin and tracks quite easily through that curve, and the stent is then implanted in the right position. Selective angio here, checking that we have no leak and no dissection, and finally the sheath is retrieved to access the left subclavian artery, and then a Viaband bridging stent is advanced after checking the position of the vertebral artery origin. There we are. The Viaband is now advanced, and then a completion selective angio, and then the completion angio will show you that we have completely excluded a very large 9 centimeter aneurysm here. This is the post-op CT, and the patient is doing nice. We have concerns regarding the absence of carotid clamping, but we will use filters in the future for those cases. And the access from the axillary requires a stiff wire position again in the left ventricle. Benefits: we don't have bilateral cut downs, no neck hematoma and swelling, and a very swift workflow. Thank you very much.
Well, thank you very much. I think this is a truly exciting talk with the totally percutaneous approach. And in fact, I'm sure we have a lot of questions to ask Professor Holon. But let me introduce our next speaker. Actually, is a co-chair of this morning's session, Professor Victor Chow. Professor Chow actually, again, need no introduction. He's a senior consultant at the Department of Cardiothoracic Surgery at National Heart Centre, Singapore. Victor is the pioneer of aortic intervention in Singapore, and he received training in the St. Vincent Hospital, Melbourne, Australia in 2005, 2006, and also Cleveland Clinic Foundation in 2006 to 2008. Victor pioneered a lot of aortic intervention in Singapore, and today he's going to share with us fenestrated TIVA for arch pathologies. Victor.
Thank you, Randall, for your kind intro. Morning, everybody. My talk is on fenestrated endografts for the arch. I have no financial disclosures. Fenestrated procedures address pathology of the mid and distal arch without needing a landing zone in the ascending aorta, but rather in the proximal or mid arch. Fenestrations and/or scallops are deployed in line with the target vessels, avoiding the need for cervical debranching procedures. These are the 3 arch fenestrated devices in the market that I know of: Cook Medical, Terumo Relay Plus, and the Najuta system, which is available only in Japan. This study from Germany is the largest series extent for the Cook medical device. It reports 44 patients with technical success of
Victor, can you
95%.
change to full screen? Sorry, the presentation mode. Thank you.
Okay, sorry.
Thank you.
Better? Okay. This study from Germany is the largest series extent for the Cook medical device. It reports 44 patients with technical success of 95% and a 9% mortality. 7% had major strokes and 2% had minor stroke. 7% had temporary had paraplegia and 7% required reintervention. Survival at 1 year was 78% and 72% at 2 years. For the Relay Plus device, this Spanish study describes 14 patients, 9 with scallop devices and 5 with fenestrated devices. Technical success was 100%. There was 1 fatal stroke, no paraplegia. At 3-year follow-up, there were no further deaths. 2 scallop cases had late endoleak, with no leak for fenestrated cases. This Japanese study describes 37 patients who underwent implant with the Najuta system. Technical success was also high at 97% with no deaths. Stroke rate was a bit high at 17% with 1 case of paraplegia. 28% of patients had type 1A endoleaks with 3 needing reinterventions. The aneurysm enlarged in 28% on follow-up. Survival was 71% at 7 years with freedom from aortic events at 51% at 7 years. Regarding our local data from Singapore using the Cook platform, we had 21 patients, mostly aneurysms and chronic dissections. 57% of devices landed in zone 0, 38% in zone 1, and 10% in zone 2. There were 52 target vessels, of which 2/3 were treated with fenestrations and the rest by scallops. Most devices had single fenestrations with a scallop, while 6 devices needed double fenestrations. 4 patients needed bypass. Technical success was 100% with 1 death, which was a fatal stroke. There was a delayed minor stroke in a patient who was discharged without antiplatelet therapy after about 2 weeks plus. No patients had paraplegia. 29% of patients had some form of endoleak, about half from type 2, half of whom required reinterventions. With a follow-up of about 2 years plus, we had no aneurysm-related deaths. The Cook customized devices come featured with single fenestration, single scallop, or 1 scallop with 1 or 2 fenestrations. The maximum seal zone diameter is 38 millimeters, as the largest graft available is 46 mm. No fenestrations can be made for the innominate artery due to the arch curvature at that point, and patients with double curve in the arch are not suitable. Fenestrations come in 8, 10, and 12 millimeters, and the graft should not be more than 25 cm long. Devices come with a preloaded catheter and wire to the scallop or fenestration, which helps in getting through and through wire, improving accuracy in aligning fenestrations to target vessels. With the reference to arch configurations, type 1 and 2 arch configurations are more favorable, whereas type 3 is not so much. This is the plan for endograft with fenestrations for the left carotid and the subclavian and the scallop for the innominate. The main pitfalls for the fenestrated grafts are too much manipulation, which in a diseased arch can lead to embolization and stroke, as well as looping of the through and through wire around the nose cone, which I'll show in a bit. This is an early case with a fenestration for the left subclavian artery. We had snapped the exchange length glide wire in the ascending aorta. The problem is we unsheathed too early without realizing the wire got looped around the nose cone. So we tried losing the wire and re-snaring, but the loop remained. So we unsheathed the stent, fully opening the fenestration and accessed using a second wire. Okay, and then we unsheathed the rest of the stent graft, and we were lucky that the fenestration was in alignment with the target vessel. So that was pretty hairy. So the result was not too bad. Here's an example of where our through and through wire got looped around the nose cone. Because we had not yet unsheathed, we could withdraw the Lundequist and the nose cone and remove the slack in the through and through wire. Okay, sorry, a bit slow, this thing. Okay, and then re-advance the wire and the nose cone. So actually the best is, instead of snaring the ascending aorta, it's best to directly select the left common carotid artery where it can be snared. And then while maintaining tension on the wire to remove the slack, the device is advanced into position. Yep. Okay, when you're happy with the positioning, you very carefully begin to withdraw the sheath while keeping tension on the wire so that it doesn't loop around the scallop struts. This helps to also align the fenestrations to the target vessel. Okay, this is the ideal result, but we'll probably have to plug the subclavian later. So the downsides for the fenestrated endografts are their application is limited to the mid and distal arch. There's a need to snare and for wire manipulation in the arch, which may increase the risk of strokes. And also it's important to be accurate in deployment, or else you may risk occluding the arch vessel. Also, good apposition, the main body and the branch graft to the vessel wall is really important for durability. And because of the importance of a good fit, fenestrated grafts will probably remain custom devices. The upside is that they are simpler to do and can be performed faster than branch grafts, and they can be deployed under normal blood pressure where there's no need for rapid pacing or IBC balloon. And of course, endografts, branch endografts, of course, are, as compared to, are more forgiving, so you don't need so much manipulation. Tolerances in the rotational alignment can be up to 1 clock position, and the longitudinal allowance is up to 10 millimeters. Because of this, branch grafts may one day be off the shelf, and I think, are they already off the shelf already? Not to me anyway. But of course, with the higher movement of the arch during the cardiac cycle, branch endografts may be more durable and stable because the proximal seal is in the ascending aorta. Also, the patency of branches may prove to be superior to fenestrations. So in conclusion, the fen endografts remain a useful modality for treatment of the distal arch and mid-arch. I guess for now, the arch, branch, and fen devices will have complementary roles, though it's likely that the fen endografts may one day be phased out. Thank you very much.
Exciting talk. Thank you for sharing your previous experience with us. So maybe,
okay.
Yeah.
All right, okay. Shall I introduce the next speaker?
Yes, thank you.
Okay, the next speaker is Professor Lu Qingsheng, who's the Director of Vascular Surgery of Shanghai Hospital. He's also Chief Editor of the Vascular Surgery Annals of Vascular Surgery Chinese Surgical Annals. I think he trained in the Cleveland Clinic. Not that I think I know, because that's where we met. Hi, Ms. Dr. Lu, and we met 15 years ago. He's also co-inventor of the Castor branch stent graft. Dr. Lu is the leader in the vascular associations in the People's Republic of China, and he's here to share with us the on-table fenestration for arch endograft, the Chinese experience. Dr. Lu?
And thank you, Stephen, invitation. I will introduce endovascular repair with on-table penetrated endografts for aortic arch pathologies. I will introduce a technique, total aortic arch covered with on-table penetrated. I have no disclosures. Okay, and this group from 2016 to 2019, and the follow-up more than 1 year, and including totally is the 37 cases, including dissection and aneurysm, and 1 case aneurysm, but aneuric, we need more landing room. And this is the practice, and the some patients, there are 5 patients before operation have stroke history. And in this group, I use one, the main device is the Valent Captiva. And for example, this case, dissection, I use the triple penetrated, and that's the follow-up. And the aneurysm also can use the triple penetration with stent graft. and that's the follow-up. And one case like this, aneurysm, arch aneurysm, and I used triple penetration. And this case is dissection. I used a double penetration, but one aimed to the innominate and left carotid, left carotid artery. And this, the follow-up. Also, this aortic arch aneurysm is boring innominate and left common carotid artery and use the double penetration technique. And this is the penetration and revasculation details. And the 37 cases and the single penetration 11, double penetration 11, and triple penetration 14. Even one case we used the core trouble penetrations. And for the innominate, left common carotid artery, left subcarotid artery, and some cases original of the innominator of bovine aortic arch, as mentioned before that. The successful rate in this group is 91%, and there are 3 cases false but transfer to the chimney technique. And this the outcome, early outcome, the mortality, the early mortality is 2 case, and they are because of some stroke. This is the late outcome, and we follow up more than 1 year, so the mean follow-up time is 30 months. And you can see that aortic-related deaths is 2 cases. Non-aortic-related death is 1 case, and there are 2 cases annual reason. For stroke, just during the follow-up, just 1 case, and 1 case standard graft migration. Main tear in the arch. Okay, I will introduce the tear information technique from this video. I will show that quickly. Main tear in the arch near the innominate arteria. The dissection involved the whole arch and the fourth lumen from the arch to both common iliac arteries. All branches are from the true lumen, including innominate, left common carotid LSA, celiac SMA, and both renal arteries. For endo repair and for vitreal penetration, the measurement and the design are most important. First was also designed at 12 o'clock. And I will put the difference again. If I hold on the front grip and the stand graft will not rotate. I name the white point at the front grip is 12 o'clock, and the same directed position of stand graft is 12 o'clock. So I know where is 12 o'clock of the stand graft. Then I measure the stand graft and make penetration depending on the design. Firstly, I measure 35 millimeter distance from the top of the stand graft and make sure where is the 12 o'clock. I use a sharp-tipped scapular cut graft, make a 15 millimeter diameter hole at the correct position, and avoid cover the metal stand. The edge of the hole is smooth, and I will not suture anything. I will not suture any mark around the hole because I know circle direction from the white point of the front grip, and I know distance position from the metal stands. I do same step and procedure for the second and third penetrations. The contralateral hole turned to up. I simulate the stand graft into the femoral arterial, forwards through iliac, abdominal, and descending aorta, then to the arch. You can find the direction of penetration from 6 o'clock, turn over to 12 o'clock, went through over the arch. I call that loose direction turnover. Please remember that. Then reset the stand graft into the delivery system. My assistant help bending the hold on the handle and the front grip. The direction of penetration will turn over to 12 o'clock. I do the angiography for the patient at LAO 52 degree, as I mentioned during measurement from a CT workstation. I preset Y and sheaths in LSA and left common cardiac arterial. I deploy distal piece stent graft firstly, which is Valent 28-150 stent graft, as restricting an extensive stent graft for distal part. It should be in right position where covered proximal piece 4 to 5 centimeter. Turn over technique again. I made contralateral hole at the function of penetration will turn over to 12 o'clock. So when I put Valent captiva 36-200 stent graft into the femoral arterial, I should make the white point at the front grip to 6 o'clock and the contralateral hole turn to up. During I put the delivery system forwards, I hold on the handle and the front grip and avoid any rotating. That means I just stable the position of contralateral hole at the front grip. It will help to stable the white point of the front grip at 6 o'clock. And when forward through iliac abdominal descending aorta, then through over to the arch, the direction of penetration from 6 o'clock will turn over to 12 o'clock. I make sure the stent position from screen, including the first piece bare stent. I put the end of the third piece stent at the front edge of innominated arterial. Then deploy main body quickly. The first penetration was in right position, then all penetrations were in right position, depending on the measurement and design. The super stiff wire was put in the left ventricle, so the top of the delivery system can be put in the ascending aorta. During deployment, the patient's blood pressure was decreased to 90. I do angiography and make sure all the branches patent. Cover stent into the second penetration. 60 cover stent into the third penetration without balloon. 1380 stent graft through the first penetration, not cover the right cervical artery. At last, to angiography, it showed all branches patent, including right subclavian arterial and left ventral arterial. A little bit annulic from graft membrane is okay. After 3 years, the patient was followed up by CTA without any complication. Stent graft was stable, no any annulic. All the inside branch stent graft were patent and stable. Most part of fourth lumen thrombosis, just left some part in abdominal aorta.
Okay, and during the follow-up, we find there are 3 cases occlusion about branch because some cases I did not put into the in-stent. Maybe it's the reason. And how about the retrograde dissection? And during this group, there are no any retrograde dissection. But in other group, that not total aortic arch covered, like this case, these 2 cases, in this area, the jugular of the 0 zone and zone 1, this area, some dissection where a retrograde dissection will happen. So I think we should choose the right landing zone and the healthy and the oversize should decrease to the percent 0 to 5. And the key point is the pre-measured, pre-design, and the direction to cover technique is very useful. and not landing the zero, zero and 0, 1, and we should put instant into the penetration. This is just the technique. I think for the totally arch, maybe need more useful and more safety devices. Thank you.
Thank you, Professor Lu, for your excellent talk. You have pretty amazing results. We will reserve questions for you later. Thank you very much. We'll go to our next speaker, Professor Liu, who's the Professor and Master Tutor, Department of Vascular Surgery, 9th People's Hospital, Shanghai Jiao Tong University School of Medicine. Professor Liu trained at the Division of Vascular Surgery, San Raffaele Hospital in Milan, Italy, as well as the Texas Heart Institute of Texas University in the US. He is here to share with us the use of undersized in situ laser fenestration for treatment of aortic arch lesions, tips and techniques. Professor Liu.
Thank you. Thanks for your introduction. Good morning, Chief and panels. Thanks for the invitation to give this speech in Aortic Asia 2021. It is my great pleasure to share our experience in the treatment of aortic arch lesions with in situ laser fenestration during TIVA. No disclosures. And nowadays, there are several endovascular strategies to reconstruct the branches, side branches during TIVA. In China, the on-table fenestration or in situ fenestration is more popular. And however, it remains a challenge in aortic arch lesions. To make the long story short, today I'd like to just introduce our experience in situ laser fenestration. The reason we choose these lasers just because we have a long history in laser ablation of saphenous veins. Definitely, this laser is used safely in veins, and we also have in vitro and in vivo studies to prove its safety and the efficiency for the fenestration on the aortic stent graft. This is published data also showed its efficiency and safety with low rate of stroke and mortality in patients, including even in the aortic dissection involving zone 0. This paper is just published recently in EJVS. And until April 2021, there were totally 266 cases treated with this fenestration technique. Most of them is single one, and we have 45 triple fenestration cases for aortic arch disease, including dissection, aortic type A dissection, and IMH, and the aortic, and PAU, and sometimes cases of aneurysm. And there are 2 cases in hospital deaths. One was mainly caused by acute cerebral infarction and pleural infusion, and one was mainly caused by cardiac tamponade during procedures, just in very early cases. And 8 cases was found endoleak during follow-up. And just one retrograde dissection during the follow-up time, and it is treated by bento procedure 6 months later. This is the very brief procedures just show these techniques, and we normally have our brain protection ways, and we also made one fresh movie demo just to show the procedure more clearly. I just will show this demo very quickly. This is our sheath brain protection bypass. And after the sheath implantation, we will import the distal restrictor cover stent first, then the main body stent graft. Then do the filtration step one by one. First is the left carotid artery, and then the innominate artery. Balloon, pre-dilatation and the stent graft, and then the post-dilatations. And now I'd like to talk about the tips and techniques. First one is the way, our protection way. We did the extra cochlear bypass for cerebral protection with special tubes. She's mainly based on the short time of our laser filtration procedure. And this just shows the real images bypass during our surgery. And we have to, the disadvantage of this method of brain detection is that it is only protect the anterior cerebral circulation, but not the posterior. So we got one cerebral infarction in posterior circulation. Even our filtration procedure was very successful and smoothly. And for tip 2 is the main body and the distal restrictive cover stent. We use proximal main body stent graft and distal restrictive cover stent combination strategies. For the distal restrictive cover stent, we choose one domestic tipped stent graft and Cura LabTech, which is better suitable for the tipped descending aorta. And for the proximal main body, we mostly choose C-Tech, which is more flexible and better adapt to the arch. And this paper I just published recently just show this feasible and effective approach of the distal tipped cover stent with satisfactory aortic remodeling and a very low risk of sign and a spinal cord ischemia. And this just show the brief techniques of the laser penetration normally in 5 steps. Because of time, I could not tell the details. And first, we will reconstruct the left common artery by the PTA and stent graft, common stent graft. We normally use the fluorescy for the side branch stent. And in some cases, it was really difficult to fenestration with laser because of the almost parallel side branch to the aorta, and also some special anatomy of the arch. And we alternatively use acupunctures in situ fenestration with special needles, and also use these techniques to the innominate artery. Just as the video just shows how we use these needles to do the penetrations. This is the needle we use. And just to show also the acupuncture for the innominate artery. And for the laser penetration, we also use Osco steerable guiding seats to the penetration. It really improved the success rate. This is the final angel that shows this image, very good result. And for the follow-up CT also showed a good result. And the rate of the type 1B indolent from the distal side branch stent is very low, but we better treat it simultaneously. For this case, we also did the fenestration very quickly and smoothly, while the indolent was very clear. You can see the final final angio, we can clearly see the embolic close to the root of the left LSA. A small side of the branch stent may be the main cause of this embolic. So we extended one cover stent to the distal embolic and the embolic disappeared. And we suggested the branch stent should have 10 to 20% outside to the target vessel in diameters. Follow-up CTA also showed the total thrombosis of the fourth lumen. And the tips 5 is just the branch stents just will extending into the aorta too much, which may cause the instability of the main body stent graft and maybe induce the retrograde dissection in this case. And we did the Bento's procedure to treat it. The tip stress is the filtration, the in situ filtration the position is uncertain. It was found that the branch stent was compressed by the wire. Immediately we could input additional BMS to cover it, and also the severe stenosis could also treat this secondary during follow-up. But in our data, over 10% cases were found branch stents with significant compression, and most of them did not show hemodynamic change. And the major risk factor for the stent compression is the impact of the metal structure, which is inevitable. And we can measure the pressure using the metal scan system in vitro study, just in different position and different angle, just to confirm the compressions. And for the thermal damage of the tips of the sheaths by laser may cause distal microembolizations. That we have to pay attention to it. And the tips 8 is the heat produced by laser may increase the diameter, but not significant compared with the regular TIVA or EVA. So make a conclusion in situ venous laser penetration to revascularize the supra-aortic arch branches is a feasible and effective option during TIVA for type A dissections and aortic arch disease with high technical success, low mortality, and high patency of the signed branch. It may need further long-term follow-up to confirm these results. Thanks for your attention.
Okay, great. So Victor, can you hear us? Hi, good. So we have now Professor Cheng and also Dr. Tam here. Also we can welcome all the panel. Can we have all the panel on board? We would like to take a group photo. All the speakers, except Stephen Hollande. He's still sleeping, I think, at the 3 a.m. in France. Oh, hi, friends. So is everyone here? Why don't we look at the camera and we can take a group photo? So when I count to 3, is it okay? Okay, 3, 2, 1, cheese. Is it done, the group photo? Okay, good. So now we can start the discussion. First of all, Professor Jiang, do you want to? Okay, maybe I start from one question that raised by one of our audience. So for the first case that Dr. Jackie Tam presented, the question is, was the LSA embolized proximally after the carotid LSA bypass? Because from the pre-TIVA angio, it appears it was not. This might decrease the flow through the bypass graft and contribute to thrombosis. So, Jackie?
Yes, thank you. So maybe I supplement a bit. We did this procedure as a two-stage procedure. So the first stage is simply a bypass graft without embolizations. So usually, if we proceed with an arch branch second stage procedure, we did the embolization at the second stage, mainly for the purpose of decreasing the endo leak from the subclavian arteries. So the answer is no, we didn't embolize the proximal subclavian artery in these patients.
Yes, I think the other advantage of leaving the subclavian branch open is like when I show you, in case there was a misplacement of the arch branch, then we can still access the sac from the subclavian artery. So, so we believe we would leave the subclavian branch open. We don't think the competitive flow would be an issue. I don't think we've seen any branch occlusion. Maybe one patient had a branch occlusion for the 24, but we believe that leaving the subclavian branch open will give us an option to cannulate the inner branches in case there was a misplacement, which was fortunately very rare.
I have one question to ask Dr. Kensuke Ozaki. So for your left thoracotomy total arch replacement, so how do you place the do you place LV vent, and where do you place the LV vent?
Thank you for asking, Dr. Randolph. Basically, we have no venting, but before we defibrillate the heart, we stick the apex by needle, and venting the air.
Okay, but you also put in a PA drainage, right? So I think that might help to reduce the LV from distension.
Yes,
all right.
That's right.
So in your experience, what are the most challenging part of your left thoracotomy, total arch, and descending replacement? Because I think it seems a very good approach to tackle multi-segment aortic pathology. So do you think there's any limitation that you will not choose this approach and go back to this two-stage approach? Any limitation?
Excuse me, I beg your pardon.
So do you think this left thoracotomy total arch replacement have any limitation? Any situation that you will not choose this approach?
Okay. I feel so there is some limitation to anastomose the proximal side. So this good option is after the hemiarch replacement is very easy because of the just only anastomose graft to graft. And sometimes innominate artery has the chronic dissection, and sometimes very difficult to anastomose the innominate artery. In my experience, one time, very difficult to see and anastomose the innominate artery. So this is, I feel, a limitation.
Thank you. Thank you.
Can I ask a question to Professor Liu Xiaoping? Professor Liu, thank you very much for doing this talk. I'm very impressed with the numbers. I noticed you prefer to use the Ancura stent graft. Is that because this is PTFE? You believe there is a difference in the materials that would impact on durability? Do you understand what I'm saying? So do you prefer PTFE to Dacron grafts for in situ fenestration?
I think the PTFE material is better than the Dacron is in this descending order, and the taped shape is also the better reason why we choose this stent graft, because in Asia patient or in China, most of the patient has a very large, a little bit the oversize is different in the distal. In the proximal aorta is much larger than the distal one, so we need a tapered one. So for this, for the material of the this stent graft, I think it's much important for these reasons.
And perhaps Professor Lu Xingxing, thank you very much for coming. Do you prefer, you prefer Valiant grafts because the material is better in terms of, do you find there is a difference in durability because there's no support rings in either in situ or on table fenestration techniques.
You missed the durability about the different material, correct?
Is there is there a possibility of the stand tearing the fenestration if there is no support?
Yes, we should support that. But for big, in some case, penetrations we not instant. You mean not support this, but it's a big penetration, and because we need a landing room, it's not affair about the endolic. Some the aneurysm just in the small curve. So during the follow-up, I just showed the true, the real world that during the follow-up is stable. So I think it's stable.
So may I ask the panel that, so far for the arch branch endograft or the arch intervention, endovascular intervention, it seems a stroke still be a problem. So what do you think is the possible mechanism in this case? Is it embolization, intervention through the vessel itself, or kinking? What do you think? Welcome to all panel.
Actually, for us, we did 21 fenestrated devices and had only one stroke, a major one. We started doing arch branch devices. We did 3, and of the 3, we had 2 moderate strokes. I'm wondering whether it's because the arch branch devices needs a lot of material for their branches. Because for the fenestrated devices, we just use the Bentley, which is a very small stent. But the arch branch device is the branches, the main body for the innominate is quite big and long, and also the fluency which you use is also quite long. So I'm wondering whether we should do dual antiplatelet therapy for these patients. I'm just wondering. Because the one case, so we had one major stroke who died and one small stroke. And the small stroke patient was a delayed stroke because we did not start antiplatelet therapy. So I'm just wondering whether it's a matter of anticoagulation and due to the large amount of graft material for the arch branch device.
Yes, I think initially we thought it is because of embolism, because the early results of the arch branch was also a little bit disappointing in our opinion, and we thought it is because of embolism. Subsequently we changed our practice. We prefer direct carotid access. In the past, we used the bypass. We used the carotid subclavian bypass to cannulate the common carotid side branch. I think there may be some residual emboli in the side branch, and because of the anesmosis, you have to turn there. So I thought when we switch to direct carotid access, we can clamp the distal part of the carotid, and that significantly reduce the stroke. I don't know whether that is an issue. And the second things that I noticed when our stroke rates come down is when we can do the procedure quicker. I firmly believe, the duration of the operation has impact significantly on the risk of stroke. So as we get to more familiar with the procedure and do it much faster, and now we can do it in maybe 4 hours, 4.5 hours, then the stroke risk definitely comes down. So on that, I'm actually quite interested to hear what you think about Professor Stephen Howland's technique of getting into the branches from the axillary artery and from the femoral, because he taught me to clamp the distal part of the carotids before instrumentation to prevent stroke. So whenever we do carotid stenting, we clamp the distal part before we put in the wire and put in the stent. But if we switch to this mode, then there is no way to control the distal, embolization unless you put in a filter. So maybe there's a switch in techniques. Maybe we are not using anticoagulants adequately. We also have some longer-term strokes, which is starting to come in. So you heard about branch occlusion. We have 2 branch occlusion which were late. One of them, because they stopped the antiplatelet agents without we knowing it. There was one bleeding, I think subsequently, maybe there was a small infarct in the brain, but the patient bled maybe like 2 months later. So I don't know how we can effectively prevent all these complications. But definitely, as you do more, I think the risk of stroke is coming down.
Do you have a ACT for your procedures? What's your ACT target?
ACT.
We keep it to about 200, 250. Right.
Okay. So may I direct one question to Professor Wurawong? So in your series you presented, in fact, you are doing the frozen elephant trunk with, for example, Medtronic stent graft, and now you have experience with the now composite graft like Froflex and Evita. How do you find the difference? Do you think it is beneficial, this kind of a newer stent graft, Professor Wurawong? Please unmute yourself first.
Yeah, I think for the commercial device, probably it can decrease the circulatory arrest time a little bit, and I think it's more simple for the distal anastomosis. However, for the acute dissection, I think the conventional stent with the distal anastomosis that we perform may be more secure than the commercial device, which we suture to the diseased aorta.
Yeah, but the length, for example, if you are doing the separate style, like the conventional using the Medtronic stent, what is the length of the stent that you use? Does it reach to like T6, T8 level?
No, actually, I still concerned about the risk of the paraplegic problems. So if usually we prefer the stent around 10 to 15%. But in case of if the anastomosis, we go down to the zone 3 or sometimes zone 4, we deploy the stent and we cut the proximal part of the stent, maybe 1 or 2 segments, to make sure that the living part of stent is around 10 or less than 15 centimeters.
And also for Dr. Osaki, in your series of left thoracotomy total arch, what is the percentage of spinal cord ischemia, and do you reimplant the intercostal artery?
About a spinal cord injury is about less than 3%. And so in my all cases, distal side is not so far. So intercostal artery reattach case is very few.
So it's not mandatory.
Mm-hmm.
Okay, thank you.
Okay, I have a question.
Yes.
Yeah, my question is about retrograde dissection. There are different techniques and different devices. Landing zone, and we need a landing to the zero area, ascending area. How about for treated aortic dissection? How about the retrograde dissection happened, and how to prevent that? I want to ask all have experience about that.
We only have experience to tackle it after it happened. So I think as long as we move to zone 0, zone 1, I think it's the chance always there. I think some series even reported over 10, 15% if you move to zone 1 or more proximally. So for cardiovascular surgeon like us, we can tackle when it happened. So maybe we can have some thought from the other panelists how to prevent it. So I assume Professor Lu's question is, if you decide to move to zone 0 or zone 1, how to prevent retrograde type A, right? So,
yeah.
Okay, we haven't had a retrograde type A for a long time, maybe for 7 years, until recently, when we had a misplaced fenestration in the arch, and then we had to use the balloon to move the fenestration backwards. And I think in that maneuver, we have torn the greater curve of the arch, leading to a retrograde. So for some reason, we haven't had one for a long time. I think in the past, we blamed the device, we blamed the proximal bear stance or attachment hooks. But since we select our patients more carefully, I think that has come down significantly. For the arch branch landing in zone 0, I don't think we had any. I think the reason is because the patient selection is, they do it very carefully. So for the Cook arch branch, they do not allow us to do it for disease ascending aorta, meaning the ascending has to be 38 millimeter or less. I think if you put it in the dilated ascending aorta, the risk it's going to be there. I know this is something that we don't like. I don't know whether you had any more experiences in that. I'm sure our two surgeons in China, we have much more experience in doing these things in the arch. What is your percentage of retrograde or comments on this?
Yes, as my experience. How about Liu, Professor Liu? Can you?
I totally agree. The slides mentioned in Dr. Lu's. It seems if the stem grass in landing zone in the zone 1 looks like a little bit higher. The retrograde dissection rate is than the landing to the zone 0. Maybe that's the arch. The have the arch in this is anatomy. Maybe use the stem graft. Have the bare metal structure in that zone 1 landing zone, maybe dangerous in the zone 0, and also the bird pitch in this stem graft. So occasionally, and in nowadays we pay more attention to the landing zone 1, and in the zone 0, it's have I think enough landing zones for the ascending aorta, so it's quite safe, a little bit safe than the zone 1 0. Zone 1. Thank you.
Victor, any comment?
Yeah, so we have seen other institutions, but so far we've been lucky. Like you say, we select cases carefully, and we try to avoid using bare stents. Yeah.
And I have a question.
Yeah, Professor Wong, yes.
I have a question to Professor Sheikh, please. For the case presentation, the gentleman that the type B dissection and did the total endovascular repair. He's 51 years old. And at the first thought, for me, I think this patient, if in my hospital, I will select to do the open surgery from the left thoracotomy. But I am quite question that the patient do the total endovascular repair. So what is the decision to select the patient, or how old the patient that you select to use endovascular repair or open surgery?
I think for all the patients, we give them the choice of open and endo. I think that was the youngest patient we had. Most of the patients would be in the 70s, and they all had consultations with our cardiac surgeons. Either they were rejected for open surgery, or the patient chose not to have open surgery. So, Jackie can, tell you that we would definitely insist on consulting the cardiac surgeons unless they are absolutely not fit. So that patient was rather unusual, that he refused open repair.
Actually, in Singapore, times have changed also because of the law in consent. We have to tell patients all the possible choices, even though we don't recommend. We have to talk about medical therapy, percutaneous as well as open, and we tell them everything, and they have to choose. Because we don't, there's a chance of lawsuit.
Thank you, all the panelists, and I think we have kept a very nice time control this morning. And thank you everyone for your nice discussion and presentation. Thank you.
Thank you.
So we should move to the next session.
Much.
Thank you.
Welcome back. So this is a tea break session sponsored by Medtronics, and we had the pleasure of inviting a distinguished speaker from Hong Kong, Dr. K.K. Wong, to address the very difficult issue of hostile necks in endovascular repair of abdominal aortic aneurysms. So Dr. Wong is a senior consultant at the Department of Surgery at Tuen Mun Hospital. He has received extensive overseas training at the Imperial College of London and also Massachusetts General Hospital, and he has taken up the Chief of Vascular Surgery and also honorary associate professorship in both universities of Hong Kong and the Chinese University of Hong Kong, and he's one of the most experienced vascular surgeons in treating aortic diseases using various devices. So today we welcome Dr. Wong to share with us his experience of using endo anchors in treating abdominal aortic aneurysms with hostile necks. So KK, thank you and welcome. Please begin.
Cases with hostile neck in the past 5 years. My philosophy principles. I believe most of you are familiar with the Atlanta system as it has been used in the field for 15 years. It got the FDA approval in 2011, and the biggest point is utilization and student requirement. In 2017, it also got the FDA approval. We used together with the Medtronic Ambulance 2S system to treat AAA with hostile length as short as 4 mm, provided the angulation is less than 60 degrees. I would like to share with you my first experience in using the endo anchor to treat my first case here. It was an unexpected AA case. Actually, Medtronic introduced the endo anchor to Hong Kong in 2016. I ordered the first system to another case, which should be done 1 week later. And my experience in using an energy machine in structure AA case has changed my practice afterward. This was young, the A&E department with abdominal pain, hostile mass, and no BP. Emergency team angiogram confirmed structure just below AA with a mark on the left side of the abdominal hematoma. Either artery and common artery was inside spasm. And either first is our department policy to structure case. This was the biopsy end. You can see that the neck was very soft, just about 3 mm length. In addition to the soft neck, the neck was also very wide. It was about 32 mm below the artery and soon become 36. And then another 45 minutes in the Medtronic one together with the endo anchor. This was the only angiogram after the application of the spinal aortic control. We switched down the aortic control balloon below the middle artery after the insertion of the body valve, and then proceed to have additional valve extension. Multiple angiogram showed that there was permanently as an additional possible up and 6 endo anchor. Then condition angiogram patient was recovered well. He suffered from transient renal impairment, but didn't need any renal replacement therapy. His renal function returned back to normal a few months later. He has multiple follow-up CT surveillance done and also good result without any pulmonary injury. His AA size was decreased from 66 millimeter to 46 millimeter. These were his follow-up CT angiogram, also very good result without pulmonary injury. AUV saw the attack can be by a very good signal force to where the distal migration of the flag valve. So far, we have performed more than 100 cases in the last 5 years. I try to review 126 cases with at least one follow-up CPA done and has been for more than 6 months. Mortality rate and the other two calculated all the cases except
頭先人標咗啊！
was mentioned. The first one by Shiva, and the second one by Amastan, and the last one by Amastan and Angus. Our result about the result and Anchor lower down is very similar to his study Anchor registry. The registry collect data for over 800 of cases. And it also showed that by the usage of the anchor, we can lower down the delay terminated to a very low rate, less than 1. Let's see the result of using anchor treating terminated by pharmaceutical group. So far, we haven't encountered any delay terminated it's not due to anchors very effective treating terminated, but just the opposite. In our early experience, we found that using anchor alone to treat terminated is not so promising. Nowadays, our needs is use multi-discipline approach. Very often, we use the anchor together with other instruments like pharmacy stand, oil, etc. As the treatment is so heterogeneous, it's difficult to make any analysis. But what we know is by adopting this multidisciplinary approach. So far, we haven't seen any delay and terminated in our treat patients. Linger registry also noticed the same problem. Although anchor can help some patients from terminated, but it's not perfect. After the application of anchor, about 80% of the patients will still suffer from persistent terminated and 1 year after procedures. My personal experience about failed terminated treatment by anchor is most of the time it involves extremely angulated land. Technically, it's quite difficult to apply the angle anchor in precise and proper position when the land is very angulated. This live case demonstration in a restaurant more than 3 years ago is a good example. We opt CD and table angle, so we would angulate and conical shape land. After the deployment of the river aircraft, we encountered difficulty in capture them, and finally we this funny maneuver to straighten up the angulated land in order to remove the cap. On table angle so the angulated land causing some instability on the aircraft and also Taiwan angling. So we have possible extension cuts and angle. The commission angiogram, so the Taiwan angling disappeared. However, during the first forms in the very suspicious Taiwan was detected. Complication and the early form CPA found that the angling was increasing in size. Finally, people patient they freely advocate for the use of CT angiogram, and which so beautifully there was a Taiwan entity. Because the AA has significantly increased in size, we often patient another operation by using condensed pharmacy stand and angle. This was the KUB after the operation. This is the form CT angiogram, so that there's no more Taiwan entity. Like most, we are finding ways to improve the result. Nowadays, when we encounter very challenging that we will try to add more angle either over the most suspicious size or in a circumferential manner. And sometimes we may apply the angle in double or even multiple modes. These are some examples. We may apply more angle over the suspicious site, and may also apply angle in double mode. Just to know the effect of angle in natural history of which voyage to find either an angle, especially about the AA set size and the possible land diameter. All along, we have 4 cases with continent set and large. We belong to the group I have mentioned, Taiwanese and the more successfully reached by secondary intervention. Another patient we can't demonstrate an entry in all 4 CA, but the central continent is inside significantly. I believe they need to support Taiwanese entity and discuss with the patient. He agreed to achieve but the operation recently and still waiting for the first floor CT and 23% of the patient has significant AA set pressure more than 5 mm, and 73% have the AA set size static. More findings has been published by others. Concerning the possible land dilatation, we found that those with angle anchor will need possible land dilatation that is 45 mm, which is significantly lower than those without angle anchor with mean dilatation at 1 mm. But whether this decrease in possible land dilatation at 1 year interval contribute to lower the future related entity in this further follow-up and study. Similarly, the decrease in the possible land dilatation after angle anchor is also observed by other authors. After using angle anchor for 5 years, I would also like to share with you my experience using it in rupture just like in the AA case. I find that it allows us to provide a much more simpler and faster way to achieve damage control for this life-saving condition. This is one example of rupture just like in the AA case with very autologous by the RGSS, but finally successfully treated by even angle anchor. The duration of the operation is just about 1.5 hours. I believe this will be much shorter than if we treat this case by an approach or by treating either. sometimes we may fail largely what you just studied by just using lever and to anchor. That is my policy divert using to Shiva. This is one case that we did a few years ago with for what you just studied Additional to the soft net, this also got another hostile net factor with regular focus over the posterior wall. So what you do is put in a lever sandbar, apply the angle, lateral wall, and then when we find that there is a almost permanently using Shiva by keeping the bovino artery from the exterior artery. And this is the final picture on table angiogram after disabling so good result. Low cover A and B scanning. Finally, we see what the exterior artery has expired. Then, through this anesthetic method, you can see that by the application of the stem bar and the anchor, one can stabilize the patient very soon. The result is just similar to apply a window control. But the advantage is that without glue, one can have more freedom to selectively cannulate the window artery for GP-stem. This was well after the operation. This was the day 5 result for CT angiogram, so that there's no Taiwanese angiogram, but just like from the IMA. This is another picture just with AA who we did the operation about 3 months ago. Found the system Taiwanese angiogram after the first and valve and anchor application. So we use it to Shiva. We're only able to stabilize the guidewire shift to the right window artery, but not for the window artery. Therefore, we will change our hand. Therefore, we change our hand to have the left window artery stop stand from the femoral artery below, and finally put in a sandwich stair by using a one. This case demonstrates well by using this technique, one has more freedom to selectively cannulate the window artery from different angles without the aortic causing obstruction. These are the results which the more challenging rupture just studied in our standards. So far, we have treated 17 cases. Half of them have their length shorter than 5 mm. And the overall mortality rate is 23.5%, of course, which is higher for those with length less than 5 mm. But among all of them, only one complicated by primary anatomy is solution by Shiva. Lastly, I would like to share with you my experience about broken angle. Don't forget, someone is advised when you use the angle out of IF. That is when you encounter focus on calcium up more than 2 millimeters, or when focus on calcium more than 50% of the vessel surface. You need to pay attention to this misfortune. The first broken angle happened when he tried to use the angle to treat the case with a inverted funnel shaken leg. He heard a very unusual kicking sound when we applied the angle over the bilateral wall of the inverted leg. And then we immediately take out the applier and found that there's a broken angle within the applier. When we reviewed the film and the CT, we found that actually there was a very heavy calcified part there causing the broken angle. This is the most recent broken angle case when we use it to treat a very angulated neck. This time we found the angle migrate away rather than stay inside the applier. So finally, we need to use the snare to capture the broken angle and then take it out and then the shape. These are the lessons that I have learned in the past 5 years after using the angle. Angle is easy to use, the learning curve is short, is safe, it is effective for using, especially when using to treat short neck in the infant neck or wide neck is less effective in treating hemorrhagic, especially those caused by acute angulation. In such case, better to consider to use it together with other measures like the pharmacy stand. And the using of anti-angle may be helpful to save life in rupture adjustment of AA cases. Thank you for your attention. Bye.
Thank you very much, KK, for sharing with us this experience, probably the largest in Hong Kong, of using endoankers. Are you still there?
Yeah. Can you hear me?
Would you be able to answer some questions?
Yeah.
Right. May I start by asking you, what is your criteria of using prophylactic endoankers? Do you do this for most EVAs, considering there is an advantage of preventing late neck dilatation, or you still only limit those to adverse anatomy?
Yeah, I only limit it to hostile net as suggested by the hospital authority. And most of the time I use the endo anchor is for short net. And most of them have at least 2 hostile factor, for example, short net plus an angulated net. I don't use the endo anchor for all patients, but only for selected case with hostile net factors.
Roughly, what is the percentage? Can you enlighten us on even on adverse, hostile necks? How many would you think is suitable?
Yeah, in my hospitals, I think it's a 50-50. About half of them will have the hostile neck factors. Yeah.
So any questions I'm getting? Do you? I understand the difficulties in using fenestrated grafts in some parts of the territory, and I understand that because of the issues of timing and also deposits, right? How do you feel about this? Is this a competing technology, or do you think this is better than the fenestration?
I personally have a very limited experience in performing fenestration, as you have mentioned. In my locality, I don't know. Whenever I mention to the patient they need to pay the deposit, they are so a lot of hesitancy. So most of the time, I will treat the patient by this technology. For very short net, I will try still to either with the endo anchor. If fail, I will just proceed to have a treatment. So because I am not too experienced in using the fenestrated, but just on the opposite, I'm doing quite a lot of treatment stand here. So my experience is most of the cases actually can be solved by treatment if the endo anchor fail.
Okay. Any other questions? Okay, so since we have overrun a little bit, and we have to draw this session to a close. Thank you very much, KK, again for joining us. I hope you stay behind.
Yeah, see you.
And the next session would be on complications and secondary interventions, which probably very appropriate. Thank you very much.
Good morning, and thank you very much, and welcome to this second session of the day. The topic is on secondary intervention and complications. It's my great honor to co-chair with Professor Andrew Chung, my very good friend in Singapore. And this session is on several talks, and then we have the discussion at the end. So without further ado, we would like to introduce our first speaker, and it is my honor to introduce Professor Yu Peng Leong, who is also our very good friend. He graduated from Monash University and then became associate professor at the National University of Malaysia in Kuala Lumpur. He is, as we all know, the founding president of the Vascular Society of Malaysia and a past president and counselor of the Asian Society of Vascular Surgery. He is a proctor for many international courses on endovascular and fenestrated devices. So may I invite Professor Leong to the podium, please.
Thank you. First of all, I'd like to thank the organizer for allowing me to participate in this meeting. It looks like we are going to have a very good program. Let's start off by saying endo leaks is a very common, it's a rather common complication that develops after EVA, and up to about 25% or more. Sometimes we see endo leaks of various types. Most endo leaks are attributed to the retrograde flow of a patent lumbar or the median sacral artery. Endo leaks can also, rather type 2 endo leaks can also arise from a retrograde flow of the patent IMA. And it has been reported and noted that in the presence of patent IMA in a type 2 endo leak, the endo leak tends to be more significant and there's a higher rate of reintervention. It has to be noted that up to 50 to 80% of type 2 endo leak resolve within 6 months after EVA. The persistent one are usually still considered benign, but they do require follow-up, and in certain cases, intervention is advised. If they're significant, that means there's a large endo leak and they're persistent, and most certainly intervention should be done if the aneurysm sac starts to enlarge. This is a case I have about 6 months ago. It's a very routine EVA, elective EVA. On the first month, post-EVA CTA shows significant and type 2 endo leak here. And this is the arterial phase, the venous phase here. And this is, when we look into the CT, we know that it's come from a patent IMA. This is also another interesting patient, which I did 2 months ago. Patient come with actually a ruptured AA, infrarenal AA. He was treated by EVA, and actually he did very well. He went home and see him in the clinic. But on the post-op CTA, again, we see a significant type 2 endo leak. And a CT reconstruction here, you can see that there's a large branch coming from the SMA, going all the way around to the IMA here. And this is the endo leak, which you can see on the CT picture. When the endo leak is significant and is attributed to the IMA, the various mode of treatment, as in the last case where there's a good branch coming from SMA, this can be treated by intra-arterial embolization, cannulating the SMA and using microcatheter and microwire technique. The wire and the catheter go all the way down to the origin of the the IMA. And in this case, some coils are put at the origin and into the aneurysmal sac. Alternatively, this may be treated by direct sac embolization through a transabdominal or translumbar route. A needle, a large bore needle is inserted into the aneurysm sac. This is usually done under ultrasound control to look at the position of the needle. and some contrast injected into it to make sure you're in the right place. And in this case, some glue is injected into the aneurysmal sac. This problem can also be treated surgically, laparoscopic ligation if the facilities are available, or through a mini laparotomy. Usually nowadays using ultrasound, we can usually locate the origin of the IMA, and through a small incision, we can ligate the IMA. Sometimes you can also, while you're there, inject some glue into the aneurysmal sac. To avoid this complication, various authors and various publications has recommended pre-procedure or pre-EVA embolization of all patent IMA. This can be done through direct cannulation of the IMA before putting in the stent and putting some coils at the origin of the IMA. There are also various reports that you can just deposit some coils around the region of the origin of the IMA, as you can see here, packing that portion of the aneurysmal sac before you, on completion of the EVA. This is a study which look at this procedure where all patent IMA are embolized pre-op. This is a retrospective, this is what paper published in the Annals of Vascular Surgery. In a retrospective study of 6 studies where the IMA, all patent IMA embolized before EVA, and they're comparing them with the group of patients where the patent IMA are not embolized. They look at 620 patients. 258 patients have embolization of the IMA. There's a very high success rate, nearly 100%, but there is actually one mortality. And this, by meta-analysis, it shows that pre-op embolization of the IMA do protect against type 2 endoleaks, and they do, this group of patients do have a lower rate of secondary intervention. Similar results is published here in a single center study. The results is very similar. Basically, again, they conclude that there is a benefit to embolize all patent IMA. However, there is critics on this routine. Routine means embolizing all patent IMA before EVA. The argument is that type 2 endoleaks are generally considered benign. As mentioned, more than 50% of them will resolve within 6 months. Less than 25% progress to sac expansion, and even a smaller percentage of this really progress to significant that require intervention. And on top of that, whichever procedure you use, there will be increased operating time, there will be increased radiation dose, of course there will be increased contrast use, increased cost. Even though the morbidity and mortality is very low, there is definitely a risk of gut ischemia, and as you can see in the paper earlier, there is mortality. And also quite significant is that the stainless steel or the platinum coils used create artifacts in the post-ops CTA, where interpretation and looking for endoleaks may be compromised. So how about selective inferior IA embolization? A group from Japan published a paper in Annals of Vascular Surgery, where they studied 196 patients that underwent standard EVA. They found that, or rather they reported that the patent IMA of more than 3 mm in diameter at the origin, or patent IMA with at least 1 lumbar artery which have a diameter of 2 mm at the origin, or a patent IMA in an aortoiliac aneurysm are all at high risk of a type 2 endoleaks. The same group went on to do a randomized controlled trial. This was published in the Annals of Surgery in 2020. They compared this group, basically they look at the group of patients with the high risk, which is the patent IMA of 3 mm, IMA, patent IMA with lumbar more than 2 mm, and patent IMA in aortoiliac aneurysm. 100 of this group of patients, 113 patients were randomized and as the embolized group, patient where they do embolization pre-op, and 106 patients under the control group. And it shows that, again, the result shows that incidence of type 2 endoleak was significantly lower in patients which is embolized. The sac shrink significantly more. And they reported no complication related to the IMA embolization. So they conclude that it's effective to embolize this group of patients they consider as a high risk patient, high risk for endoleak. So where do we stand today? I feel that routine embolization of all patent IMA before EVA is probably not necessary, and neither is it cost effective. Certainly further study need to look at this group of patients which is considered as higher risk of significant type 2 endoleak. Maybe we can actually selectively embolize those IMA pre-EVA to reduce type 2 endoleak resulting from this patent IMA. Thank you.
Thank you, Professor Leong, for an excellent talk. I'm sure there'll be lots and lots of questions, which we will reserve till the end. I have a few myself that I'd really appreciate your opinion on. But in the interest of time, let's just move forward to our next speaker. It's my great pleasure to introduce an old friend, Professor Chan Yu Chi. He graduated from the Charing Cross and Westminster Medical School in 1993 and was awarded a doctorate of medicine in 2004, looking into atherosclerosis. He has trained at my own alma mater, St. Mary's, as well as Guy's and Tommy's, before he returned to Hong Kong in 2007, where he's now based at Queen Mary Hospital. A highly published, very well-regarded academic vascular surgeon. Professor Chan, we'd love to hear your talk. Thank you.
Thank you.
Mr. Chairman, ladies and gentlemen, thank you very much to listen to this Aortic Asia 2021, a virtual symposium in Hong Kong. My name is Yu Chi Chan, and I'm talking on paraplegia and monitoring of spinal cord ischemia. Paraplegia, meaning half-stricken, has a varying degree of motor and sensory dysfunction of the legs, sensory loss over the torso, incontinence of urine and feces. From the vascular point of view, this is inevitably due to spinal cord ischemia, or very rarely due to aortic dissection. Patients have significant morbidity and high mortality. We have to understand the blood supply to the spinal cord. Cranially, it arises at one anterior and two posterior spinal arteries from the vertebral arteries. There are several radicular arteries contributing in the first sector extending to T3 from the subclavian artery, the second sector from T1 to T7, and the third sector from T9 to T12, mainly from the arteria radicularis magna. Branches from the internal iliac arteries also contribute. We all know about the artery of Adamkiewicz. This arises from the aorta via a left posterior intercostal artery at the level of T9 to T12 and is the only radiculomedullary artery that supplies the thoracolumbar area of the human spinal cord. There are many risk factors for paraplegia. Most importantly, the extent of aortic replacement or coverage, including previous or multiple aortic procedure, is of paramount importance. Other factors include hypotension and a long operating time, together with hemodynamic instability. Adjuncts to prevent paraplegia include generalized and localized hypothermia, several medications, in open surgery reattachment of intercostal arteries, and in endovascular procedure may be deliberate or intentional endoleak, together with perioperative insertion of a CSF drain. None of these, however, are universally effective in preventing paraplegia. In the University of Hong Kong, Queen Mary Hospital, what we do is if we do insert a CSF drain or the antiplatelet agent, except for aspirin, should be stopped for at least 1 week. The platelet count should be more than 100, the INR less than 1.3 with a normal APTT. Of course, the drain has to be set up in an aseptic technique and connected to ICP or EVD set. The CSF drain monitoring should aim at as high an arterial blood pressure as possible, more than 80 to 90, with a CSF pressure of less than 10. The drainage should be less than 10 mils per hour or less than 150 mils over 1 day, and it usually kept for 2 to 3 days. Let's look at a few cases that develop paraplegia postoperatively. This is a gentleman who had a ruptured descending thoracic aortic aneurysm. As you can see here, he was very unstable and had an emergency TIVA with the distal landing zone all the way to the celiac trunk. Another case where there is a type 3 thoracal abdominal aortic aneurysm with iliac extension and a custom-made composite branch endograft was used. Another case where there is a complex type B aortic dissection, a chronic with aneurysmal formation necessitating a hybrid procedure with ascending to innominate and left carotid bypass and a TIVA graft afterwards. We have some other examples of a patient who had acute dissection with malperfusion, and we did a cross carotid bypass and a TIVA, and again the distal landing zone was all the way to the celiac axis. Another case with bilateral carotid subclavian bypass to be followed by a Cook custom-made double branch device, and the coverage was from the ascending aorta to the distal descending aorta. Similar case with a chronic dissection with a elective repair using a Cook custom-made thoracic proximal fenestration for left subclavian artery and a scallop for the left carotid artery. And the coverage was from the left subclavian to the celiac axis. Over the years, from the year 2000 to 2021, at the University of Hong Kong, we have 13 patients who develop paraplegia. This first table showed the first 7 patients. You will notice that they all have very complex pathology, some with aneurysmal changes, some with dissection, and most of them have multiple aortic procedures over the years. Most are elective, and in each case, we tend to not sacrifice the left subclavian artery and the internal iliac artery. At least one was patent. But the universal fact is all of them have rather long coverage all the way down to the celiac axis in most cases. This table shows the remaining of our patients from patient number 8 to 13. Similarly, they have multiple operations for very complex pathology, mostly elective, but 3 emergency cases. The left subclavian artery was preserved in most of the cases, and internal iliac artery were preserved, and again with all long coverage. Out of these patients, you will notice that they may not have preoperative CSF drain in situ. In fact, in this table, only 1 had a preoperative prophylactic CSF drain, and maybe this is something we should improve on. If paraplegia develop, they develop mostly immediately after the operation. Only 2 on this table have delayed, but For those who have postoperative paraplegia, CSF drain was inserted, but the recovery rate was universally very poor, mostly but sometimes there was no recovery even with postoperative CSF drain. Most of them died either soon or later on, but have quite a high morbidity. Similar table in this shows patient number 8 to 13, and indeed, even if a post-op CSF drain was inserted, only a minority of these patients would have a recovery, and some died quite soon. Recently, we have the 4 most recent patients. They're still alive, but some of them are wheelchair bound, and some have to walk with individual aids. So the summary of our patients with paraplegia after complex aortic procedure is that in the 13 patients with paraplegia, 6 had complex dissection, 11 have multiple procedures. They all have long coverage, often involving the T8 to T12 segment and prolonged procedure, and only 2 of these had preoperative CSF drained. 4 patients had some recovery, but mostly no recovery, and we had 3 early mortality and 5 late mortality. So overall, our paraplegic rate in our institution is about 1.46% for all the patients who have had endovascular procedure. But because it is such a multifactorial cause, of course, this is not an accurate estimate. So something to consider for all of us is, when you're doing a TIVA next time, if the distal landing zone is here, quite some distance from the celiac axis, but there's still false lumen filling, should we consider extending it all the way down to the celiac axis and yet sacrifice these intercostal arteries and risk paraplegia? So in conclusion, paraplegia is a devastating complication. There are risk factors, but inevitably it involves a long recovery length and multiple aortic procedures. Prophylactic CSF drainage may be useful and should be considered in most cases. And even with CSF drainage, recovery rate is quite poor with significant morbidity and mortality. And with that, thank you very much for your attention.
Thank you. Now, I would like to introduce our next speaker is Professor Andrew Chung. He graduated from Imperial College London and then received his higher vascular surgical training at St. Mary's Hospital, together at the Royal Brisbane and Women's Hospital in Australia. He is now a consultant vascular and endovascular surgeon specializing in aortic work in National University Heart Center in Singapore. And he's also associate professor in the Department of Surgery in the National University of Singapore. So, Andrew, we look forward to hearing your talk now. Thank you.
Thank you, chair people, moderators, and the organizers of Aortic Asia for inviting me to give this talk today. My name's Andrew Chung, and I'm an associate professor of surgery at the National University of Singapore and a vascular, endovascular, and aortic surgeon at the National University Heart Center, Singapore. And today I'd like to talk to you about biochemical markers in the assessment of spinal cord ischemia for complex aortic repair. This is our current world that we're living in, but I'm grateful that we are still able to have such virtual symposiums. But I sincerely hope that in the near future we can all meet in person and maybe you can see the sights and sounds of Singapore one more time. These are my disclosures. And for those of you on social media, you will know that I'm relatively active, and these are my handles and my hashtags. Complex aortic repair as an entity is a spectrum, and it can be particularly invasive with significant physiological insult. And so you can have extent 2 thoracoabdominal aortic aneurysm repairs done under hypothermic circulatory arrest. You can have similar aneurysm repairs done under cardiopulmonary bypass or left heart bypass. For slightly smaller extent aneurysms like 4 and 5, you can do clamp and run. And with the advent of the endovascular revolution, there are also visceral hybrid repairs where you can perform retrograde visceral bypasses and completion endovascular stenting. And obviously, now we have branched and fenestrated total endovascular repairs where the arch is no longer off limits. However, one universal problem exists in complex aortic repair, and that is of spinal cord ischemia. Every single modality of complex aortic repair runs the risk of spinal cord ischemia. Whilst we have a number of adjuncts, it still remains the most devastating of complications with no cure. A very quick run through of the spinal cord blood supply. It is complicated. It is not just limited to the artery of Adamkiewicz and the paired lumbar and intercostal arteries. There are also subclavian artery supply contributions, as well as internal iliac territory supply contributions from both the lumbar and the sacral arteries. So, what do we know now, and what can we do? So the spinal cord blood supply, most of us will agree, should now be viewed as a network, and in the prevention of spinal cord ischemia, therefore, all contributing factors should be considered. There are multiple studies on the preoperative identification of the artery of Adamkiewicz and other large contributing spinal arteries, and appropriate intraoperative revascularization based on size and also backflow. There's good evidence that revascularizing the left subclavian helps, as well as ensuring patent internal iliac systems, which is all the more important in this endovascular era where many infrarenal aneurysms will have been repaired with EVAR with potentially concomitant internal iliac embolization. In terms of the technical procedural details, we should, wherever possible, avoid long lengths of endovascular coverage. There is consideration being given to perfusion branches in complex endovascular procedures, and also there is an argument to be said for staging complex hybrid or endovascular procedures to allow the spinal collateral network circulation to develop. In addition, there is this equation that we're all very familiar with regards to blood pressure and spinal drains, and the spinal cord perfusion pressure is equal to the mean arterial pressure minus the intraspinal pressure. And so in terms of perioperative management, maintaining a stable blood pressure throughout the procedure and avoiding swing highs and lows is very important. Avoiding hypotension generally is important, and we should also aim for a higher mean arterial pressure perioperatively. Spinal drain insertion, accepting the risk of epidural hematoma formation, does allow ISP monitoring and CSF drainage to decrease the intraspinal pressure and minimize obstruction to blood flow, and should be used judiciously. So, what role for biochemical markers in the assessment of spinal cord ischemia? We are still searching for an equivalent troponin of the brain or central nervous system, and currently no such molecule or assay exists. However, there are some promising biomarkers that may yet yield value in the future. This is some recently published work in the last 2 years based on work I did whilst I was at the St. Mary's Vascular Unit at Imperial College in London. And we looked very extensively into the use of biochemical markers in the assessment of spinal cord ischemia in thoracoabdominal aortic aneurysm repair. We used standard systematic review PRISMA guidelines, and of 1,000 studies, we included 14 in our qualitative synthesis, which included 321 patients being studied, looking at 6 biomarkers of interest with a subgroup analysis on S100 proteins. For those of you that don't know, S100 are a family of proteins that are derived from the neural crest, Schwann cells, melanocytes, and glial cells. S100B or S100 beta is glial specific and expressed primarily by astrocytes, and this protein may function neurite extension, proliferation of melanoma, mediated phosphorylation, astrocytosis, but probably more importantly, axonal proliferation. Glial fibrillary acidic protein is an intermediate filament protein that is found in glial cells such as astrocytes. First described in 1971, it is a type 3 IF protein that maps in humans to 17q21. This is an example of our studies that we included in our analysis, and you can see there are a number of different biochemical markers that were used. Lactate S100B, neuron-specific enolase, glial fibrillary protein, the tau protein, and the neurofilament protein. And they used a combination of samples of peripheral blood and serum, and more importantly, perhaps, cerebrospinal fluid. Of note, there was no protocol adhered to in terms of sample timing, but generally it was preoperatively, before a cross-clamp, around cross-clamp timing, and after cross-clamping time. Significantly, only a few studies looked at endovascular stent grafting, whereas the majority of them looked at open thoracoabdominal aortic aneurysm repair. This is an example of the types of patients that were encountered, and you can see that overall the paraplegia rate is actually reassuringly low and consistent with the literature. What you can see, however, is that S100 beta was probably the most studied and tended to show rises and tended and trended towards significance in those that had central nervous system injury. So bearing this in mind, we looked at this a little bit further, and we did a subgroup analysis of S100 beta in CSF in relation to those that had developed spinal cord ischemia. And you can see that there are significant peak rise in S100 beta in CSF in almost all cases, although the timing of the rise and the significance of the rise and how we can apply that clinically still requires further attention. In summary, we are dealing with small sample sizes, and peripheral blood work should be discounted because there was a significant confounder found by Van Dongen which demonstrated that actually when you use a bypass machine, S100 beta is found in the circulating blood of the bypass circuit. There are trends towards significance, and CSF samples show greater rises in markers in paraplegics. S100 beta and glial fibrillary acidic protein appear to show the most dramatic rises, although in all the studies there was a great variation in time points of sampling and rises. Further study is obviously needed. Importantly, we are still searching for a troponin of the spinal cord. But even if we find one, we need better ways to address spinal cord ischemia, diagnosis, prevention, and cure. A multimodal approach is clearly necessary, and spinal cord still remains the Achilles heel of complex aortic repair. Thank you very much for your time and attention.
Thank you, Andrew, for that wonderful talk. I'm sure there will be some answers at the end. The next speaker in this session is Dr. Vince Lau. Dr. Vince Lau is our colleague here at Queen Mary Hospital, and often we collaborate in dealing with complex cases, especially in re-intervention. He is the assistant professor in the diagnostic radiology of the University of Hong Kong and a consultant radiologist in Queen Mary Hospital. So Vince, may we listen to your talk? Thank you.
Thank you, Dr. Chen, for the kind introduction, and thank you, Aortic Asia, for the invitation. It's truly an honor to give a talk. My topic is on endoleak management as an interventional radiologist. So this classification needs no further explanation. What I will talk about today is mainly the type 2 endoleak, which is the most common indications for reintervention after EVA. It has a high prevalence, quoting about 10 to 30%. And bear in mind that up to 50% of the type 2 endoleak spontaneously resolved. So actually the correlation between the persistent type 2 endoleak and the rupture risk remains controversial. So what is more important is the presence of sac enlargement for intervention. And according to different papers, you can quote 5 to 10 mm sac growth as an indicator for interventions. So before we talk about the treatment, I would just like to introduce the concept of AVM concept. So for AVM, you have an inflow and you have an outflow. And with that, in between, you have a nidus. And when I treat an AVM, the important thing is to treat the nidus, but not the inflow or the outflow. If you just coil the inflow, there will be more arteries reconstituting the nidus with time and making the next intervention even more difficult. And that has a lot of similarity when I treat type 2 endoleak. So I would take the endosac as the nidus, and I would take the feeding arteries, some as the inflow, some as the outflow. So if I only treat one of the inflow, it's bound to fail. But if I treat the nidus, then I can have a better success rate in treating the endoleak. So let's look at this case as an example. This case has an endoleak that is apparent from the SMA and IMA arcade. So this case was performed about 10 years ago, I'll say, and the operator found the SMA IMA arcade, and he found the IMA supplying the endosac. So there was some coil that was placed inside the IMA, so-called the inflow of the sac. And unfortunately, the endoleak persists, and with time the sac grows. So we have to go in again, this time through the iliolumbar arteries, which is more difficult, more attenuated, and harder to cannulate. And took a bit of quite an effort for us to do the re-interventions through these very tortuous attenuated arteries, but we have successfully cannulated it and inject some glue into the endosac. After the embolization, the sac size seems to be at rest. So the choice of the embolic agents, you can put coils, you can put glue, thrombin, EVOH such as onyx or particles, and there's no actually clear advantage of one over another, although there is some paper that support using coil alone will require re-interventions. So I think more important is to treat the endosac, but the choice of the agent might not be as important. Next, I'm going to talk about different accesses that we use to treat type 2 endoleak. Starting with transarterial, which is the conventional method that we treat the endoleak. There are two pathways, usually. The first is the SMA through the arc of Rheolin into the IMA into the sac. It is usually more apparent on CT and on angiogram. It's usually arise from the early branch of the SMA, and then you go for a very tortuous, but still a patent course. And you can see it's quite tortuous, and into the IMA. And before IMA, you can see the superior rectal artery, which you would like to avoid, not to embolize, not to put glue inside. And then you reach the endosac and treat it. As in this case, you inject contrast, you see the IMA supplying the endosac. And I put some coil in there, and the parent branch are preserved with occlusion of the endoleak. The other pathway is through the internal iliac artery, through the iliolumbar artery, and the reaching the sac. So the iliolumbar artery arises from the early branch of the internal iliac artery. So So another example in this case is the endo leak that arises from the internal iliac artery, and then you can see the iliolumbar branch, which is again very tortuous. And with some cannulation, we have succeeded in reaching the endosac. So that brings us to the second method, which is the direct sac puncture. It is proposed as an alternative to endovascular treatment since about 20 years ago. The challenge is to correctly place the needle into the endosac. And with nowadays, we can use ultrasound or cone beam CT to have a better accuracy in tackling the endosac. Let's take this case as an example. This is a case of type 2 endo leak. And then we see that the leak is at the posterior aspect. So when I plan the needle, I plan it at the posterolateral approach through the psoas muscle. Put the patient prone. And I use the fluoroscopic with cone beam guidance combined access to try to cannulate the endosac. And after that, I inject some contrast. I confirm there's backflow of arterial blood, inject some contrast. And I confirm there's an endosac opacifications. And afterwards, I inject some glue, which is a diluted glue of around 20%. And this is the pre and the post angiogram, CT angiogram. You can see that the sac and the glue distribution is almost identical, meaning that the glue has successfully infiltrated the endosac completely. So there are different papers that compare transarterial access with direct sac puncture. The conclusion is that in this paper is that direct sac embolization has a higher success rate with a lower risk of complications. Another paper shows there's no significant difference between the two treatment methods with respect to repair success. Another paper shows that the direct sac puncture is a preferred approach given its shorter fluoroscopic pre-procedural time. So is direct sac puncture the treatment of choice? In the past, there are many studies that use direct sac puncture as the second-line treatment. Difficulty comes with the feasibility of access. But nowadays, we have cone beam CT. I think this is already solved. One thing to bear in mind is that the direct sac puncture cannot identify type 1 or type 3 endo leak, which could be occult on angiogram without angiogram. So, and in that case, it would result in ineffective or delayed diagnosis. And it has also complications such as a secondary type 3 endo leak, puncturing the muscle or the artery or the organs along the path, non-target embolization, and retroperitoneal hematoma. Okay, next I will talk about the transgluteal access. This is not a common access that we use, more of a barrel access. As in this case, where the endo leak is at the anterior aspect of the stent, so we cannot find a role for direct sac puncture, and the arteries cannot be traced, so we cannot exactly cannulate the arteries. And the IIA, internal iliac artery, is coiled in this case. So we put the patient in a prone position. We find put an ultrasound in the buttock area, and what we look for is the superior gluteal artery, which arises from the posterior division, as we all know, of the internal iliac artery. And then we put in an access catheter through the buttock into the superior gluteal artery, as in here, and we go retrograde back into the internal iliac artery, and then we find the iliolumbar branch. So we put a catheter into superior gluteal, and then we find the internal iliolumbar branch, and we do it the same manner as the transarterial access. And then we find the endosac, we inject some onyx into the sac with some obliteration of the sac. Okay, last but not least, I would like to complete the methods of access with a transcaval access. We haven't done it in our center, but this is one of the access that has been quoted in the literature with a catheter, such as a puncture needle catheter, that you go from the transcaval through into the endosac. And then after you puncture, you put in coils or glue, as in other methods. So in conclusion, for type 2 endo leak, I think treating the endosac is more important than choosing what embolic agent. If you only treat the inflow or the outflow, sometimes it will recur. For the SMA to the IMA arcade, I would generally prefer transarterial access over direct septal puncture. And for the ilolumbar artery, usually very attenuated. So from my experience, I think direct septal puncture has a much higher technical success and a much lower procedural time, and I would prefer that over transarterial access. And I've also mentioned transgluteal technique as a bailout procedure. With that, thank you for your attention. Thank you.
Thank you, Dr. Lau, for a wonderful overview of endoleak management. I'm sure that will generate a number of questions at the end. It is my distinct honor and pleasure to introduce our next speaker, Professor Peter Robles. He requires no introduction. Aortic Asia, he is one of the original founders, as well as being the founding head of the department that I now currently work in at NUH. He is an ex-president of the Asian Society for Vascular Surgery, and also the founding president of the Singapore Society for Vascular and Endovascular Surgery. So without further ado, I would like Peter to talk to CT angio suites for endoleak characterization and management. Thank you, Peter.
Thank you very much, Andrew, for a very kind introduction. Thank you to the organizers for an excellent virtual meeting and program. It'll be great to see you all again in real life, so to speak, and we look forward to those days. My talk today is a very nice segue from the previous excellent talk on endoleak management. I'm just going to share with you our experience of using a combined CT angio suite for the endoleak characterization and management in our patients. So we've all seen this slide. I don't need to dwell too much on it, just to say that these leaks can come from quite a lot of places. And it's important to characterize them first because that dictates the kind of treatment that you're going to undertake. This becomes even more complicated now when we have complex endografts involving fenestrations and branches and more places that leaks can spring from. So again, the imaging is so much more important to try and figure out what to do, when to do it, and whom to do it on. So how common a problem is it? This is quite recent data from the ENGAGE registry looking at a series of 1,200 patients undergoing EVA, and they published that about 15% of their patients developed type 2 endoleaks through a 5-year period. And of these, 11% went on to develop a late type 1 endoleak, of which 2/3 required some form of intervention. I'd say in experience, this probably is a conservative estimate, and other papers have shown a much higher rate of endoleak incidence and also reintervention. Is it worth treating these endoleaks? This recent publication suggests that those with type 2 intervention and sac enlargement have a better survival rate if the endoleak was treated. We've heard from the previous speaker on the different types of treatments available, and I'm not going to dwell on that just now. The remit of my talk is to just introduce a new toy we've got in our sister hospital, and this is an angio CT suite where you have a CT parked in one side on a self-propelled gantry and a ceiling-mounted C-arm in the corner. So in this room, you can perform helical CT scanning without moving the patient while you have a catheter in the patient, in the aneurysm, and you can both do DSA and a CT with different timings to try and work out where the endoleak's coming from. So the benefit of not having to move the patient and having real-time imaging really helps you to characterize the endoleak. Just also to look at the floor of this room, the rails are all level so that you can move the patient in, you can have an ultrasound come in for ultrasound guided puncturing and so on, and it's quite smooth. Just a little bit more about the room. So it's broken up into 3 elements. First is your CT and C-arm setup so that you can switch between the angio and CT real time during the procedure without too much fuss. If you need to justify the cost of this room, you can park the CT at the corner and then use it as a standard angio suite, and vice versa. You can park the C-arm away on the side and then use it as a standard CT room. The second element is your fixed table. It's not quite a floating table, but it's got a long tabletop so that you can move the patient into the CT scan and then back to your angio setup while keeping the patient position fixed. The last element, which I think is the most important, is you have a large multi-screen monitor where you can have all your images live, your CT scans, different reconstructions, and all your angio imaging, including your live imaging, obviously, all in one big screen. What is not shown is the large control room at the back where a lot of the imaging is done and the planning is prepared for your intervention. Another quick tip is this: when you start the case, to put all the tubing and lines within the donut, because if you don't, it's a non-starter. You can't move the CT in so easily. So that's a quick tip for your anesthetist. So I'm going to show you how we use this room just with two cases. So this is a man who's had an EVA and IBD done in 2019. His sac continued to grow, and his CT scan showed a type 2 endoleak, which we weren't sure whether it was from a lumbar or persistent IMA. So we brought him to this suite. A catheter CT angio was done in 4 phases: a pre-contrast, arterial, venous, and a delayed scan. And we thought this was coming from a lumbar source rather than the IMA. So through a left internal iliac access, as demonstrated by the previous speaker. Now this requires quite a bit of interventional radiology, kung fu if you like, various microcatheters and so on to get into that left lumbar. And finally, when we get in the left lumbar and then identify the connection with the sac, we injected a liquid embolic solution of onyx into the sac, and then as you come out into the origin of the lumbar artery. So you do sac first and then embolize the origin of the lumbar artery last. Finally, we then went to look at the SMA through a retrograde approach to the IMA, and we found no retrograde flow into the sac, so we did not coil the IMA origin. Okay, so here you see in a different view, the onyx in the sac, and then coming out into the lumbar origin. So all this is done in one sitting. You get a CT scan with the catheter already in the EVA. You do your intervention, and then you do a post-intervention CT just to demonstrate you've not missed any other leaks. Okay, so this is what it looks like. You get a screen with multiple views of the CT scan, your intervention, and so on. And while you're planning all this, your onyx is cooking. You've got all sorts of other kit in the room, coils, glue. We set up a direct sac puncture if we need to, and so on. So a lot of options on the table. Moving on to the second case, this is another man with an EVA and left-sided IBD in 2017. He had the usual type 2 endoleaks embolized in 2019. The sac stayed stable for a bit and then started to grow again. And on his CT scan, we were wondering whether this was a type 3 endoleak or whether it was a persistent type 2. And so we brought him to the CT angio suite. And this is really the key, where you have a CT scan done in different phases. So we look at the timing of the contrast, not so much the images itself, but we could see the contrast coming out of the graft very early on with the catheter parked inside the graft. You can park the catheter obviously in the graft, above the endograft, and just to demonstrate whether you got type 1, type 2, type 3, and so on, and then have different phases of scanning. So we thought this was going to be a type 3 endoleak, and we put in a Cook aortic cuff, a 30 by 58, just above the bifurcation of the device. And we were able to show in the same sitting that the early contrast leak from the graft was abolished after putting in the cuff. We did a lot of imaging later to look for persistent type 2, but we couldn't see anything. And so we were quite happy that this endoleak has been addressed for now. So that's it, a short talk just to show our hybrid angio CT suite to deal with complex endoleaks. And thank you very much for your attention. Look forward to seeing you in Singapore next year, I hope. Thank you.
Thank you, Peter, for the wonderful talk. Our next speaker in this session is Professor Thihi Chanmeka. He graduated from the University Thailand Demonstration School, Kukhon, in 1998, and subsequently became a Thai Board of Thoracic Surgery Faculty of Medicine in the same university in 2013. Currently, he works as an assistant professor at the Division of Cardiovascular and Thoracic Surgery in the Department of Surgery, Faculty of Medicine in Kokkun University, Thailand. He's going to tell us about the management of retrograde type A aortic dissection after TIVA. So may I invite Professor Chanmeka to the podium, please.
Thank you, Mr. Chairman. Good morning, Mr. Chairman, and our distinguished guests. This is my honor to be here to present the topic of the management of retrograde type A aortic dissection after the TIVA. I have no conflict of interest for this presentation. And this presentation is courtesy to Assistant Professor Shaurit Wongputta, my boss. Retrograde type A aortic dissection, or we call ARTAD, is an uncommon but very devastating iatrogenic complication of the TIVA. The incidence of this ARTAD is about 2.5%, and ARTAD also most of the case found in the dissection more than in the aneurysm. In the aortic dissection, we found that the most of cases about the acute type B aortic dissection and 3% for the chronic dissection. Mortality rate is very high. It's about 37%. And we found that the sudden death is about 19%. 15% occur during the procedure and significantly higher in mortality rate. We found that the timing for the ARTAD intraoperatively is about 20%, and a half is about within the 30-day postoperative. And after the 30-day, we found that about 30%. That this figure is found that the stent induced the intimal tear in the ascending aorta. And we found the intimal flap here at the aortic arch. And also here. Risk of ARTAD, we found that the proximal bare stent, proximal stent graft configuration is also played a role in the ARTAD, but we found that no significant difference for the bare stent and non-bare stent. And the stent graft diameter is more than 42 millimeter is also induced the ARTAD also. And the zoning for the proximal landing zone, we found the most cases in the zone 0 is about 8%. And the zone 1 is 2.5, and the zone 2 is 2.6%. And not so often in the zone 3 and zone 4. And the stent graft oversizing, we found the study showed that if the oversizing more than 14% is more risk for the ARTAD. And also the spring back force. We know that in the free state stent, the stent also make the conform of this in free state. And after the stent it become curved, and more curve, more higher state may be to the aortic wall. And this for the more force to the aortic wall is more incident of ARTAD. And also the Winkessel effect that it become from the dynamic movement of the ascending aorta that aggravate the interaction with the lightest stent edge to the aortic wall and aortic intima to injury around here for the Winkessel effect. And the patient with the loss of the sinotubular junction is also increase the incidence of ARTAD. And the aortic arc malformation, like especially in right side aortic arc or aberrant subclavian artery, also increase the risk too. And the severe angulation. If the angulation is more become severe or become more than 130 degree, the spring back and the Wind-Kissel effect may become more trouble for the stent to induce the intimal injury. And also the wire and catheter manipulation. If we do the manipulation without the cautiously, with the wire and the catheter can do injury to the intimal. Balloon dilatation of the proximal stent and the end of endograft also the factor. Fragile aorta. And the next factor is become more controversy is the timing for the intervention of TIVA after dissection, where we do the on acute or chronic, or we leave, or we wait, or we do in the emergency situation. Maybe many factors around here. And also the connective tissue disease such as the Marfan syndrome and also the ascending aortic pathology. More experienced center may become to have lower RTAT incidences. From this paper from Professor Cheng, that we found that the factor that affect the RTAT is the hypertension and ASA class, and also the history of vascular surgery. How should retrograde type A aortic dissection after TIVA be managed? Emergency surgical repair is mandatory unless the patient has a prohibited surgical list. So I have the case for this the case of 46 years old male. He come to the hospital with acute chest pain, and he had the hemothorax and the acute limb ischemia at left leg. The diagnosis is complicated type B aortic dissection. We plan for the operation is to do the TIVA with the left common iliac artery angioplasty with the peripheral stent with femoral bypass. 3 days after TIVA, we have the protocol for the follow-up the CT. The patient has no symptom. The patient become fine, but the CTA show that the intimal flap in the ascending aorta here, and we see the flap extend from the proximal base stent down to the aortic root. That we see the RTAT occur in this patient. So we plan to diagnose retrograde type A aortic dissection after TIVA. Our plan is to do the total arc replacement with the forceps elephant trunk technique. Operative technique, we do the axillary cannulation and two-stage venous cannulation and right superior pulmonary vent. And the cardioplegia, we use the direct HTK cardioplegia. And we perform the moderate hypothermic circulatory arrest with the selective anti-gate cerebral perfusion. This video shows the gross pathology of the ascending aorta. You see that the aortic root become larger and the bluish color at the aortic root. And aortic root pathology, after we cross-clamp the aorta and we open the aortic root and found that in a hematoma at the fall lumen down to the lychoric cyanotoxua and non-cus. We remove the hematoma first and inspect all around the aortic root. You can see that the RTAT is really frightening incident after the TIVA, and we can see the we can see the fall lumen down to the aortic root at the non-corecus and lycoricus. We do the proximal cup preparation by the sandwich technique and do the neo media by the groove, inject the groove to the media, to the fall lumen to occupy the fall lumen, and we do the double sandwich technique at the proximal. And for the distal, after the temperature reach the moderate, we do the circulatory arrest and open the distal, the aortic arch to examine the proximal stent. You found that the bare stent here, the bare stent export here, and we inspect the primary intimal tear just below the, just after the brachiocephalic trunk. This is the bare stent here, and the cover stent. And after that, we found the primary intimal tear here, down here at the just distal to the brachiocephalic trunk. We found that the tip of the bare stent injury to the intima, and make the dissection here, around here. You can see this. You can see the primary intimal tear here. Sorry, the primary intimal tear here, around here. After that, we do the bare stent removal by using the knife, 11 knife, to remove the bare stent by cut the suture that fix the bare stent to the cover stent. This we use. Some professor use the wire cutter to cut the bare stent directly, but we consider to use the 11 blade cut the suture material that allow the bare stent to fix the bare stent at the cover stent here. But beware of the make the stent to be perforated by the knife and the injury of the blade to the aorta. And that's we can remove the bare stent here, not here. And we do the distal cup preparation by using the double sandwich technique too, and use the groove to be the neo media allowed here. And we use the 4-band graft, and we sew the 4-band graft distally as traditional technique. We also reimplant, we also make the conduit from the saphenous vein graft. We make the conduit from the ascending aorta to the left vertebral artery also, because the left vertebral artery arising from the aortic arch. The operative and postoperative characteristic from the paper from Professor Yao Jun Dun, we found that most of the case, they do the total arc with Fossen and tongue technique. And the cardiopulmonary bypass is also 170 minutes. Aortic Hotcan time is about 100 minutes. And intensive care duration stay is about 5 days, and postoperative of the hospital stay is about 11 to 12 days. The incidence of the death is about 30%, 13%, and stroke rate is about 5%. It's the same as our patient here. The conclusion: the total arc replacement with or without Fossen elevation technique was suitable. The treatment of the retrograde aortic type A dissection after TIVA from our experience. Thank you for your attention, and thank you for your precious time here.
Thank you, Professor Chanmakatiti, for an excellent presentation. Retrograde type A dissections, as we all know, are a terrifying complication. So in the interest of time, we're going to move on and we'll save questions to the end. I'd like to introduce our next speaker, Professor Kamin Chinsakchai, who's an associate professor in the Department of Vascular Surgery at Suraj Hospital in Mahidol University, Thailand. He's trained in Utrecht in the Netherlands, as well as Guy's and St. Thomas's and King's College Hospital. And he's got specialist interests in both the open and endovascular treatment of abdominal aortic aneurysms, as well as peripheral vascular disease and hemodialysis. And he's going to talk to us about the pre and post-operative factors to determine adverse outcomes after EVAR for infected abdominal aortic aneurysms.
Good morning, ladies and gentlemen. First of all, I would like to thank you, Professor Stephen Cheng and committees, to invite me to share experience about infected abdominal aortic aneurysm. In this morning, I'm going to talk about the pre- and post-operative factors to determine adverse outcomes after EVAR of infected abdominal aortic aneurysm. As you know, that infected AAA is not uncommon in Asian population. From the literature review, it accounts for 13.3% of the total AAA. In our experience, we found that the infected abdominal aortic aneurysm or AAA account for 12.6%. Open repair for infected AAA has been the gold standard treatment for several decades. Endovascular aortic aneurysm repair or EVAR has been controversial in treatment of this condition. The diagnosis of this condition we follow by the JVS 2011. That means 2 or more of the following features: sepsis, positive blood culture, positive culture of aneurysm wall or thrombus, CT radiological appearance such as a circular eccentric configuration of a AAA multi-lobulated aneurysm, and also the soft tissue inflammation or mass around the aorta, as you can see in these slides. Endovascular repair for infected abdominal aortic aneurysm has the benefit that means the less invasive, suitable for unfit patients. However, the drawbacks are stent graft in an infected field, recurrent sepsis or infected AAA, stent graft infection. As you can see, this one shows the adverse outcome of the stent graft EVAR in the infected abdominal aortic aneurysm. After treatment, they develop aortic entry fistula. And in this case, they develop recurrent infected aortic aneurysm at the distal part of the stent graft. From the literature review in Circulation 2016, they enrolled patients infected abdominal aortic aneurysm, 62 patients treated with open repair and 70 patients treated with endovascular repair. They excluded the graft infection, aortoenteric or graft enteric fistula, inflammatory aneurysm, and previous aortic surgery. The antibiotic duration around 12 weeks. There is no significance between the two groups, and the survival at the 3 months was lower in the open repair than endovascular repair, and similar 10% at the 1 year after treatment. The result of a median follow-up, they found that no difference in the long-term survival at 5 years, and infected-related complication and reoperation between the two groups. And they concluded that EVAR was associated with the improved short-term survival at the 3 months in comparison with the open repair, without higher associated incidence of serious infection-related complication or reoperation. This one is published in 2017, EVAR for microtic aortic aneurysm. They enrolled 40 patients, rupture 25%, most common organism are Salmonella infection. And they found that at the median follow-up 25 months, cumulative 1 and 5 year survival rate around 21 and 53%. Persistent or recurrent infection occur 20%, and most of them die within 6 months without any treatment. And they conclude that EVAR is an acceptable alternative treatment of microtic aortic aneurysm. However, persistent infection is often fatal without surgical treatment. If you look at our experience at the Silat Hospital, we perform more than 1,000 cases during the last 10 years. We start the infected aortic aneurysm between 2010 and 2017 to present which pre- and post-operative factors affecting the adverse outcome of persistent infection after EVAR for infected abdominal aortic aneurysm. And the favorable outcome is patient who could continue antibiotic after EVA. Criteria for stop antibiotic are no abdominal back pain or fever, normal white blood cell count, ESR or CRP, complete ligation of triple A or no fat standing, and insect pericarp correction by CT angiography. This one is a show favorable outcome. You can see that after EVA treatment in mycotic abdominal aortic aneurysm, we can stop antibiotic at 39 months after treatment. Criteria for persistent infection, that means the patient continue antibiotic and aortic graft-related re-intervention such as stent graft infection, aortic entry fistula, recurrence of a new infected abdominal aortic aneurysm. This case shows the persistent infection. You can see that after 1 month, the patient developed aortic entry fistula. We have to perform stent graft explantation, axial bifemoral bypass graft. And this one as well shows the recurrent infected aortic aneurysm at the distal part of aortic stent graft. And this case shows the aortic entry fistula and stent graft infection. We perform open enterography and omentum flap coverage, as you can see in this slide. The technique for this one, we open laparotomy and separate duodenum from the aneurysm sac. You can see the middle picture that the stent graft in abdomen. The patient develop a rupture. The median age 72 years. The most common demographic data show that hypertension and diabetes are common in this condition. The morphology of aneurysm, most of them, 92.2% is a sacral aneurysm. The location, 67.2% located in the abdominal part, and a rupture, 25%, aortic entry fistula, 10.9%. Most common organism is a Salmonella, 34%. Postoperative complication, renal failure, need hemodialysis, 7.8%, and pneumonia 15.6%. Perioperative mortality 4.7%. In hospital mortality 6 cases account for 9.4%. And if we study the predictor for persistent infection, 58% exclude in hospital mortality 6 cases. And we found that 24 cases we can stop antibiotic after discharge, and persistent infection 34 cases. The median time for stop antibiotic is 15.9 months. No recurrent infection or the reintervention in this cases. And persistent infection, we have to continue antibiotic 21 cases and reintervention 13 cases. In 13 cases, that means aortic entry fistula. 8 cases, we perform open enterography, as I mentioned before, 7 cases. Recurrent infection, triple A 2 cases, and endograft infection 2 cases, and graft limb occlusion 1 cases. Estimate time, median time for follow-up is almost 40 months. And we found that the overall at 5 years between group of stop antibiotic and persistent infection, it shows statistical significance at the survival. That means the patient who can stop antibiotic is 68% compared with persistent group 32.9%. And factor related to the persistent infection, preoperative is albumin less than 3 mg per deciliter, and the postoperative is CRP more than 5 mg per liter, as you can see in this slide. And also CT scan show fat standing and insect pericarp correction is show the persistent infection. So I would like to conclude that EVA might be the feasible treatment for triple A that infected with the rate of without reintervention almost 80%. In the persistent group, might develop adverse outcomes such as graft infection, enteroenterofissular recurrent new infection. Preoperative albumin less than 3 mg per deciliter, postoperative CRP more than 5 mg per deciliter, postoperative CTA show fast standing, air insect polygraph correction might be the factor to determine adverse outcome. Therefore, surveillance with a CRP and CTA is very crucial for persistent group who diagnosed with infected type A treated with endovascular procedure. Thank you for your attention.
Thank you very much, Professor Carmine, for that wonderful talk. The last speaker in this session is Dr. Kunokom Prampraka. He learned vascular procedures in various renowned centers around the world, first from Dr. Prumprasit Karacha in Songkla Garinda Hospital, and also he gained the Asia Pacific Endovascular Fellowship to Epsworth Hospital in Melbourne in Australia, and also he learned endovascular procedure in UCSF with Professor Tim Shooter. So we would like to listen to his talk now on fever reintervention. Thank you.
I would like to thank Aortic Asia Committee to this opportunity to share our experience about reintervention in Finested and Blanche EVA. In Songkla Hospital, we started using Finested and Blanche to treat our patients since 2015. Until now, there were 48 patients with 162 branches, which included one left common carotid and one left subclavian fenestration. We all know that the purpose of the aortic stent graft is to prevent aneurysmal rupture. So, after implant it into our patients, it is important to have a good and regular surveillance. In our experience, only one patient in this cohort had disease progression and needed to have a proximal extension to maintain a good seal. This 70-year-old gentleman had CMD EVA for his T-AAA since 2016. 4 years after that, the descending aorta became aneurysmal dilatation caused type 1A endoleak. We brought him back and did the proximal extension to the good and normal aorta, which was the zone 1. There were no significant aortic stent migration in this group, but many of them felt a problem about the branch. So we think that this is the important factor to determine the long-term outcome of the branch and fenested endograft. In 2013, Cleveland Clinic report their 10 years data of secondary intervention. And as we all know, the renal branch needs more reintervention compared to SMA and celiac. The rate of reintervention in our patients were not different in each vessel. We have celiac reintervention higher than other report. Surprisingly, we had renal branch reintervention less than we thought. This might be because our cohort were not yet followed long enough, or maybe it's about the type of bridging stent that we used. The common cause of reintervention of the celiac branch in our patients were stent dislodged from the target vessel. This might be from the bridging stent was too short to have adequate seal into the target vessel. Most of the time, the reintervention was not difficult, just cannulate through the bridging stent into the target vessel, and then extend the stent deep into the vessel. The key to gain a good distal seal is clearly see the celiac origin and the branch. The AP view with CC angle can lengthen the celiac length, so we can clearly see the celiac orifice and its bands and actual length of it. This is now our preferred view when we deploy the celiac stent. The next problem about the branches are endoleak from the bridging stent. This can happen due to stent material fatigue by itself or poor alignment of the bridging stent. This man had CMD EVA repaired for his 9 cm 3 AAA in 2016. The CMD has 2 branches for the sesame and right renal artery, 1 fenestration for the left renal artery. Our bridging stent were balloon expandable stent graft. 1 year after implantation, we found endoleak around visceral vessels. We brought him back for selective angiogram on each branch and found endoleak at mid portion of the bridging stent of the SMA and right renal stent. We plan to reline the SMA stent, but manipulate wire pass through the stent sometimes is not that easy. The previous stent had endoskeleton structure, so the wire tend to catch the stent or go outside the stent. Sometimes we thought we could pass the wire to the distal end, but actually, the wire went outside and back into lumen again. We knew that when we couldn't pass catheter over the wire, we had to withdraw wire and start over again. Finally, we successfully passed the wire into the lumen and reached the distal end, then reline it with the new stent. This is the CTA 4 years post-implantation. All branches were well patented without endoleak. The aneurysm was shrinked to 4 by 8 cm. He is doing well now. This is another patient who also had CMD stent graft for his TAAA. Again, we bridged all band with balloon expandable stent. 3 years later, we found endoleak around the SMA stent. On the angiogram, we found the SMA stent fracture. We tried to cannulate past the fracture site, but the wire went outside the distal fragment all the time. We changed the wire to Rosen wire. We thought the U-tip might difficult to go outside the stent. We was wrong again. The U-tip couldn't pass the fracture site. Finally, we used command ESY. It's smaller diameter with a long floppy tip. We got lucky this time. The wire was easily past the fracture site into the SMA. We faced with more difficult situation if the bridging stent was totally disruption. This is our first CMD case in 2015. In 2019, 4 years after CMD was implanted, he came back to our office with abdominal pain. CT scan showed the SMA stent fracture and disruption at the fenestration site with the huge endoleak. The cannulation from proximal fragment to distal fragment was not difficult when we have a gap between the fragments. After that, we bridged the new stent into the SMA. Immediately after he woke up, the abdominal pain was disappeared. He has no sign of bowel ischemia at all. But if there were not enough gap between the fragments, cannulation from proximal to distal was more difficult. This man got T-branch endograft implanted in 2016. 3 years later, he came back with back pain and recurrent pulsatile mass in his abdomen. The CT scan showed SMA and celiac branch fracture. Without the gap, cannulation from proximal to distal fragment was really hard. There was no room for wire and catheter manipulation. We have tried several catheters. Finally, with reverse curve catheter and angle tip wire, we got lucky again to cannulate into the distal fragment. Then we used balloon to realign the fragment, then reline with new stent graft. Sometimes the fracture stent occur in malalignment of the bridging stent. This happens when we didn't properly deploy the stent, or it slipped out from the target vessel during the deployment. The kink or acute angle of the stent made it difficult to reinsert the stiff wire or sheath beyond the kink. And during follow-up, the fabric of the stent was tear. In this situation, it is difficult to reline a new stent. To prevent aneurysmal growth, we have to occlude the proximal branch to clear the endoleak. This is another case. He had an endoleak from select stent fracture due to kinking of the stent graft. The selective SELECT angiogram show endoleak at the mid portion of the branch. We cannot just occlude the proximal stent like in renal branch. The black fold from SELECT trunk will cause persistent endoleak, so we had to go beyond the kink. This time, we use microcatheter to pass through the kink and fracture site. Then we do coil embolization, the distal fragment, then the proximal stent. In conclusion, ladies and gentlemen, I want to state again that EVA were created to prevent rupture of the aneurysm, not to cure the disease. So we need optimal surveillance with prompt problem solving when we found it. And finally, I think the long-term outcome of finessed and branched endograft is determined by the durability and patency of the branch. Thank you.
Thank you for an excellent talk. We've run a tiny bit over time, but we should ask some questions. I'd like to ask Professor Chun-Yu Chi and the whole panel really, when you are faced with a complex thoracic aortic procedure with potentially a long length of coverage, do you have a set protocol for your spinal drains? My personal policy is I tend to put them in everyone. There's very, very rare situations where I don't. I would like to sort of seek your opinions as to what you would do and what you would advise other people to do.
Well, ideally, we should put in prophylactic CSF drain in all of these patients, especially if we regard them as high risks. But unfortunately, the reality doesn't really match the ideal. In a lot of cases, what we find is that most of the time they're quite elderly and difficult, and the CSF drain may not be successful if we put them in preoperatively. And therefore, in our institution, the CSF drainage rate prophylactic is quite low. Even in post-operatively, if we put on a CSF drain, I think the recovery is quite dismal in most cases. So maybe the other experts could enlighten us as to what is their way of trying to decrease the rate of paraplegia.
Professor Leong, please.
I would say I'm a bit more selective. If I have to count, if I just count, I mean, in a standard TIVA, even if I cover the subclavian, but it does not go close to, I mean, it may go close to the celiac, I generally would not use a spinal drain. But if I do a fenestrated involving the visceral part, as well as a big portion of the descending, then I would put in a spinal drain. Of course, I would routinely revascularize the subclavian if I have to cover it.
Okay. May I ask Dr. Vince Lau, our colleague here, we enjoyed very much your talk on the treatment of endoleak. Are there any specific situations where direct sac puncture is contraindicated in your opinion?
Thank you for your questions. I think throughout the collaborations in the past few years, we have used direct puncture many a time as a first-line treatment. So mainly the concern is whether there is a safe access point. I meaning that the stent is not on the way, and whether there's any other vital structures. Usually we put the patient prone and we are able to get the access. So sometimes it's more anterior, which would be more difficult. But fortunately, for the anterior endo leak, type 2 leak, they are usually from the SMA. So we're able to get through the transarterial access in those cases. And as I said, transgluteal is another bailout that we would use if we fail to do direct sec puncture. But so far, the direct sec puncture, we have achieved 100% technical success. So I think it's a very useful procedure. Yeah.
Thank you. Any questions from the experts? May I ask Professor Leong, what do you think are the selection criteria for preemptive IMA embolization? We enjoyed very much your talk on the embolization. Is it a matter of seeing the size of the IMA on the preoperative CT that one should consider embolizing them in the same EVA setting?
I mean, I presented, or rather this idea of this paper came about because recently, recently I have two cases which are quite close to each other. And this is not one of those endoleaks you don't see too often. I remember a bit, the last one I saw before these two cases was something 2 or 3 years ago. Yeah, I mean, the experience is really quite limited, but I mean, based on the literature search and looking at the papers, I think basically especially the one the paper I presented there, it suggests that IMA more than 3 mm diameter, or patent IMA with associated large lumbar, which they put there as a 2 mm diameter. And also they find the risk is higher if there's a patent IMA in the the abdominal iliac aneurysm. So those are the group of patients that suggest have a higher risk. I mean, with this recent experience, I certainly will look at the size of the IMA, which I have to say I don't normally look at it previously, but recently, because of this experience, I will look at the size of the IMA and possibly embolize them if they're big.
Professor Leong, just to follow up on that, if the IMA is really that big, do you not have concerns that it's obviously giving a very significant supply to the hindgut, and therefore the risk of sigmoid colonic ischemia is potentially higher by preemptively embolizing it? What are your thoughts on that?
Yes, I'm smiling because I thought about that as well. Yes, I think in that situation, I probably would also have to, if you say you just look at IMA, you obviously have to look at the SMA and the celiac as well. I mean, if those big already they are patent, and probably you can do that. But if certainly the cases of time when we've seen where the IMA is just large is because of some stenosis of the SMA, or mostly stenosis of SMA, occasionally the celiac as well. So yes, I agree with you. That is a point well taken.
Maybe I would like to address a question to Professor Titi, please. On the retrograde type A aortic dissection, when do your patients start having symptoms of retrograde dissection? Because as we know, it's quite common to have some sort of chest pain or sort of fullness after a TEVAR. Do you CT all your patients that tend to have these symptoms? Because in our experience, we find that there are some delayed cases of type A dissection. Some even died at home. So it is not only in the immediate perioperative period that we need to be careful about. So we would like to hear from you briefly as to when do they start presenting in your series?
Thank you, Professor. From my experience, most of my patients have no symptom, but we found the retrograde type A by incidentally found it by the CT.
No symptoms.
Yes, most of cases with no symptom. But I review the literature. The symptom doesn't make the marxism become the big problem. But most literature suggests for the surveillance, CTA surveillance after perform the TIVA.
Okay.
And my suggestion is just all the case with, especially in the acute aortic dissection and treatment with the TIVA, all the case must have the follow-up CTA after the procedure.
Thank you. Are there any more questions, please?
I just have a question for Professor Robles. It's a really nice bit of kit you've got there. What are the contrast loads like when you are doing sort of pre and then post CTs with sort of endovascular intervention? They seem, or at least seem to me, to be quite high in a situation like that. Is that the case?
Sorry, contrast volume.
Yes, total contrast volume.
So I didn't record it specifically, but it's very focal, very focused. So you have the pigtail catheter in the aorta. You're not doing a venous injection as you would do a normal CT. So you can use very small amounts just at 0, 3, 6, 9, 12 seconds if you need to. So it's the sequence of injection more than the volume.
And do you use a power injector for that as per normal?
Yeah, because you can't be in the room, right?
Thank you very much to all our speakers. It's been an exceptionally educational session. The last thing that remains for us to do really is to take a picture, such as these things are now. So can I get everyone to smile at the camera, please, and show us your best smile, and they're going to take a picture for us. So we'll count down from 3. 3, 2, 1. Can I confirm that's been done?
Thank you very much, everybody. We'll draw
Thank
this session to a close. Thank you very much for your wonderful talks. Thank you very much.
Thank you very much.
Bye now.
Bye.
Dear colleagues, hello and welcome to this lunch symposium. Together with my co-moderator, Dr. Sorokin, we would like to focus today on new frontiers in aortic arch disease treatment. Obviously, this lunch symposium is sponsored by CryoLife. And as we are a little bit over time, without further ado, we would like to start with the first speaker. And Dr. Wong is going to familiarize you with the new Evita Open Neo, which is the new frozen elephant trunk device from CryoLife. So Dr. Wong, please.
Thank you, Chairman, for your kind introduction. And I would like to also thank CryoLife for allowing me to share our experience with the Evita Open Neo in Hong Kong. Basically, I would like to recap a little bit about a talk that I have done this morning about the total art frozen elephant trunk that we have. This is the paper we published in Seminar of Thoracic Cardiovascular Surgery about our previous experience of total art frozen elephant trunk with the in-hospital mortality of 9.8% and the overall mortality after discharge is 14.7%. We are able to achieve 100% 3 years post-discharge survival. And because we have a vigilant postoperative follow-up, including frequent CT scan in a timely manner, and we're able to identify 32% of our patients requiring second stage procedure. Total, we have 5 receiving endovascular second stage and 4 with open second stage. So far with the satisfactory result, but we are still trying to improve further. So the problem that we have with the previous model that we are using is we noted there's a short distance between the last branch of the left subclavian artery to the sewing collar. That imposed technical difficulty when we are doing a direct anastomosis through the very compact space. Secondly is we noted there's a phenomenon of a shortening of the stented portion of the thorax. I will show you a video later about that. We have noted also a 20% chance of a distal sign, and 32% require a second stage procedure, as I mentioned. So let's look at this chest X-ray. So for those who have experience with implantation of thorax will know that sometimes it's not uncommon to see from chest X-ray that the elephant trunk seems somewhat shortened than what we want and we planned. So this to your left side, you can see the elephant trunk of the thorax seems somewhat not as long as we expected. And to your right-hand side, you can see Evita Neo. Because of the stand graft design is similar to the usual TIVA that we have, so it usually be able to stand and position in where we want. This is the reason, I think, because of the scallop design, is able to actually have a shortening of the thorax stand. This is what I think the issue with the longitudinal stability. The other issue that we suspect associated with the distal signs are the presence of these protruding parts of the distal ring of the thorax. And you can also see there's a ring, mainly the distal ceiling is provided by the radial force of the distal ring. And these impose a very focal pressure to the distal aortic endothelium. The last thing I want to show is the distance between the sewing collar from the left subclavian artery branch. To your left-hand side is thorax, is only 5 mm. To your right side is Evita Open Neo, is 2 cm. And you can see from this to your left-hand side is the Evita Open Neo. You can see the direction because of the 2 centimeter distance from the LSCA to the sewing cuff. There's a bigger room for it to align with the left subclavian artery. To your right-hand side for the thorax, it's not uncommon to see this kind of angulation between the left subclavian artery and the branch at the origin because of the close proximity between the distance of LSCA and the sewing cuff. So last year we have the privilege of having Professor Hans Jakob from Essen to virtually proctor us to perform the first Evita Open Neo in October the 6th. So actually we have published our video in CTSNet, and you're welcome to visit it through the CTSNet. And we also published in the Journal of Cardiac Surgery regarding how to launch a new product with the virtual proctoring despite the COVID challenge. So I would like to share with you the second case. This is sort of the sequence that we are adopting in doing the EVITA Open Neo now. So this is a case with ascending aneurysm and descending chronic type aortic dissection. So in such a case, we normally would cannulate the ascending aorta as an aortic cannulation, and RAA for the venous cannulation, and then the RSPV. During circulatory arrest, we will clamp the ascending aorta and give the cardioplegia to the native aortic roots in around 20 to 30 minutes interval. After that, we will identify the guide wire that we previously planted at the beginning of the operation. It will trim the aortic wall and then establish antegrade cerebral perfusion. So in this time, the heart is intermittently protected by the cardioplegia with the clamp on. So there will be less issue with the de-airing later on. So after we achieve the antegrade cerebral perfusion, it's our practice to antegrade perfuse all hand neck vessel. So after we have done that, then normally the patient will wake up around 2 to 3 hours after the operation. It has no significant difference from a normal double valve procedure. So after establishing the antegrade cerebral perfusion, we will do the distal anastomosis. So I would like to scroll it faster. So because this left subclavian artery is a bit deep, so we will cut the branch, one of the branch of the EVITA Open Neo, to do the separate anastomosis to the left subclavian artery first, before we perform the distal anastomosis. This is our usual strategy. We also publish the different strategy to tackle different anatomical variation of the left subclavian artery in the JTCVS technique. So after anastomosing this side branch that we have cut from the EVITA Open Neo, we will proceed to the deployment. So during the deployment, we need a copious amount of water to lubricate the guide wire. The guide wire that we use is a 300 mm Terumo wire. Then we don't need a very stiff wire. All you need is to have assistant to pull through and through wire and to straighten it. And then we can introduce this system to the desired length, position. So we will slide down. When the assistant hold the proximal part of the guide wire and also the femoral part of the guide wire, we can introduce the system into the desired location. After it reaches to the desired location and the orientation is ascertained, we would use a pair of forceps to hold the collar so that during deployment, it will not be displaced. So we need to make sure the orientation, and then we can deploy it. Afterward, we can remove the guide wire, make sure the guide wire is well pulled down to the descending thoracic aorta. When we remove this system, as I mentioned, we need to hold the collar of the EVITA graft to make sure it will not be displaced when we remove this introducing system. And then in our center, we routinely would perform continuous suture to perform the anastomosis, followed by interrupted serial with pledget to secure the distal anastomosis. This will prolong the circulatory arrest time, but at the same time will give us a pristine hemostasis. That's what we want. We don't want to be bothered by the bleeding later on. After that, we will restart the antegrade cerebral body perfusion, clamp the graft. Afterward, we will do the proximal anastomosis, so to reduce the myocardial ischemic time. And at the same time, we are already rewarming the patient. And after that, we would do the left common carotid, subclavian bypass, common carotid bypass. And one trick I want to show you is to use the first side branch of the EVITA Open Neo as a de-airing. So we are actually, from here, we are using the first side branch for de-airing. Because the heart temperature already back to more than 35 degrees Celsius. The heartbeat is now spontaneous. So after de-airing, we can clamp and do the last anastomosis. And the ACP is still in position. That's why we have slightly longer ACP time, but that doesn't actually affect the patient outcome. So after the final anastomosis, this is the hemostasis at the end of procedure, soon after protamine, finish the protamine. So the third case that I want to share with you is to deploy the system without the use of guide wire. We only use guide wire when there's a dissection. If it's just aneurysm, we can deploy without using the guide wire, like in this case. So leave these orange introducer in sideshow, and then we can mold the elephant trunk in a desired direction, and then introduce it and deploy it. It's very simple and easy. I think it requires no learning curve about this stage. After that, we can remove the introducing part and then just deploy it. As I mentioned, hold the neck collar with forceps before we remove the system. So afterward, we will confirm the position and adequacy of the opening using an angioscope. And then this is the hemostasis at the end of the procedure. Fourth case is a retrograde type A IMH arch PAU. Actually, is performed by one of our aortic fellow, Dr. Jackie Ho. He will present it tomorrow about our left subclavian strategy, how to tackle the left subclavian in total arch replacement. So actually, we have published this technique of different management approach to the left subclavian artery during total arch frozen elephant trunk procedure. And to give you a bit of summary about the cases, so far we have done 9 cases. The mean age is 67-year-old. Actually, 11% of them are subacute DeBakey type 1 aortic dissection. We have so far 2 patients present with Ortner syndrome, which have a recurrent laryngeal nerve palsy even prior to the operation. And this is a very busy slide. You can see the circulatory rest time is around 16 minutes. The intraop transfusion of PAC cells 4 units. 67% of our patients actually will land on zone 3. And we have also 33% of our patients with concomitant procedure, including AVR and CABG. These are our outcome. We have 100% survival so far, and 0% 30-day mortality, of course. We have an average length of stay in intensive care unit is one day, and the length of stay average is 9 days. And we have some minor issue of the WAF oozing after we given protamine, and we have actually have some strategy to tackle it. So far, we have 0% stroke. We have 11% of patients with transient paraplegia. Since our number is small, it seems a quite high percentage, but in fact, we have 1 patient with permanent paraparesis, which after we implant 180 mm frozen elephant trunk. So far, we have no postoperative renal dialysis, no stent graft mouse placement, so 0% stroke as well. And we have 0% restenotomy for hemostasis. So we have so far we have planned second stage procedure in 78% of our cases. 3 of our cases already have second stage surgery, which is a planned one. We have 1 open descending replacement and 2 TIVA. So far, also no mortality after second stage intervention. This is the case that we have done open second stage after the EVITA open neo, which also show nice result. And the key is to have a 1-to-1 size of the graft to do small bites with the anastomosis, as previously been published by Dr. Fujigawa and our team. So in summary, ladies and gentlemen, I think EVITA Open Neo is a more versatile approach and adoption of the total arch frozen elephant trunk. It is more friendly, and I think it's slightly better design. And but there are also potential ways to reduce oozing from the graft. So thank you.
Thank you very much for this nice case illustration. Dr. Sorokin, do you have questions?
Yeah, Dr. Randall, thank you for a very nice presentation. One quick question. When you do second stage operation and you operate on descending aorta, how do you manage the graft? I mean, you cut it off, you try to keep whole length, and what's your suture technique? Thank you.
Sorry, you are talking about the dealing with the frozen elephant trunk, the stent?
Yeah. Yes.
So far, actually, this is our biggest concern in the past. That's why we have a lot of discussion with Dr. Fujigawa and myself. We discuss about that, whether there's a oozing from the graft itself. But so far, we haven't encountered both Foraflex and Evita. Fortunately, we have not had any issue with the graft oozing, the stent graft part. So far, we haven't had any problem.
So when you do stitching on descending aorta, you keep native aorta in and you completely take it out?
Yeah, we will finally wrap the graft with the native aortic wall.
Yeah.
Not because it is for any hemostatic purpose. It's just to prevent the graft from develop some reaction with the lung and the chest wall.
Just pure graft to
graft to graft. We don't include any aortic wall. Yeah.
Okay, I see. Thank you very much.
So maybe from my side, a question in regard to, do you always go to zone 3, or is this depending on the anatomy, or is it kind of evolving over time that you're now these days doing more zone 2 anastomosis?
From case to cases, because ideally we should choose zone 2, because I think zone 2 is associated with less recurrent laryngeal nerve injury. And but in the cases, as you can see, the first 9 cases that we have done, 60% we need to go to zone 3. That's largely because of the anatomical consideration. Some patients actually have quite a big PAU at zone 2 and zone 1. That's why we cannot not to anastomose at zone 3. So largely, I agree with, I think the global trend is to anastomose at zone 2. Yeah.
And then also we need to mention that the Vita Open Neo, it comes in different configuration.
Yes.
I've seen the branched version here. There's also the usual island configuration that has an extra perfusion arm, and also there's the trifurcated version that allows potentially to do a zone 0. Yes. Any kind of thoughts on this?
In fact, we are more familiar, as just illustrate the experience that we have. We are more experienced with those branched graft, and I think branch graft give us a bigger margin, because I always worry about the trifurcated graft. If the main trunk got any thrombosis, that all the head and neck vessel will be jeopardized. And also we are not too familiar with the island technique. And we also worry about the island part of the aortic wall may become aneurysmal in some case. We are not sure. Yeah.
Thanks a lot, Dr. Sorokin. When I introduce the next speaker, we need to make up some time, unfortunately.
Let's move on. We are a bit behind the schedule. So next speaker is Dr. Daniel. He is from Queen Mary Hospital from Hong Kong. He's fellow of Edinburgh College from 2009, and he got his fellowship in North Carolina under Professor Underwood. His talk is about using the MDS hybrid prosthesis for aortic dissection. Please.
Thank you, Dr. Sorokin, for your kind introduction. So I have the privilege to share with you our initial experience for using this Osiris medical dissection stent, so in short, the AMDS, for the acute aortic dissection. These are my disclosures. So first of all, for introduction, acute aortic dissection is an uncommon disease with a high mortality and morbidity. So clinical is simple. We use the Stanford classification. Type A, we go for surgery. But in fact, the DeBakey type 1 is being the most common one and also the worst type for the patients. So surgical treatment, the principle is that during surgery, we try to resect the tear. Then we establish the true lumen flow, try to correct the malperfusion, and hopefully promote the future aortic remodeling for the patients. So nowadays, standard treatment will be the hemiarch, or here in our locality, we call them ascending aortic replacement. So this is a little bit data from our institution. So in the past 8 years, we performed about 350 acute aortic dissection repair. The overall mortality is 9.5%, complications including bleeding, acute renal impairment, and the stroke. And one thing I think, it's very global, is that the results improve over years. So nowadays, about 5.5% of mortality every year. The improvement of the early results depends on a lot of factors. I think what importance, another big issue is that what happened next to our patients. So from the literatures, we find that after type A aortic dissection, the overall 5-year survival is between 50 to 80%. This is a very wide diversity. And one key thing we notice is that the indicator for good survivals is whether the remaining aorta has been remodeled. If the aorta is remodeled, usually the patients have a better long-term outcome. Unfortunately, this belongs to a minority of the patients. About 30% of them can have a remodeled aorta, which means that majority of the patients, they have the patent false lumen. They are less favorable because they are prone to have complications related to the aorta, the malperfusion, or complications from the re-intervention. This is a CT follow-up study published in 2017, saying that as high as 80% of the patients, they have the patent false lumen early after operation. This is another study. They also found that besides the patent false lumen, if the patients have a large entry site more than 1 centimeters and the proximal location of that tear, the survival is even worse. So the next question is asking, why there be false lumen? In the surgery, we definitely resect the primary tear. We examine the arch, there's no tear, might be some of the small tear down in the descending aorta. But we found that one of the key problems is that from the distal anastomosis at the proximal arch or the distal ascending aorta, we are doing the anastomosis on a dissected frail aorta. The pressure is still present inside the false lumen, so that's why the intima itself will be quite easily cut open from the tension of the sutures. This phenomenon we call the DAN, the distal anastomotic new entry site. And the same study demonstrated that from the CT, 70% of the patent false lumen is actually due to this DAN. And again, from DAN, it is a proximal and a large entry site. So once that happens, you expect the patient doesn't do well in the future. So this is one of our local experience. Typical 50-year-old man, hypertension, come in, DeBakey type 1 acute aortic dissection. Intraoperatively, no tear at the arch, so just a valve-sparing aortic root replacement. Uneventful post-op, but 1 month after, the CT shows a large false lumen at the arch and the descending aorta. And also, there's a new entry site at the distal anastomosis. So AMDS, this stent was designed to treat for this treatment gap. So this stent is supposed to put in the aortic arch and the descending aorta during the circulatory arrest. So the proximal part is actually a PTFE felt graft. So just like any other ordinary felt graft is for us to use the sandwiching the distal aorta just as a reinforcement. And the stent is an uncovered open natinal stent. The idea is to support the true lumen. So for this stent, it has a low radial force, which means that it will protect very gentle to the dissected aortic wall. So if the stent is oversized, it doesn't put much force on the aortic wall, but in fact, it will change its length to become longer. And also it's kink resistant, and the distal part of the stent is pointing away from the aortic wall, so just to prevent the new entry from the distal end of the stent. The use of this stent has been confirmed with the effectiveness and the safety by this DAST trial published early on this year. So it's a multi-center prospective non-randomized trial involving 6 centers in Canada and Germany. So first of all, among the 46 patients in this trial, the characteristics is quite typical for those patients undergoing type A aortic dissection. Most patients have the hemiarch repair. So first, the device deployment success rate is 100%. The median time to deploy this stent is only 3 minutes. So for the primary endpoint is that the mortality is 13% with a very low complication rate, including stroke of 6.5%. I would say it's comparable or even lower than most of the published series. And this is logical because it's just only 3 minutes extra from the circulatory arrest time. And another important point is that there's no aortic complication related to the stent. No stent fracture, no new entry site. But more impressive is the secondary endpoint. So from the clinical and the CT follow-up from this trial, the vessel malperfusion defined as clinical or the CT follow-up, 95.5% has been resolved without secondary intervention. There are positive aortic remodeling, which defines in the change in the overall aortic dimension or increase in the true lumen size or decreased on the false lumen size. It happens in 100% in the arch and 77% in the descending aorta. Same, false lumen thrombosis, 74% at arch and 53% at the descending aorta. Just by eyeballing comparison, the follow-up data and the results is much better than a lot of the published series. So this is our first example or first experience using the ADMS in Hong Kong. So this is a 48-year-old lady. She presents with a typical dissection chest pain. And this is the CT at the emergency department. So it shows the patent false lumen. The dissection involved the ascending aorta with the tear at the ascending aorta. And you can see there's a complete transection of the intima from the ascending aorta and back again in the aortic root. So before going into the operating theater, we use the CT sizing to choose the stent we are going to use. 2 points to size. First is the aortic arch at the level between innominate and the left common carotid artery. It measures 38 millimeter. Second point is at the level of the trachea bifurcation. It measures 29. So from the company, we have a simple chart. We're going to use this stent. So for the sizing, quite simple. So basically, you have a small stent or large stent. And each stent, you either have a straight one or a tapered one. So basically, I'm going to use the large stent with a tapered end. So sorry that I don't have the picture from the first case because it's in the middle of the night. But the setup is quite straightforward. So a typical right subclavian artery cannulation, circulatory arrest at the 26 degrees Celsius, and antegrade cerebral perfusion. So as shown in the CT, the intima was completely transected at the ascending aorta. But luckily, the root was patent and also is not dilated. Also, no tear found at the arch, so I can spare the root and the arch for her. So this is some intraoperative TEE. Quite interestingly, you can see the remnant of the intima going in and out of the aortic valve together with a severe aortic regurgitation. And also in the descending aorta, there's a similar flow in the true and false lumen. So these are pictures from my second AMDS stent, just to illustrate the technique implanting the stent. So first, during circulatory arrest, so examine the aortic arch, make sure there's no tear inside the arch, and also leave about 1 centimeter of aortic cuff for the anastomosis. So next, just to insert the stent. Now, the stent, the tip is looks like a pigtail, so it's very soft. Just put the stent all the way inside the true lumen. When to the proximal part, then just simply remove the plastic covers at here, and the felt strip will pop open. So next, just to use a couple of stay sutures to stay the inner plagate, aortic wall, and the outside plagate strip. So here I use usually 3 stitches, should be all right, because the anastomosis site is not so deep, so later on it's quite easy to go on with the operation. And then, when ready to deploy, just unscrew the green knob and then pull the string all the way out. The stent will be deployed inside, and slowly retrieve the delivery catheter. And that's it. So next, just give the antegrade cerebral perfusion through the stent. So the choice is that I can start giving antegrade cerebral perfusion through the right subclavian cannulation artery early on during circulatory arrest. But since the deployment just used 3 to 4 minutes, so I decided to cannulate the neck vessels after the stent deployment. And also, it's quite easy to do so. The next is quite some usual practice to complete the anastomosis and the graft replacement in a usual manner. And at the end, the graft looks like that. So, of course, we cannot see the stent from outside. But most impressive one for myself is that circulatory arrest time is only 23 minutes. I just use additional 2 minutes even in the first case. And the postoperative TE, you can see the stent in the descending aorta with a good flow in the true lumen, and also a mild AI after aortic valve resuspension. Patient was quite uneventful postoperatively. I'd like to show you the CT at 4 weeks later on. Although the false lumen is still patent, you can see, but at least I don't see any distal anastomotic new entry. And you can see the stent is quite long down to the abdominal aorta. And from this CT, I can show that there is positive aortic remodeling. Compared to the preoperative size, the true lumen increased to 27 millimeter. And also this also happened in the descending aorta. The true lumen size increased. So hopefully for this patient, we will have provide her a better long-term outcome. So come to my conclusion is that DeBakey type 1 acute aortic dissection remains the commonest, but yet the worst type of acute aortic dissection. Then itself is very common after surgery, and it will cause a patent false lumen and affect the long-term survival of our patients. AMDS itself can support the true lumen, promote aortic remodeling, and prevent the dent. And the use of AMDS, importantly, is easy, safe, and doesn't change our usual practice that a lot. And of course, we have to wait for the long-term outcome, the long-term data to confirm the benefits. So thank you for your attention.
Thank you, Professor Kemper. Do you have any question?
I think if you have to do these cases in the middle of the night, and this is the usual nature of the acute type A procedures, in regard to the sizing, as you have pointed out, technically it should be relatively easy. You need to size in zone 1 and then in the descending. But sometimes you do not have any software on hand that can do a MIP or a centerline reconstruction. So there's a kind of a simple surgical workaround. You can use a 33 millimeter mitral valve sizer. And if this one is smaller than the arch, then you need to use the larger proximal stent. And if it's smaller, you use the smaller one. So just if you're in an emergent case, it's a nice trick. Other than that, there's also the option to not use bilateral antegrade perfusion. I honestly only use unilateral over the axillary artery. So you do not have to cannulate the arch, but obviously this is due to your own personal preference and practice, and I guess should not change whether or not you use or you do not use the AMDS stent. So we have done now close to 100 of these stents, and it has become a standard of care in our center.
Thank you, Professor Kemper.
Dr.
I think
Daniel,
that's a
good. Simple question, technical questions. How difficult to put cannulas to left common carotid and left subclavian artery through the stent? Is it technically challenging? Or?
No, it's actually not. It's quite easy, just like usual practice, because the stent cell itself is quite big, quite large enough. So, even in the first time, I didn't find any difficulties in putting it. And also, because with the stent, it just pop up the rest of the aorta, just like, kind of stenting up the aorta. So actually, it promotes your vision inside the arch itself. So I found it quite easy, to be honest.
May I ask a question? Is if you could see a tear at the mid part of the arch, for example, would this stent still work, or will you choose another approach?
I don't think so. I think I would stick to the surgical principle. If we see the tear over the arch, I would choose total arch replacement rather than just use this stent.
Okay. Any further question? Okay, in this case, maybe we move on And our next speaker is Professor Kepfer. He is from Berlin. He got his residency for cardiac surgery in Leipzig under Frederick Moore. And now he's working in Berlin Heart Center from 2014 under Professor Falk. Okay, and his talk is going to be about algorithm, how to apply this new technology in clinical practice on daily basis. Please, Prof.
Yeah, would love to give you kind of an overview. I have a little bit technical problems because I cannot share my screen. It is deactivated by the host. So I guess they will solve this. So basically the idea is that you have seen both devices, so the AMDS stent, which is meant to be used in the acute setting. And we can have maybe after the presentation a discussion whether or not we should use it in all or only in selected cases. And then obviously there's the classic, more aggressive radical option to use a full arch replacement using, for instance, a frozen elephant like the Evita Neo. So I've brought with me a couple of case examples, so to fire up maybe the discussion. So as it has been pointed out a minute ago, the surgical principle is going to direct which device to be used. So in all the acute type 1 dissection, if the anterior is located on the ascending only, then resection of the ascending, open anastomosis plus minus an AMDS stent is enough. However, if the anterior is in the aortic arch or in the proximal descending, then this should trigger a full arch replacement. So this is our kind of a strategy. Again, if it's a simple case, so only an anterior in the ascending, the patient might present with or without malperfusion. Our standard of care is ascending resection plus the AMDS, and this is now basically done in all our dissection cases. However, if there is an additional anterior, and this is a case where you can nicely see with an angioscope a tear in the proximal descending, which also was suspected by the CT scan, then this portion of the arch, the proximal descending, simply needs to go, and you need to go for classic arch or frozen elephant replacement. So an addition kind of debatable topic is whether or not you go for prophylactic full arch with a frozen elephant in younger patient where there is suspected connective tissue disease. We can have the discussion later on. There are many different opinions on that. I personally think that if the patient is in a good preoperative state, I rather would take the arch if the patient is very young and there's suspected connective tissue disease. So let me walk you through a couple of case examples. So this is a relatively simple type A. So there's a tear in the ascending, no arch tears. There are no real kind of malperfusion. So standard of care would be ascending replacement, open anastomosis with an AMDS. This one here is more or less the similar kind of startup scenario. Again, entry tear in the ascending, no arch tear, no cerebral malperfusion, but this time, as you can see here, the left leg was gone, so distal malperfusion. As it has been pointed out, the AMDS has been found to be very kind of effective in treating this downstream malperfusion. So again, isolated ascending replacement and a zone 0 AMDS, and the left leg opened on its own after reperfusion. So now things get a little bit more complicated. Again, it's a ascending tear, so no problem in the arch. However, there's the usual cerebral malperfusion, including some neurological symptoms. And in those cases, in my opinion, it's critical to understand whether or not it's a true lumen collapse, so subtotal occlusion, as it can be nicely seen on the preoperative CT scan on the right, common carotid, and also the left one was involved, but the right is more obviously pronounced here. And our standard of care is to use true lumen cannulation. In this case, we use the right axillary artery. And then once the perfusion is started in a true lumen, the anesthetist is going to do a neck ultrasound. And usually, if this is only a true lumen collapse, you can see restitution of the flow on the Doppler, as it can be seen here. And in those cases, we do not add any extra surgical techniques. We simply go with the ascending replacement plus the AMDS stand. You can see on the post-operative screen here on the green circles that both carotid artery nicely opened up. However, these things are not always that simple. This is again a patient with acute type A. In addition, a polyaneurysmatic aorta downstream. In addition, there was a large arch entry. So in this case, we would need to go for a full arch replacement. But focusing on the carotid situation for a minute, you can see that there's almost complete occlusion of the innominate artery and obviously occlusion of the right carotid. And in this case, after starting flow in the true lumen, in this case, we used a femoral cannulation technique, you can see that there is actually false lumen thrombosis, and there's no way that this one is going to open up on its own. So in those cases, we use a different surgical technique. So we would do a cut down to the right carotid or the left one if this one is affected, and then dissect the bifurcation, and then simply cut the origin of the internal carotid artery. Usually this part is not dissected, and then you do an end-to-end anastomosis with an 8 or 10 millimeter graft, and then you can use this one for cannulation as well. So the cooling would be through the right internal carotid and a femoral in the artery and a femoral vein in this case. And then later on, obviously you need to connect this one, and this is going to be then a kind of an extra anatomic carotid rebranching. In this case, we also did an extra anatomic to the right subclavian because the innominate artery was completely gone. And due to the fact that there was an entry in the arch and there was a polyaneurysmatic aorta, we chose an Evita Neo in zone 2 in this case, but this technique also would work with an AMDS if there's no arch involvement. And this is what is summarized on this slide here. It's similar case actually. The only difference is that this time there's no downstream problems and there's no entry in the arch, but again, it's the same kind of startup scenario. The total occlusion of the innominate artery, the right carotid was almost completely gone, the left is subtotal. And again, it's the same strategy, cut down to the right carotid, end-to-end anastomosis, and then a zone 2 AMDS with a branch surgical graft. So that's also an option that you always should keep in consideration. We also can use the AMDS in a zone 2 configuration, and in such a way you spare the reimplantation of the left subclavian. So again, summarizing our treatment algorithm, basically the technique is tear orientated. So if there's only a TND ascending with or with mild perfusion, ascending resection and the AMDS is enough, you might consider some extra anatomic rebranching in case of false lumen thrombosis in one of the carotid. If the entry tear is located in the arch or in the proximal descending, then simply this arch needs to go, and our strategy would use a frozen elephant to be used. And then obviously there's a topic to be discussed. If the patient is really young age and there's a suspected connective tissue disease and the preoperative status is relatively stable, and you have the option to have an experienced aortic team on site, then in my personal opinion, it is good to go with a prophylactic arch replacement in this relatively rare subset of patients. Thank you for your attention.
Yeah, thank you very much for your nice talk and very beautiful algorithm. So I just have one simple question. Do you have room for ascending aorta graft interposition with hemiarch? And for example, if you need to do a Bentall operation, would it change your plan for the arch?
You mean in regard to when you're using the frozen elephant or the AMDS?
For frozen elephant and MBS, where is the hemiarch, not simple hemiarch goes to? You don't use it at all?
Honestly, no, we don't use it if it's a type 1. Obviously, in a type 2, we would use it, or if the dissection would end in the arch, then we would use a standard hemiarch. But other than that, I don't see any kind of disadvantage of adding the AMDS to a standard open arch procedure. I guess we all agree on the only downside might be related to reimbursement cost issues. But other than that, I've never seen any patient that had any negative kind of impact from the AMDS stent. And it doesn't change anything. In regard to your question for additional root surgery, the anastomosis for the AMDS is roughly the same position close to the innominate artery as you would do from an open standard arch, so to say. So I don't really see any downside with that. The only unanswered question is if these patients might bounce back in the future and might require distal intervention like growth of the descending or even the arch, what we have not seen yet, then obviously the question is going to be, how do you tackle that? Do you need to use candy plugs, or how easy is it going to be to take out an AMDS then once it is in for a couple of years? But we have not seen this, and I'm not aware of any case worldwide.
Okay, thank you.
Thank
Dr.
you, Professor
Rondel, Daniel, any question?
Yes, I have two questions for you, Professor Camphert. So for the AMDS, have you any experience deploying at the zone 1 or zone 2? And second question is that since you have early experience, what do you think about mid to long-term results with the patients with this stent implanted?
Yeah, so regarding the first question, I've shown one of these cases in the slides. Yes, it's absolutely possible to go into zone 2 or 1. I think zone 1 is more common. If the innominate artery is completely kind of dissected, you might consider doing a zone 1 anastomosis with the AMDS, and then do not attach a standard graft, but a kind of a side branch, an antiflow prosthesis. And if you go into zone 2, then obviously you need to have a more branched graft, and we would use the loop PI prosthesis for those instances. So this is absolutely doable. For the midterm, our first patients are now at 3-year follow-up. So my personal feeling, and this is obviously not scientific data, but what I can tell you from their clinical practice or experience is once the patient are at 1 year, nothing is going to change. We have not seen anything happening beyond 6 months or 1 year follow-up. So usually the CT looks pretty stable. We have had 2 patients that required a secondary intervention after AMDS implantation. In both cases, the arch was fine. However, we saw growth of the proximal descending. And in both cases, there was a kind of a feeding through a large re-entry in the left subclavian artery, which led to false lumen growth in the proximal descending. And both patients were treated by a carotid subclavian bypass and then coiling of the left subclavian, and then this phenomenon was gone and further follow-up was stable. So I think that maybe in those patients where we recognize a really large re-entry in the subclavian, you just need to be aware of it, right? And maybe have a shorter follow-up. It's easy to treat, but just you need to be aware of that this might be a source of false lumen feeding even after the AMDS.
Thank you. That's impressive.
Right. So I was always looking forward to the midterm outcome, because I think it would definitely be challenging. I mean, considering the open second stage treatment, and also we need to redefine the concept of endoleak, because it is a bare stent. So what Professor Camphert just mentioned, to embolize the left subclavian and then do carotid exterior subclavian bypass. So this kind of false lumen perfusion, whether we should call it type 2 endoleak, because to be honest, this is a bare stent. So how would you classify? Do you need a new classification system?
Yeah, there was a kind of by the founder of the initial company, or the guy who invented the AMDS stent, Ali Shahriar, is also a cardiovascular surgeon. He came up with a kind of a new classification, which is exactly directing in these kind of area. So because it is bare stent, obviously we need to kind of classify whether or not there is a re-entry in the subclavian, in the carotid, whether or not there is still false lumen flow or complete thrombosis in the arch or in the proximal descending and stuff like that. Because I fully agree, this might impact on what we see in the anatomical development over time. And this, once we learn more about it, might also redirect our treatment strategy, whether or not we go for easy coiling in the carotid subclavian, or if you do T-bar extensions or these kind of stuff. I mean, having 100 of those devices implanted now, I can reassure you that overall I'm very impressed with the clinical results, but obviously it's not realistic to believe that there's no single patient that is going to require secondary intervention. This is why I fully agree it's an important topic for future research.
Are you aware of any flow dynamic assessment of the true lumen, false lumen change after the AMDS implantation? Are you aware of any study?
Yeah, so we have tried a couple of MRI scans trying to exactly highlight that. Unfortunately, it doesn't work well because you get so many artifacts. It is hard to kind of do flow visualizations, right? So based on what we see in the true lumen expansion, I think you have seen yourself that in the majority of cases, you still have some false lumen perfusion at a discharge CT scan. And then if you're lucky and if there are no large re-entries in the supraaortic vessels, then typically the arch, and if you're lucky, also the proximal descending is going to thrombose over time. But it's all depending on the kind of a re-entry status in the supraaortic vessels.
Thank you.
Thank you.
Professor Comfort, can I ask you a question? If you do your all AMDS in a hybrid theater, or you just use a normal theater without guide wire?
So no, I do not use a hybrid theater for those procedures. I have to say, also I'm very active also in the transcatheter business, doing lots of MitraClip and TAVI and this kind of stuff. I hate doing type A emergent procedures in the hybrid theater. I find this very challenging because, you can't kind of work with your table. It's hard to do the logistics behind it. And one beauty of the AMDS stent is that you do not need to have a fluoro. And honestly, also, you do not need to use a guide wire. I have never used a guide wire. There's a pigtail-shaped kind of a tip end that is very soft and atraumatic. If you want to, you can use a guide wire. It houses a standard 35 wire, but I did not found this necessary. So I'm actually really glad that this one doesn't really require a hybrid.
Dr. Daniel, how's your institution? Do you use guide wire or you just introduce it without a fluoroscopic control?
No, we don't. We don't use guide wire. So same comment from Professor Comfort. So we do all the TAVI as well, but we hate the hybrid theater. So luckily, it's quite a straightforward stent. And we blasted that in an acute setting. Usually you can identify the true lumen by the eyeballing. So I think most of the time you don't need the guide wire for the AMDS. I agree with that.
I think we are run out of time already.
Yeah, so we also do not see any questions from the floor.
Yeah, no question.
So if there are no burning question, do you want to wrap up kind of the session?
Yeah, I think so. Well, first of all, we'd like to thank again the CryoLife for offering us this opportunity to share our initial experience of both devices in Hong Kong. And also thanks for the expert experience from Professor Comfort, and thanks, Professor Sorokin, for your participation in this session as well. Thank you.
Thank you.
Thank you. Thank you.
Bye-bye.
Good afternoon, everyone. Welcome to Aortic Asia. And after the whole morning on focusing on the aortic arch and also some endoleak interventions, we come down a little bit to talk about the complex thoracoabdominal interventions. I'm Dr. Sky Pan from Hong Kong, and I'm the moderator in this session. To chair with me at the same session, it is my honor. We have Dr. YP Leung from Malaysia. He is the most famous endovascular and vascular surgeons in Malaysia. And in this session, we have very packed schedule with one mini case and also a lecture. And without further delay, let me introduce our first speaker today is Dr. Huang. He is an attending surgeon in Division of Cardiovascular Surgery, Cardiovascular Center, Chen Xin General Hospital, and he has several qualifications, including the surgery in Taiwan Surgical Association, Cardiovascular Surgery, Taiwan Association of Thoracic and Cardiovascular Surgery, Vascular Surgery, Taiwan Society, Vascular Surgery, and also Cardiologist, Taiwan Society of Cardiology. And please, Dr. Wang, please.
Okay. Hello, everyone. Sorry. Hello, everyone. Welcome to today's webinar in program of complex thoracic intervention. I'm Dr. Huang from Zhenxing General Hospital, Taipei in Taiwan. I'm delighted to be with you to share one of my team case. Her past medical history was significant of Marfan syndrome with repeated aortic dissection and slowly expanding thoracoabdominal aortic aneurysm. At the age of 23, she underwent an emergent bento operation of acute type A aortic dissection. 8 years after the first surgery, she had restenotomy heart transplantation with total arch and descending thoracic aortic replacement due to recurrent aortic dissection at the distal arch with ascending aortic aneurysm and moderate aortic retraction with significant paravalvular leak, leading to the acute decompressed heart failure. Recurrent aortic dissection from ascending aorta to abdominal aorta, and the diameter of the true lumen has been compressed to extremely small. We use a combination of surgical strategy with heart transplantation and the total arch and the descending aorta reconstruction. After previous bento operation, an annual temporary aortic dissection and the original at the distal arch and the true lumen compressed in descending thoracic aorta was noted. With the dissected sac growing and the severely compressed true lumen of the aorta, the dark cone graft with V-arching ring connector was placed into the fourth lumen with multiple penetration in order to restore the flow through all visceral vessels and the legs from the true lumen of the aorta. It is the CT or the chest CTA after heart transplantation with total arch reconstruction to descending thoracic fourth lumen. The CTA image showed the diameter of post dissection aortic aneurysm was 4 in centimeter in 2009, and it grows bigger and reached to 8.5 centimeter in 2020. In this case, the disappearance of the true lumen was not just compressed by the expanded fourth lumen, but also by extensive dissecting thoracic abdominal aneurysm. Ciliary trunk SMA and the right renal arch are also arise from true lumen, but the left renal artery is from fourth lumen. We take thoracic abdomen incision with repair of thoracic abdominal aneurysm into consideration for this young muffin lady. It is very technically demanding and associated with high morbidity and mortality. The family and the patient all refused due to previous major operation and her body status. The BMI only 40.5. We take endovascular treatment into alternative. Along the CT image of the thoracic abdominal aorta, we found the diameter is about 4 plus 45 to 5 plus 6 centimeter in thoracic aorta, which is 1 to 3 centimeter above the ciliary trunk. This is comparable with the IFU of the T branch. The rupture hole to vessel artery from the true lumen to fourth lumen is about 6 to 7 millimeter in diameter. We might have an opportunity to use this communicating hole as an access to cannulate all the vessel arteries from the true lumen. As you can see here is the ciliary trunk. The other issue is how to deploy the stent graft to connect the branch of the T branch and all vessel artery after all arch artery has been reconstructed over ascending aorta. So we take a ascending aorta approach by CTA. We could identify the third intercostal space is the best route to ascending aorta. Left side picture shows the standard T branch for posterior dissecting aortic aneurysm. The main body is deployed in true lumen, and the ciliary trunk SMA and one renal artery are also in true lumen, but it could not be done in true lumen stenosis case. In our case, fourth lumen has space enough to expanding 4 branch of the T branch, but it is difficult in cannulating true lumen vessel artery from the small rupture hole. This picture shows the ascending aorta exposure after we divided the lung and the pericardium. Bilateral inguinal common femoral artery were approached by a cardiac muscle, retrograde angiogram from right inguinal common femoral artery showed the distribution and the communicating hole with bilateral iliac artery. Angiogram inside true lumen showed the ciliary trunk, SMA, and the right renal arteries are also showed the left renal artery from the fourth lumen. After the guide wire runs through from the true lumen into fourth lumen, we use the bud 14 millimeter arterial balloon to dilate the rupture hole. It was like an endovascular penetration. Sorry. We make a two portion sutures over ascending aorta. Two go long flexible sheets, 20 French and 24 branch were inserted into ascending aorta. through aortic arch and to descending aorta. All the Cook shuttle sheaths were also placed inside descending aorta. Sequential target vessel cannulation with external labeling of preloaded guide wires at the ascending aorta sheath, followed by sequential access of the SMA right renal artery and then the last one celiac artery. The reason is that we were afraid that the bigger shuttle sheath or fossiliar trunk would occupy more space. SMA and the right renal artery stent grafts were placed and deployed in the first two steps. The cannulation of the ciliary trunk was only kept by guide wire and the sheath. Due to the sharp angle and the narrow space for ciliary trunk stent graft entrance, we send a stent graft without shuttle sheath protection into ciliary trunk. By ultrasound, we noticed the orifice of the left renal was in the pouch of the fourth lumen. It was very difficult to identify and cannulate the orifice of left renal arch. We come back to CTA image and then notice the orifice of left renal is stenotic and the orientation may be at 4 or 5 o'clock. It spent us about 1 hour to find and cannulate left renal arch. The Cook-Ronson guide wire and the CSI support supporting catheter were inserted sequentially. 4 and 5 balloons were used to dilate the stenotic orifice under the supporting with super stiff guide wire. All the stent grafts used in this case were destined. We cannulate into the short leg of EVA body from the right common iliac artery by snaring the guide wire from ascending aorta because the space of the distal abdomen is too small to expand the short leg of EVA body fully. The final autogram showed the all vessel artery has good flow, but a small 1B endoleak from left common iliac artery. We believe it will be healed gradually, so we manage it with close observation. The following CTA 9 days later showed still contrast extravasation outside stent graft and inside the abdominal true aorta, the true lumen. Two weeks after the T-branch procedure, we repeated another endovascular procedure to treat the 1B endoleak. We got in the gap of the left common iliac stent graft to the abdominal true lumen. We used two 12mm M+ vascular tube plug and multiple pushable coils to embolize the residual abdominal true lumen and the gap. This is the follow-up CTA 1 month after the embolization. The volume of the contrast extravasation had significantly decreased. We would like to repeat the CTA in July, in this July or August. Finally, I have to summarize that there are 3 key points in this case. The first issue is that he had heart transplantation with total arch replacement. The second one is the fourth lumen reconstruction. The last one is the successful use of level use T-branch. Use of the shaft T-branch. As we know, that open repair in this case was impossible, and it admits of no delay of endovascular repairs. Another issue here is that we can rescue this case successfully because of clinical awareness, extensive pre-op operation, pre-operative planning, as well training endovascular surgeons and organizer teamwork. However, it still requires a long period of follow-up. This is our team case. Thank you for your listening.
To share with us these complex cases and give us the insight for the use of the T-branch as a forced lumen reconstruction, and showing your excellent technique in doing these cases. And so we probably leave the question at the end of this session. Without further delay, I would like to introduce the next speaker, Dr. Tsutsumi Oshima. Dr. Oshima has been practicing in Kawasaki Aortic Center for 10 years and has huge experience in thoracoabdominal aortic surgery after conducting over 1,000 aortic surgeries. He is currently the director of Kawasaki Aortic Center. Today, his topic is a conventional thoracoabdominal aortic replacement in largest volume center in Japan.
I am very honored to be able to participate in this Aortic Asia. I'd like to express my gratitude to Dr. Randolph and my senior Dr. Fujikawa. Today, I will be presenting the results of thoracoabdominal aortic replacement at my institution, the Kawasaki Aortic Center. Thoracoabdominal aortic replacement is still fraught with serious complications such as spinal cord injury, severe infarction, and renal failure. Some Japanese institutions are seeking a breakthrough in the stent graft treatment because the results of thoracoabdominal aortic replacement in Japan are not so good as in the West. At our institution, we do not treat thoracoabdominal aortic aneurysms with stent graft at all, but only with open thoracic surgery, striving to improving the result by enhancing surgical techniques. This figure shows the surgical strategy for thoracoabdominal aortic aneurysms at our institution. In Kawasaki Aortic Center, thoracoabdominal aortic replacement surgery is classified into 5 types as shown in the figure above. Most of them correspond to the Crawford classification, but the difference is that we use a similar approach for pararenal artery abdominal aortic aneurysms as we do for thoracoabdominal surgery. Whether to use the 1R or 2R approach depends on the patient's condition. If the patient has more complications, we used to do the 1R, but in recent years we have reduced the number of 1Rs and actively do the 2Rs. One of the problematic complications in surgery for thoracoabdominal extent type 1 and 2 is cerebral infarction due to the atheroma sputtering when clamping the proximal side. Our strategy is to perform total arch aortic replacement and elephant trunk insertion in most cases for safe clamping of the distal arch. Recently, we have also been able to avoid clamping the distal arch by using the circulatory arrest technique in many cases. This figure shows a typical thoracoabdominal aortic aneurysm procedure. At our center, most cases are performed by left heart bypass with blood perfusion to the visceral vessels and cooling water perfusion to the bilateral renal artery. Segmental clamp is performed in 1 or 2 sites. This is a video of a typical thoracoabdominal aortic replacement. A 5th intercostal thoracotomy and established the left heart bypass. The proximal aorta and superior celiac artery were clamped. The aneurysm is removed and a proximal anastomosis is performed. Temporarily interrupt the blood perfusion from the femoral artery to open the abdominal aorta, clamp the distal site and resume femoral artery perfusion. Blood perfusion to the visceral artery and start the renal cooling. We choose a large size intercostal artery with low backflow. Reconstruction is performed as an island with mattress sutures using 3-0 PVDF. And trim the visceral branch from the intimal side to a button shape and then move on to the peripheral anastomosis. A continuous suture is performed, followed by reinforcement with a full round mattress suture. Then visceral arteries were reconstructed. And the surgery was done. Today, I show you the investigation of the results of Kawasaki Aortic Center. The period is approximately 10 years from January 2012 to March 2021. We have performed 4,251 thoracic and thoracoabdominal aortic aneurysm surgeries at our center. Among them, we have performed 693 cases of 1R to 5R treatment by thoracoabdominal approach. In this study, we selected 468 cases of thoracoabdominal aortic replacement from 1R to 3R and investigated them. This table shows the operative patient profile. The mean age was 68 years and 75% of the patients were male. Marfan syndrome was diagnosed in 7.7%, and the patients and diabetes was present in 10%. COPD was also present in 14% and 18% with creatinine levels above 1.5. Those who were on HD were found in 4%, and those who smoked tobacco were found in about half of the patients. As for the aorta, dissection accounted for half of the cases with a mean maximum diameter of 57 mm. Emergency surgery was performed in about 20% of the patients. The following is a summary of the surgery. About 18% of the patients needed to be reduced thoracotomy. Cerebrospinal fluid drainage tube was inserted in almost all the patients of elective cases. Left heart bypass was used in 92% of patients, and circulatory arrest was needed in 3.2%. Visceral branches, perfusion, and renal artery cooling were performed in most cases except for 1 hour. This is a short-term result. In-hospital mortality was observed in 6.2% of patients, including 4.1% who were 30-day deaths. The mortality rate was 3.6% when it was limited to elective surgery. Spinal cord injury was occurred in about 10% of patients, and paraplegia was occurred in 4.7%. When the patients were limited the result of elective surgery, Paraplegia was occurred in 1.5% of patients. Cerebral infarction was occurred in 2.3%, renal failure in 12.4%, and the need for new hemodialysis in 2.8%. Both tracheostomy and reopening of the chest due to bleeding were required in 2.1% of patients. Here are the long-term results. The 1-year survival rate was 90%, the 3-year survival rate was 85%, and the 5-year survival rate was 83.4%. Multivariate analysis was used to identify the risk factors for spinal cord injury. The risk increased with the aging of the patients. The odds ratio was also higher for patients who had a reopening due to bleeding and emergency cases. In addition to age, emergency cases were also a risk factor for worse long-term outcome. A comparison of elective surgery and non-elective surgery showed that elective surgery had a significantly better long-term outcome. In addition, patients with postoperative renal dysfunction had a worse prognosis. Conclusion: contemporary approaches to open thoracoabdominal aortic repair obtained presentable early and late results. Nevertheless, there are possibilities that substantial adverse outcome occurred in patients. We need further improvements our surgical skill in order to treat the elder or high-risk patients in the future. Thank you.
Thank you, Dr. Oshima's your wonderful talk and show us your excellent results in Kawasaki Aortic Center. And the next speaker is Dr. Kei-Yun Park. Dr. Kei-Yun Park graduated from Seoul National University College of Medicine in 1987 and underwent thoracic and cardiothoracic surgery resident trainee in the same university hospital till 1992. And after working in Samsung Medical Center for 10 years, and he moved to Seoul National University of Budan Hospital in year 2005 as the director of cardiovascular surgery. He got a tenured professor position in Seoul National University College of Medicine in year 2012. And now is the chairman of the Department of Thoracic and Cardiothoracic Surgery in SNUBH. And he had numerous publications, and he also held a biennial international meeting called Budan Aortic Surgery Symposium since year 2008, which he performed a live surgery for thoracoabdominal aneurysm repair. And since year 2019, he is acting as a council member and the chief of aortic domain of the Asian Society for Cardiovascular and Thoracic Surgery. His topic today is the patency of branch vessels after thoracoabdominal aortic replacement, implications for the surgical technique.
Hello, ladies and gentlemen. I'd like to thank the organizer of this conference not only for inviting me, but also for making this highly educational meeting possible in very difficult time. In surgical replacement of the thoracoabdominal aortic aneurysm, reimplantation of the visceral branches and the segmental arteries is an indispensable element. There are various options in technical details, and the preference varies among surgeons. The branches can be implanted directly to the main aortic graft or via interposition graft. Each branch can be implanted individually, or multiple branches can be reattached en bloc. In case of graft interposition, we have the options of individual grafting and the sequential grafting. For all above-mentioned options, it is possible to anastomose the branches in so-called Carrel patch or using the inclusion technique. In the earlier days, Direct reimplantation of branch vessels as en bloc inclusion patch has been widely adopted as the standard technique of thoracoabdominal aortic replacements. In the meantime, use of pre-sewn branch graft seems to be increasing in the current millennium. As far as the speed is concerned, the en bloc inclusion patch technique may be the fastest method. The simplest form of thoracoabdominal aortic replacement is reimplanting two en bloc inclusion patches, one for the intercostal arteries and the other one for visceral branches. However, it has some limitations. The first concern is the substantial risk of later patch aneurysm development, especially in the patient with Marfan syndrome. Secondly, the en bloc patch technique is not an ideal technique for some situations. We all know that sequential clamping can reduce the duration of ischemia to the spinal cord and the visceral organs. In case we reimplant the lowest intercostal arteries in inclusion patch and clamp the graft distally to allow perfusion to the spinal cord, direct reimplantation of the visceral branches becomes a little tricky job. And when the visceral branch openings are widely apart, the suture line of en bloc patch becomes long and the risk of bleeding may be increased. Aortic wall calcification and the severe atherosclerosis may make the suture work difficult and increase the risk of bleeding. For severely angulated aorta, a direct reimplantation of branch vessels may cause kinking of the graft or tension on the anastomotic lines. For the above-mentioned scenarios, a branch graft technique may be more advantageous and provides a substantial degree of technical versatility, let alone the fact that it allows earlier reperfusion of the individual branches. Only a small number of studies investigated the patency and the long-term outcomes of branch vessel implantation. In those studies, for visceral branch implantation, graft interposition technique resulted in excellent patency rate. But one thing to be noticed is that there was a 5 to 9% instance of early occlusion of the graft to the left renal artery. The small caliber of the renal arteries causing size mismatch with the interposition graft may account for that. However, considering that occlusion was mostly seen in the left renal artery side, kinking of excessively long graft seems to be the most important cause. It is important to take into account that medial visceral rotation displaces the left kidney quite a lot from its original position. So the left renal artery graft should be cut as short as possible in order to prevent redundancy and kinking. Sometimes crisscrossing the two renal artery grafts may have better alignment with the recipient vessels. For small renal artery, which is the case in dual or as accessory renal artery, and to side reimplantation to a loop-shaped graft may be a reasonable alternative to solve the problem of size mismatch with the larger Dacron graft. In any form, direct reimplantation to the main aortic graft has been reported to result in 80 to 90% patency of the target intercostal arteries. Graft interposition to the intercostal artery has some technical advantages. As I have mentioned already, there is more room for versatility. In addition, it is easy to handle the anastomotic bleeding. Using a pre-sewn branch is less time-consuming because it abbreviates the need of graft-to-graft anastomosis. On the other hand, Using a separated graft allows the surgeon to keep the length of the graft as short as possible, whereas it takes a little longer before perfusing the implanted intercostal artery unless a selective perfusion is provided. On the contrary to the case of visceral branch reimplantation, it is known that 50 to 70% of the interposition graft to the intercostal arteries occluded early after surgery. On the basis of the few published reports, a short perpendicular graft seems to have a little lower chance of occlusion than a long pre-sewn graft. As an effort to overcome the limitations of the technical options shown so far, we are using a different technique. We attach an 8 or a 10 mm graft to the main aortic graft in advance before the aorta is clamped. The intercostal arteries are anastomosed to that side arm graft in sequential manner. The size of the hole made in the graft is around 2 centimeters. The suture technique is basically the same as the individual inclusion cup reimplantation. We use Foger-Prolling running suture for this anastomosis. Carbon dioxide blower is very helpful to perform precise suturing in case the field is obscured by backbleeding from branches. Reimplantation of one intercostal artery takes 5 to 10 minutes. The same step is repeated for the other intercostal arteries. If the graft is clamped between the anastomosis, perfusion of the upper reimplanted arteries can be resumed at earlier stage. With my small hand, handling a 10 mm graft is much easier than handling 26 or 28 mm graft. Actually, after using this technique, it became very rare for us to struggle with the bleeding from the intercostal artery implantation site. As the last step of the main procedure, the sidearm graft is anastomosed to the main aortic graft using a partial clamp to make them parallel. I assume that this anastomosis significantly contributes to improving the patency rate. This is the typical postoperative CT scan. We named this method the frontage graft technique as the parallel service road of a highway is called the frontage road in North America. With this technique, there was no event of postoperative spinal cord ischemia so far. In the postoperative CT scan, the frontage graft was totally occluded only in one patient, and 89% of the implanted intercostal arteries were clearly visualized in continuity with the frontage graft. So I'd like to wrap up this presentation by concluding that en-bloc inclusion patch and the branch graft technique results in equally satisfactory patency of the visceral branches. At least in my experience, branch graft technique has the advantage of technical versatility needed for handling difficult scenarios. On the contrary, graft interposition showed too much unsatisfactory patency rate to be recommended as the choice for intercostal artery implantation. The frontage graft technique may overcome the limitations of the other different techniques. Thank you very much.
Thank you, Dr. Park. And after this two exciting talk on the open aortic surgery, and it's time for us to switch the topic a little bit to endovascular approach. And now we have Dr. Chet Jie, and he's my friend and also my senior. And he is a famous vascular surgeon, fully trained in both endovascular and open vascular surgery. And he performed the first Trimley EVA in Hong Kong in year 2010. And year 2015, and Dr. Jie is first applied endo-anchor in Hong Kong for complicated aortic cases. And he has multiple positions in both public and also private hospital in Hong Kong, and he's very active in his profession. And he was the chairman of the Queen Elizabeth Hospital Doctor Association and also the founder of Young Fellow Chapter in College of Surgeons. And he is also the council member, chief editor of the newsletter of College of Surgeons Hong Kong. His topic today is endo-anchor tips and tricks.
Thanks, Sky, for your detailed introduction. Well, it's my honor to be able to give you the presentation here. I'm being asked to share with you some of the tips and tricks on the use of endo-anchor. I have nothing to declare. The endo-anchor can provide neck stability as good as hand suture and anastomosis by providing extra anchorage. And a number of studies has shown that the endo staple can replicate the function of an interrupted aortic suture as in open surgical repair. And by applying 4 to 6 endo anchor, basically the anastomosis can be as strong as hand suture type. Now, the device comes in thoracic and abdominal system, but most of the published data would be on the abdominal side. The main reason is the endo anchor basically can change the rules of the game a little bit. When we face with this kind of hostile neck aneurysm, we can use the endo anchor for this kind of short, gastrinal, funnel, or angulated neck or wide neck. And we can still use the standard EVA together with the endo anchor and make EVA possible in this kind of hostile neck and minimize the risk of having type 1 endo leak. Whereas in thoracic side, there seems not much this kind of data being published. So my presentation will still be concentrated on the abdominal side. In abdominal aortic aneurysm, when we use endo anchor for EVA, it can provide extra anchorage that can make sealing possible and more durable. The standard use of endo anchor is well described in the company's IFU. What I'm going to present to you is some of the tips and tricks that they haven't mentioned. Now, when we faced with a short neck, can you see my mouse? Not really. Okay. When we faced with a short neck, if we use a standard EVA, we try to land the graft as close to the renal artery as possible. But what happened a lot of time is the video is not. Sorry, the video is not showing. Yeah, but what happened a lot of time is they will have severe type 1 endo leak, and then because of the migration of the graft right after the graft deployment. So what we need to do is we use the endo staple to fix the initial graft first to prevent it from further migrating, and then insert an extension cuff, and then use the second row of endo staple to fix the cuff. That means both the migrated stent graft and the extension cuff will be anchored. Some people will ask, can we use the endo staple to go through 2 layers of graft rather than just rather than using 2 rows of graft? But my impression is the endo staple would have difficulties in going through 2 layers of fabric, and even though it can go through the 2 layers of fabric, it may not be able to penetrate the aortic wall. So I don't think that's a very good idea. So after the cuff being inserted, so with the endo anchor, so completion angiogram show good sealing with no more endo leak. So when we face with this kind of short and gastrinal neck, it's better to prophylactically use the endo anchor to prevent the graft from migrating rather than wait till type 1 endo leak occur and then remedy with a cuff. So the standard use being recommended by the IFU is you deploy completely the graft first and then use the endo anchor to fix it. But this would they would have the chance of having the graft being migrated downward before you use the endo anchor. So what we would do is we would deploy the graft until the short limb comes out, and then we stop. So by that time, the long limb would still be inside the delivery system. That can prevent the graft from migrating further down. And then we will immediately insert the endo anchor through the short limb and then the staple fire to fix the graft. And in that position, you may not have a lot of freedom to choose when to deploy the endo anchor because the delivery system is still inside the lumen, but you just find a convenient position to fix the graft first. And in this case, we deploy 2 endo anchor to fix the graft. This is enough to prevent the graft from migrating down. And then we deploy the main body and then the iliac limb as usual, or even complete the ballooning. And then at the end, we will deliver the remaining staple to fix the graft. And with this technique, we find that we can do it in very short neck or just the window neck cases, and with good sealing and anchorage. In highly angulated neck like this, we do have some tricks to deal with them. Now, ideally, we want to land the main body perpendicular to the center line. But in reality, this is not going to happen because the guide wire and the delivery system would pass through the shortest route. And when we open the graft, the main body would open parallel to the center line and would end up in something like this, with poor sealing and severe type 1 leak. Also, in angulated neck, it's always easy to deploy the endo anchor at the outer wall or the side wall, but it would be hard to deploy the endo anchor at the inner curve because there's a limit on the bend of the steel row sheath, and if too much bending, it can cause breakage. Studies also shown that the best way to deploy the endo anchor is to have the endo anchor 4 to 6 at a circumferential distribution with small distance in between that can provide the best stability. So we should deploy the endo anchor like this rather than just at one side. So when faced with this kind of highly angulated neck, the key move for success is to be able to keep the delivery system as close to the center line as possible. And then in this case, we mark the left renal artery with a guide wire first and then position the graft as close to the renal artery as possible. And you can see the delivery system is bent to follow the curve of the neck. But how can this happen? Actually, we use a trick of using a 16-French long sheath coming from the left subclavian artery. We counteract the pushing force from the delivery system. And then this can align the delivery system along the center line of the graft, of the aneurysm, to form a curve like this. And we call this the S-curve technique, just like the sign of the Tai Chi. So with these tricks, the main body can then deploy perpendicular to the center line and with good sealing and a position to the aortic neck. So we then deploy the suprarenal stent, but still this is a very unstable position, and we use the previous trick of inserting the endo anchor through the short limb and then fire the staple to fix the graft first. And then for the inner curve, since the 16-French sheath is still at the left subclavian artery, and then we can put the endo anchor from above through the subclavian artery, and the approach would be very direct to the inner curve without any problem. So this is the end result. By deploying graft like this, there's good apposition and anchorage, and with good result. And we have done this case a couple of years ago, and up to now, it's already almost 4 years, and with no endo leak and no graft migration. We don't did this technique very often, only in highly angulated neck case. And recently we have done another case like this, and also with good results. But there's also downside because we need to go through the subclavian artery with the 16 fan shift, so it can cause dissection of the subclavian artery, as in this case. But luckily, it was silent. For all these cases, we need a contingency plan. Sometimes we find that the neck is too short for us to do the standard EVA, so we will just proceed to chimney EVA. So in conclusion, endo anchor can make hostile neck still suitable for EVA, and it can provide extra anchorage and make sealing possible and more durable. But when the anchorage and sealing is not really possible, then we move the graft further up to cover the renal artery, and then it's the time to use fenestrated EVA and chimney EVA, but the chance of needing this technique would be less. Thank you.
Thank you, Dr. Jie, for your excellent presentations. And now we leave the question at the end, and it's time to introduce the next speaker, Dr. Masaki Kato, and he is the consultant in the Department of Cardiovascular Surgery, Morinomiya Hospital in Osaka, Japan, and he is specialist in the field of aortic dissection and aortic aneurysm. And he is also the original developer of frozen elephant technique and TIVA for aortic dissection. And his talk today is penetrated and branched TIVA for thoracoabdominal aneurysm and dissection.
Thank you, Chairman. Today, I will talk about fenestrated branched TIVA for thoracoabdominal aneurysm or dissection, TAAD. The author declared no conflict of interest associated with this work. Open repair is a classical standard treatment of TAAD, but it has serious disadvantage of being extremely invasive. In order to reduce the invasiveness of open repair, hybrid repair, a combination of reversed bypass for visceral arteries and TIVA, has been developed. However, it also has a serious disadvantage of requiring laparotomy and risk of long bypass occlusion. Fenestrated branched TIVA is in the process of widespread use along with the development of its device, and due to its minimally invasive nature, it is expected to become a standard treatment for TAAD in the future. However, there are few reports on the mid to long-term result of this treatment. The purpose of this study is to clarify the acute to mid-term outcomes of fenestrated branched TIVA and identify the future problems in endovascular treatment of TAAD. Patients were 93 cases, mean age was 71, and dissection included in 40. This slide shows the anatomical Crawford extent of aneurysm. 12 patients is extent 1, 23 in extent 2, 28 in extent 3, 30 in extent 5. Patients of extent 4 were excluded for this study. This slide shows patient profile. Most characteristic profile is history of aortic repair. 68% were redo operation, and 81% were referred by profession of vascular surgery because our institute is the shelter for patients with complex aneurysm in West Japan. Most of the main body devices have been developed, have been ordered to Cook, and custom-made devices were prepared. In 16 patients, surgeon-modified devices using Cook TX2 were prepared on the table. In the planning of device order, if there is working space in the visceral branch area, a branched device is selected. If there is no working space in the visceral branch area, fenestrated device is selected. In our series, fenestrated device were used more frequently than branched device because we treated many aortic dissection and we have had intention of minimizing the covered extent in order to avoid the spinal cord injury. Spinal drainage was inserted preoperatively in 81 patients. Our criteria for preoperative insertion of spinal drainage are shown in this slide. This slide shows a typical case of total endovascular treatment for TAAA. A patient was a 68 years old man with Crawford type 2 thoracoabdominal aneurysm. And right common iliac artery and bilateral internal iliac artery were completely occluded due to his thrombus AAA. Because he was a Jehovah's Witness, he could not receive conventional open surgery. He decided to receive total endovascular treatment. First, we tried to recanalize his occluded right iliac artery, but it was impossible. Reluctantly, we decided to treat him with 4-branched device. We inserted the main body via a left femoral artery. For bridging stent graft, we always use Atrium Advanta or Goa, Viavan, or VVX. This slide shows pre- and post-operative CAT scans. Thoracoabdominal aneurysm was completely excluded by branched device. And all 4 visceral branches were patent and bilateral leg circulation were no change. This slide shows 3 types of device to treat TAAD. 44 patients were treated with fenestrated device. Most of dissection cases were included in this group. 11 patients were treated with branched device and 38 patients were treated with fene and branch combination device. Device selection will depend on their anatomy. This slide shows Crawford extent of graft covering in this series. In endovascular treatment, covering extent was wider than anatomical extent because of needing for landing zone. Crawford type 3 is majority in the graft covering extent. And lower row shows Crawford extent of graft covering in this series plus a previous operation. In our series, there were many redo patients, 68% of all. Total covering extent become more wider with previous operation. Crawford type 2 was majority in this series plus previous operation. The bridging stent graft patency was obtained in 99% of the branches except 4 branches. However, these 4 occluded branches and the 6 branches that were dissected or otherwise compromised intraoperatively did not supply sufficient blood flow, which often lead to acute complications such as ischemic colitis and acute renal failure. Type 1 and type 3 end leak were treated with re-intervention except 3 cases. This slide shows the mortality in acute phase. Within 30 days, deaths were occurred in 2 patients. One was multiple embolism, including brain, resulting MOF. Hospital deaths were occurred in plus 4 patients. 2 were malperfusion of visceral branches, resulting ischemic colitis, ARF, and MOF. This slide shows the morbidity in acute phase. Spinal cord injury occurred in 8 patients in this series. All cases were paraplegic, but half of them had sensory disturbance, suggesting that the cause of spinal cord injury was due to emboli. 3 of the patients recovered to almost the same condition as before TIVA with appropriate treatment and rehabilitation. Ischemic enterocolitis, ARF, and acute cholecystitis occurred frequently in patients with failure of visceral branch reconstruction. This slide showed survival in this series. In all-cause death-free survival, 3 years survival was 76%, 5 years was 65, and 8 years was 36. In aneurysm-related death-free survival, 3 years was 89. 89. 5 years was 86, and 8 years was 54. The aneurysm-related mortality for fenestrated branched TIVA is poor compared to that of simple TIVA or simple EVAR. When we examined the specific reason for the 8 aortic aneurysm-related deaths, we found that 3 were stent graft infection due to aortic esophageal fistula. 1 was a thoracoabdominal aortic aneurysm rupture due to type 3 end leak. 2 were aortic aneurysm rupture in no target region. And 2 were sudden death at home. This slide shows conclusion of my presentation. The acute outcome of total endovascular treatment for TAAD is not related to the covering extent of stent graft, but depend on the performance of the bridging stent grafting and intraoperative multiple embolism. The chronic outcome seemed to be strongly related to the end leak associated with the bridging stent graft and end leak related aneurysm enlargement and wall inflammation. In order to further improve the result, we believe that simple and durable bridging stent grafting is the most important. Thank you for your attention.
Thank you, Dr. Keto. May I now have Dr. Leung to introduce our next speaker? Dr. Leung, please.
The next speaker in the program is Dr. Yin Chang from Taiwan. He did his medical education at the Chinese Medical University in Taiwan. And after graduating, he received his medical training in the National Taiwan University, and eventually, and the present position is a visiting staff at the Zhonghua Christian Hospital. His special interests include minimal invasive surgeries and robotic surgery for aortic patients. Dr. Yin?
Dear organizer of the Aortic Asia and the participants, I'm Dr. Chen from Zhonghua Christian Hospital, which is one of the medical centers in Taiwan. Today I'm going to present you a case of mycotic aortic aneurysm that involves 4 vessels treated with TIVA procedure. We report a case of 76 years old male patient. He presented with low back pain and fever for 5 days. His blood culture at local hospital showed some metastasis, and the antibiotic was used for days, and then transferred to our hospital for management. His blood culture in our hospital showed cultural negative infection. This is the preoperative abdominal CT angiogram. We can see the juxtarenal pseudoaneurysm. And then the infection thrombus was upward, extended to the level of cell trunk. We consider several options for treat this patient, including open surgical repair, penetrative, T-branch, or total TIMI. We don't choose the open surgical repair due to high surgical risk. The custom-made penetration endograft need waiting for preparation. The surgical anatomy is not suited for T-branch. Therefore, we chose the total TIMI TIVA procedure for treat option. The decision of choice EVA for this patient is also supported by the recent Swedish multi-center study, including 132 patients, has reported higher early survival rate of endovascular treatment compared with open surgery, without higher incidence of infection-related complications or reoperation. The size of stent graft are selected based on CT image. We can see the suprarenal aorta is 28 mm in diameter. We select the 36 mm endurance, which is around 33% oversizing. For the visceral branch, we select Biobond because we think the flexibility is an important factor. In addition to the LT stent graft and the cover stent, there are accessories that I think are critical for every Chiba procedure, including shuttle sheaths and the Rosen wire from Cook. For the oversizing, in this case we use 33% oversizing, and is aligned with the recent publication shown here, which show that at least 30% is required for Chiba, in contrast to previous report which recommend a range of oversizing between 20 to 30%. This is the intraoperative aortogram showing inadequate sealing zone. Therefore, we chose the total Chimi endograft procedure. We can see the huge pseudoinner. We can see the final aortogram. There is no endo leak and the preserved full vessel branch with good flow. For the mycotic LT aneurysm, I think most concern is infective-related complications, so antibiotic treatment is very important. The AHA recommends 6 weeks to 6 months, while ESVS recommends 6 to 12 months, or even lifelong. In our hospital, we use antibiotics for at least 12 months to lifelong duration. This is the follow-up image of the patient after 18 months. We can see there is no endolegal migration. The Chimi grafts are patent. In addition to the single case presentation of our hospital, here I would like to share with you a publication last year in Annals of Vascular Surgery, which included patients with mycotic LT aneurysm treated with Chiba. A total of 16 visceral vessels are involved. Selection of paralyzed stent graft, including Biobond, Aventa, and the VVX. In this study, the mean follow-up was 8 months. During this period, 2 patients expired, one from an aneurysm-related cause, no stent occlusion, and no reintervention due to endo leak. No patient required explantation of the stent graft or conversion to an open surgery. The author concluded that Chiba is a feasible and safe treatment modality for mycotic abdominal aneurysm involved the vessel segment. Yet, the author also mentioned that the intentional occlusion of selective vessel artery may be required to minimize the risk of gutter endo leak in this urgent setting. Lastly, I would like to share the recommendation from the SBS, which also suggests that paralyzed stents are an authoritative endovascular strategy in urgent or emerging complex EVAR case. For the selective of cover stent, SBS suggests balloon expandable for penetration strategy and the semi-expandable for branch or Chimi strategy with tortuous anatomy. Thank you for your listening, and I wish we can meet in person soon.
Thank you, Dr. Yin, for the interesting topic, the interesting presentation. The next lecture is by Professor Glenn Tan from Singapore. The title is A Lesson for Custom Endograft in Thoracoabdominal Aorta. Glenn is presently the head of the service in endovascular and endovascular surgery in Tan Tock Seng Hospital in Singapore. He received his surgical training in Singapore, and proceed to his vascular training in UK and Australia. His special interest is complex endovascular aortic aneurysm repair. Glenn?
Good afternoon. My topic for today is lessons for customized endografts in the thoracoabdominal aorta. I'd like to thank Professor Stephen Cheng and the organizing committee of Aortic Asia for the invitation to share our experience. This is where I work in central Singapore. Tan Tock Seng Hospital is a tertiary hospital with 1,600 beds. I declare I've got no conflict of interest. In Tan Tock Seng Hospital, we've done more than 80 customized endografts, of which 20% are aortic arch interventions and 65% are for juxtarenal and pararenal aneurysms. We primarily use the Cook Medical platform, but we do use other devices such as the Vascutech Anaconda device. We feel that each device has its own advantages. For this device, they can customize fenestrated valleys, which means we can reduce the number of fenestrations to be able to achieve the seal that we want. In this case, you can see that we managed to cradle the left accessory renal artery in the valley of the device. We also use a Terumo aortic potent device. We customize a distal reverse scallop for this thoracic aortic saccular aneurysm at the level of the diaphragm itself. This to augment the distal seal zone to reduce the chance of a type 1B endoleak. We also use the CryoLife Aortec graft in this patient with a very short neck diseased with thrombus. We decided to use this because his iliac vessels were very small, between 6 to 7 millimeters. Aortec was able to customize this device on a 20 French delivery system with an outer diameter of 6.7 millimeters. In this case, we customized a 2-vessel fenestrated EVA with a scallop. And this device is unique in the sense that you could come from above to gain access to your visceral vessels even with the device partially deployed. In this case, we could get the renal artery from above, and once you deploy the device fully, you can always come from bottom to get the other visceral vessels as well. In our experience, almost 70% of the cases involve 3 or more fenestrations. We also do not stent the C-lap fenestration in most cases. More than 90% of our C-lap fenestrations are left unstented unless they are involved at the level of the aneurysm itself. Over a median period of 38 months, we have seen no celiac artery occlusion or malperfusions in those that we have not stented. We know that over time, there's a propensity for the enlargement of seal zone in any fenestrated EVA, and so we always feel that it is better to plan for more fenestrations if required so that we do not run into problems with the future endoleak. And this study from Dr. Eric Verhoeven's group in Nuremberg in Germany has shown that 3 and 4 vessel fen EVA is not associated with increased perioperative mortality or morbidity. So our aortic philosophy is to try and seal from normal to normal. We always strive for a clean aortic wall of at least 20 millimeters in length, and the distal seal zone that is healthy as well. And we always try and preserve the internal iliac arteries if we can. We always make sure that we plan for future intervention, and we do regular surveillance for patients with aggressive reintervention if required. We also assess each patient very carefully, and in patients with limited life expectancy, we would usually decline treatment. And this looks like a very nice, deceptively long aortic neck. There are many options for this patient. However, we always feel you should look at the entire aorta before deciding what we should do for this patient. Look at this patient, you assess the thoracic aorta. There's been some ectasia and some saccular aneurysm over there. And then you look at the seal zone as well around the juxtarenal area. You see this aortic bulge, and I think it's very important to look at the aorta in all 3 planes if you can, sagittal, coronal, and axial. And if you look very carefully, sometimes you can miss something like this, a posterior bulge. In this patient, we end up doing a 4-vessel fenestrated EVA, and we leave 1 to 2 stents above the celiac fenestration to allow for future proximal extension. You can see we've done a multi-layer flow modulating stent for the penetrating ulcer in the thoracic aorta, and if this fails, we can always extend more proximally to seal this off. We apply the same principles to physician-modified endografts. When there's a patient with a mycotic aneurysm at the level of the SMA, you can see his left kidney has already been compromised. In this case, we decided that this patient needed a right renal chimney and 2 fenestrations that were fashioned back table, as this patient had some pain and there was no time to customize an endograft. We used a TX2 thoracic stent with no top cap, so this was easy to unsheath. create the fenestrations, and then resheath the device again later. After deploying this device, we had a good seal from this. However, this patient came back several years later with some back pain and more fever with the recurrence of the mycotic aneurysm. We were thankful that we left one sealing stent above the celiac fenestration so that we could extend with a thoracic stent to achieve a seal for this patient. And we were lucky in this case to be able to get away with this. We also decided to optimize the overlap zone with some endo anchors to prevent any stent separation in the future. You can see that the endo anchors have taken very well in this case. And this patient had no problems after 3 years without any recurrence of the mycotic aneurysm, but he remains on antibiotics for lifelong. And this is another patient with a very ectatic seal zone. It's about 32 millimeters in diameter around the juxtarenal area. And we were planning to use a 38 millimeter fenestrated EVA. But we felt that this is probably not durable in this area. And if anything bigger than 36 millimeters, we always try to look above for any proximal seal zone. When we look in the thoracic aorta, we see that there's some ectasia as well in the mid-descending thoracic aorta, and we have to find a seal zone higher up. And so we planned for a customized TIVA tapered from 30 to 30 millimeters, as well as a fenestrated EVA below that. And this was so that we can create a proximal landing zone to ensure that we get a durable seal for this patient. How about any strategies for angulated necks? We always believe you should land in the straight part of the aorta rather than the angulated part of the aorta. In this case, if we had done a fenestrated EVA without preload catheters, once we deploy the device fully, you'll find that you'll not be able to maneuver this anymore if the fenestrations are malaligned. So in this case, we decided to preload catheters. We used the device on the left because it was able to be delivered in 20 French sheath. In this case, when we do angulated necks, we always partially deploy the device. We come from above with preloaded catheters to get to the visceral vessels before we fully deploy the device. You can see that the catheters come through the trifold of the device so that we can get into the renal fenestrations and get to renal arteries itself through that. And once we've unsheathed the device fully, we come from below to get the SMA. And in this patient, he has very hostile visceral anatomy. If you look at all the visceral vessels, there's osteostenosis in the SMA, the right renal and left renal. And there's also a very, very narrow aortic lumen at the juxtarenal area. And the lumen goes down to almost 13 to 19 millimeters. And we felt in this case, we had to pre-stent the visceral vessels before treating this patient, or else we would run into trouble. We pre-stented, we planned for a modified preload with a bipod handle. This allows us to come and get the fenestrations from below through the main body device itself. So we left preloaded guide wires in the left renal artery and the SMA. But because of the narrow lumen, we decided that we had to chimney the right renal artery instead. And you can see we came from above to get the right renal artery, and we've got our V grafts in the left renal artery and the SMA, and this is what it looks like after we've deployed the entire system with the B grafts in place. And this is another patient we had with a very short angulated neck with a type 1 endo leak on table when we deployed a conventional device. This was solved with aggressive balloon molding, and we managed to get the patient off table without type 1 endo leak. But over the next 3 to 4 years, he had widening of his aortic neck and change in the aortic neck morphology, and increasingly he was losing his proximal seal zone. We thought we could arrest this by applying some endo anchors, but this over time the sacs had continued to grow in size, and so we decided this patient needed relining of the old endograft. When we reline old endografts, we tend to reline with a bifurcated graft rather than a cuff alone. We feel that a bifurcated endograft will give this patient a more durable repair, because over time, if you just use a fenestrated cuff, it might separate over time. But to do a bifurcated graft, we need to use an endograft with a special customized inverted limb so that we can seal the iliac limbs within the inverted limbs. But you need to be careful not to crush the lowest renal fenestration stent when you are introducing the iliac limbs. And this was us after we've completed the fenestrated EVA. We also feel that in fenestrated EVA, it's important to preserve as many internal iliac arteries as possible because there's often long segment aortic coverage in FEN EVA. This can result in a high risk of spinal cord ischemia as well as large bowel ischemia if we lose both internal iliac arteries. This is a patient that has a large aneurysm with the left 3.7 cm CIA aneurysm. And we felt that there was some thrombus in the proximal seal zone, and that's why we opted for 4-vessel fenestrated EVA and a left iliac branch device. In this case, we do always the fenestrated juxtarenal component first before doing the iliac branch device. We deploy the whole device first, and then we deploy all the bridging stents before bring out the delivery system and then doing the iliac branch device. You can see this patient is a very short 3.5 centimeter common iliac artery aneurysm, almost borderline for IBD. And we had to push the device up a little bit so that we could deploy the branch, and then we come from crossover to get the internal iliac artery. And this patient had a fairly good result with this repair. But not all Asian patients have such long iliac arteries. A lot of Asian patients have got short common iliac arteries, and this patient, you can see that he's got a common iliac artery that is about 1.6 centimeters length. And we again use fenestrated EVA at the top because it's a juxtarenal aneurysm. We do the fenestrated EVA component first before going on to the customized iliac limb. This is a fenestrated iliac limb, and we come from the ipsilateral side to get into a fenestration, and then we stent it with a balloon expandable covered stent. And this patient had a good result after 3 years without any recurrence or any endo leaks. We also use this fenestrated iliac limb with the Cook platform, and again we always deploy the fenestrated component in the juxtarenal region first before going on to do the iliac fenestrated limb. And in this case, we came from the crossover approach to secure the right internal iliac artery first in case we malalign the stent and we can still have access to embolize it. But in this case, we're fortunate to be able to get in from the ipsilateral side into the internal iliac artery. And once we've done that, we again placed our balloon expandable covered stent in to bridge between the iliac fenestration and the internal iliac artery. And we need to also be aware that a lot of patients in Asia have got a very small iliac access. This is very common in females as well as patients with high arteriosclerotic burden. And this is the most heartbreaking angiogram anyone can encounter. A patient on table with iliac rupture, usually easily solved with a Viaban. In this case, we always try to plan our fenestrated EVA with low profile fabric as it brings down the sheath size by 2 millimeters, 2 French. We also plan to do a iliac conduit if we are not able to get the device up through the external iliac artery. And in this case, we always use a 10 mm Dacron graft to sew onto the iliac bifurcation to get the endograft up into the aorta. We must be also very, very vigilant when we do our final angiogram, because you can see visceral complications that sometimes may present quite late. In this case, this patient had a right loin pain after EVA, but we realized that actually on the final angiogram, there was a hint of some extravasation of contrast. This patient had to be returned to the operating theater for coembolization of the renal artery branches. It can happen to SMA as well. This patient had pain post fenestrated EVA, and we did a CT scan which showed some mesenteric hematoma, and this patient required a return to operating theater for coembolization. When we get severe abdominal pain out of proportion to examination findings after fenestrated EVA, we always worry about any perforation or any ischemic bowel because of occlusion of the SMA. And it's very important to always do an early CT if we suspect such symptoms. Over follow-up, we also need to look very carefully at CT scans. This patient had a bridging stent fracture 2 years post-fenestrated EVA. We always look at all the integrity of the bridging stents to ensure that we're not missing anything, and this patient required relining with a balloon expandable covered stent. So in summary, ladies and gentlemen, low profile fabric can be useful to reduce the sheath size and groin complications and spinal cord ischemia, especially in Asian patients where they have very small iliac arteries. We believe that preservation of internal iliac arteries are important in complex EVA. We also feel that preloaded catheters can be very helpful in angulated difficult anatomy, so you can come from birth to get the fenestrations, and we ensure adequate proximal seal leaving room for future intervention. We do not compromise the number of fenestrations. If we need a 4-vessel fenestrated EVA to seal this patient's aneurysm, we always do that. And when performing redo EVA, we feel it's ideal to reline the entire endograft. We also feel that stenting of the celiac artery fenestration can often be avoided if there's good apposition between the endograft and the aortic wall. I'd like to also thank my radiology colleagues as well, who are a big part of our aortic team. Thank you for attention.
Thank you, Glenn, for sharing your experience with us. It's very interesting. The next speaker is Professor Jian Dai from Xinjiang Medical University. Professor Dai is currently the director and the chief surgeon of the vascular surgical department. He did his postdoc fellowship in the South Carolina and University of Kansas, and have been visiting scholar at the Leipzig in Germany, as well as in Stanford University in USA. The title of his talk today will be On Table Fenestration for Thoracoabdominal Endograft, the China Experience.
Good afternoon, ladies and gentlemen. I'm Xiangchen Dai from Tianjin Medical University General Hospital. My topic today is on table fenestration for thoracoabdominal endografts, the China experience. It's my disclosure, I do not have any potential conflict of interest. The major difficulty while treating TAAA is how to revascularize the visceral arteries. The choice of treatment is related to the morphological classification of aneurysm. Because of different anatomic conditions, true aneurysm, pseudoaneurysm, and dissecting aneurysm should have different treating strategies. The treating strategy include open surgery, hybrid surgery, and endovascular surgery. The open surgery is classic method to treat TAAA, but it have to face the huge injury to the patients. So only the young patients with good general conditions can be performed these methods. Hybrid surgery is a less invasive method compared with the open surgery, especially during some urgent conditions. For some difficult cases, well, revascularized renal arteries, vortex technique can be used by using cover stent grafts. But hybrid surgery also causes some large injury compared with the endovascular methods. According to the different anatomic characteristics, there are lots of methods for endovascular treatment in clinic, such as local sealing, fenestrated EVA, branch EVA, octopus techniques, multi-layer fluid modulator technique. At present, fever and beaver show an advantage in clinic gradually. It's an example for dissecting aneurysm. We designed to use the fenestrated endograft for these patients. Because of the limitation of the custom-made endografts in China mainland, we have to modify the stent graft by ourselves. So we made these feature-modified endografts from the standard Cook-Zini thoracic endografts. This is a full fenestration, and this figure shows the diameter reducing device. By this PMAC, all aneurysm has been excluded entirely, and the patency of all visceral artery is satisfactory. And this is another example for dissecting aneurysm. Because the true lumen is too narrow, there is no enough space to deploy the stent grafts. So the converting technique have to be used to merge the true and false lumen into one lumen. A full PMAC with full fenestration was designed, and firstly, we deployed the procedure of cheese wire technique. The guide wire and the catheter was advanced from true lumen into the false lumen through the tear around the level of renal artery, and then go back to the true lumen in the distal aorta through the tears. And then we pull down the wire and the catheter until it reached the distal aorta. From the angiogram, we can see the occlusion of distal aorta. It means the intima has been teared into the distal aorta. After that, the PMAC with full fenestration was deployed successfully. And then the proximal and distal cover stent were deployed step by step. This is the final angiogram. We can see the aneurysm has been excluded entirely. All visceral artery keep good patency. This is the result of follow-up. This is another example for pseudoaneurysm. From this figure, we can see the aneurysm located at the contralateral position of visceral arteries. So we designed a PMAC with two fenestration to revascularize SMA and celiac trunk. This is the result of follow-up. The aneurysm has been excluded entirely, and celiac trunk and SMA keep good patency. And this is another example for true aneurysm. A PMAC with full fenestration was used for this case. From the result of follow-up, we can see there are weak endoleak around the ostium of celiac trunk. We think about the reason is the celiac trunk is open at the aneurysm body, so there are type 3 endoleak happen. So for another cases, we designed the PMAC with 3 fenestration and 1 inner branch. And after deploy the PMAC, the aneurysm has been excluded entirely, and all visceral artery keep good patency. This is the result of follow-up. All visceral arteries keep good patency, no any endoleak. We also try to use the branch PMAC to treat TAAA. Full whalebone were sutured to the short leg and body of endografts and deployed successfully. This is the result of follow-up. The aneurysm was excluded entirely. Celiac trunk, SMA, bilateral renal arteries keep good patency. This table shows the general information of TAAA in my hospital. 11 open surgery, 3 hybrid surgery, and 25 endovascular surgery. More older patients were treated by endovascular surgery. More type 2 and 4 TAAA were treated by endovascular surgery, and more type 3 and 5 TAAA were treated by open or hybrid surgery. FIVAR or BIVAR were used for 90% of true aneurysm, 60% of pseudoaneurysm, and 50% of dissecting aneurysm. From the data of intraoperative period, there is no difference in operative success rate, mortality, and morbidity among 3 groups. Amount of bleeding and duration of operation in endovascular group is less than the other groups from data of the POD30. The mortality of hybrid group is higher than the other groups. The morbidity of endo group is less than the other 2 groups. There is no difference in intervention rate among 3 groups. This is the result of follow-up. There is no difference in mortality and reintervention rate between open group and the endovascular group. The morbidity of endovascular group is higher than that of open surgery. So finally, we get take-home message. Endovascular repair for TAAA is the better choice for older patients. PMAC is an alternative customer-made stent graft for TAAA in urgent condition. The technical success of PMAC depends on precise measurement, preload guidewire, the emitter reducing device, and scapy technique. Thanks for your attention.
Thank you, Professor Dai. The next speaker is Professor Eric Van Hoven. He won't need much introduction. He's quite well known to us, having given a lot of lectures in this region as well. Professor Van Hoven is currently the chief of the Department of Vascular and Endovascular Surgery in the General Hospital of Nuremberg. He was born in Belgium, received his schooling in both Germany and France. He went to medical school in Belgium and did his postgrad training in the Netherlands. And now he's currently, back in Germany, in Nuremberg. The title of his talk today is it always needed to stent the celiac artery in the 4-vessel fan EVA?
Good afternoon, and thank you very much for allowing me to present this work. I would obviously rather be in Hong Kong with you, but I'm going to tell you how to do 4x fever without stenting the celiac artery in selected patients. My disclosures are well known. I work with Cook since more than 22 years, and I also added the companies that provide us with the bridging stent grafts. So when we talk about fenestrated EVA, we discuss to find a sealing zone above the renal arteries and to add fenestrations as needed. Now, if you look at 4x fever, it's obviously the most extensive repair, but it could present with a number of advantages. First of all, you create a longer sealing zone. Maybe you find some healthier aortic wall, and this may all lead to a more durable repair. And if you have a patient with also diseased thoracic aorta, it would be much easier to extend at a later stage. I must tell you that 2x fever in our hospital has virtually become obsolete, and we always choose between 3x or 4x fever. The problem with 4x fever is that it is the most difficult procedure because you have 4 fenestrations, and sometimes the celiac artery is a more difficult vessel to catheterize and to stent. In addition, the celiac artery is subject to the respiratory motion and the movement of the median arcuate ligament. And if you would do this without stenting that celiac artery, so just drop a fenestration in front of the celiac artery in case you have sufficient sealing zone, you could imagine a number of advantages. Obviously, you reduce the complexity of your procedure. You may also reduce the duration the radiation and the use of iodinated contrast. And finally, in using one stent less, you slightly reduce the costs. So we came up with a new strategy for the juxta and suprarenal aneurysms that we wanted to treat with 4 fenestrated grafts. So this is the algorithm. First, you look at your sealing zone, your neck. You need a neck between the SMA and the celiac artery. If you don't have that, obviously, you have to stent your celiac artery to avoid an endoleak. But if you do, you could plan this patient not to be stented with regards to the fenestration of the celiac artery. Then you discern between the patients that have a nice and easy celiac artery and the patients that have a difficult celiac artery. If you have a difficult celiac artery, you don't catheterize it, you don't stent it, and you just let the fenestration drop in front of the celiac artery. And in view of the fact that you have a fenestration for the SMA and that SMA will be stented, that 8 mm strut-free fenestration should fall into place. If you have an easy catheterization, you catheterize it, you put a stiff wire in the celiac artery, and after you stented the other 3 fenestrations, you use that catheter to do a lateral angio, and you look whether there is a good perfusion and no endoleak. If this is the case, you don't need to stent your celiac artery. If this is not the case, you have to stent your celiac artery. Let me show you 4 case examples. This is the first example with a patient without a decent landing zone. In other words, you have to stent your celiac artery to avoid an endoleak. And this is the end result in this case. This is a second case where we decided that the steep takeoff and the stenosis in the celiac artery didn't justify catheterization. So we treated this one as a triple fenestrated graft, and we landed, and in the end the celiac artery remained nicely open and we had no endoleak. As you can see in the image on the left, this was a repair of a previously failing anaconda. This is a third case where we had a celiac artery that deserved catheterization, even if it was fairly steep. We catheterized it, we did the lateral angio, and this is the angio of the celiac artery with a wire still in the celiac artery. And this showed a beautiful perfusion, a beautiful position of the fenestration, no endoleak, so we decided not to stent the celiac artery. And this is the final case, fairly similar actually. And here at the end, our angio showed not a good perfusion. So we decided to still stent that celiac artery. And this was the end result in this patient. So all in all, we reviewed all the patients in which we applied this treatment algorithm. There were in total 48 patients, 46 males, and a number had previous open triple air repair or previous EVA. These are the 2 main groups. For primary stenting, 17 patients, 35%, and patients not or planned not to be stented, 31 or 65%. And this is the interesting group, of course. So we had 14 with difficult catheterization where we just let the fenestration fall into place. We had 17 with easy catheterization that we all catheterized and all checked. And of those, 13 were fine and 4 were not and were still stented. So 3 because of inadequate perfusion, as shown in the one example, and 1 because of an endoleak. If you look at the intraoperative parameters, actually the unstented celiac artery patients required less contrast volume. They also had shorter mean operative times and fluoroscopy times, but these 2 parameters didn't reach statistical significance. The results were very good. In 47 out of 48 patients, we had 1 renal artery failure. Unfortunately, we had no open conversion, no spinal cord ischemia at all, and no mortality in the first 30 days. During follow-up, we had not a single celiac artery-related endoleak or reintervention. We had no aneurysm-related deaths, but we had 2 celiac artery occlusions out of 48. Interestingly, they were both in the group where the celiac arteries were planned not to be stented, neither to be catheterized. So there were both very ugly celiac arteries, and in the end, they occluded without symptoms. The estimated primary patency of the celiac artery at 12 months was 97.1%. So to conclude, 4 times FIVA without stenting of the celiac artery in selected cases seems an acceptably safe and effective strategy. And in our series, in more than half of the 4 times FIVA patients, it was possible not to stent the celiac artery. Thank you very much for your attention.
Thank you, Professor Van Hoven.
So, Dr. Lam, we now come to the discussion session, but because we have overrun a little bit, probably we only got about 5 minutes or so for discussion. But before that, I would like to invite all the speaker and moderator to look at the camera to take pictures before we start our discussion. And please smile at the camera, and I count down for 3 seconds. 3, 2, 1. Oh, can we do that again? Because I just saw Dr. Park is coming again. So, okay, ready? 3, 2, 1. Okay, maybe we can start by a question. Any question from the panel? If no, may I first start the question to Dr. Jie. Thank you for sharing with us about your special tricks on doing the endo anchor. Just wondering, because you said you will not fully deploy the stent graft before putting in the first field anchor. And I'm just wondering, because sometimes the short neck is rather narrow, and we worry about the infolding of the stent graft once upon deployment. Will you consider to do the first, when you consider to put in the first field anchor, will you put in the balloon for molding before doing the anchor, or you still just put the field anchor first and do the rest?
In short neck cases, I would, before, as I described, once the short limb comes out, I would stop deploying the graft so the long limb would be still in the delivery system. That can make the graft more stable. And at that moment, I would deploy the first few endo anchor first. This is to stabilize the graft and prevent the graft from migrating. I would not do the ballooning at that moment, because we find that if you do ballooning, in short neck cases, it can cause the graft to migrate down immediately. It's very easy. So that's why we would deploy the first few endo anchor, stabilize the graft first. And then at the end, when we fully deploy the main body and the iliac limb, then we would do the ballooning first, and before we deploy the subsequent endo anchor. Yeah, and then those endo anchor would be the graft being molded to and then with good apposition to the aortic wall.
Okay, thank you, Dr. Jie. Any questions from the panel?
I have one question to Dr. Park.
Yes.
From Kawasaki Aortic Center. So we shifted the position of the artificial vessel downward from the original position of the abdominal branch, and anastomosis the abdominal branch to prevent it from kinking. In the retroperitoneal approach, the left renal artery is most at risk of occlusion. What is your opinion on this prevention from the kinking graft? Please let me know.
Actually, I don't think there is just one solution, but in my experience, my preference is to put the grafts, the branch graft position a little higher than the recipient position, so it can, so the result is like the branch graft taking the downward course, slant course. But even with that, the left renal artery is a problem. So maybe the Coselli graft, which is the mostly used graft, is I don't like that design because the left renal artery respect the original position, but in surgical field, it is vulnerable to be redundant. So if you are really worrying about that possibility, you may put a separate left renal graft taking a little bit higher from the main graft.
Okay, so you put the graft branch to higher position from original position. So how about the downward? I make the cellular branch downward from original site.
You mean that it takes upward?
Yes. Yes.
I don't have such experience because I always try to keep the main graft as short as possible. So always the branch takes the downwards. I mean from up downward course.
Oh, thank you very much.
And my question to Dr. Oshima is, do you have any experience with doing the drop abdominal after previous proximal TIVA or frozen elephant trunk? So how do you treat the proximal anastomosis? Do you make the proximal anastomosis too close to the left subclavian artery, or do you leave the proximal excluded portion alone?
Yes, we have a lot of the track of the aneurysm enlargement for the lumen after TIVA or after frozen elephant trunk. So most of the frozen elephant trunk we can anastomosis directly to the frozen elephant trunk. So that is not so problem. But the TIVA is have some trouble of the thrombosis around the stent graft. So in that case, we mostly use the hypothalamic cyclic acid and remove the TIVA stent graft, and anastomosis to between anastomosis to arch between the subclavian artery and the carotid artery with using circulatory arrest.
I would like to ask Professor Verhoeven about this. Your angiogram to determine whether your final angiogram to determine whether you will stent the celiac. You already have a wire in the celiac arteries when you do the angiogram. If that's the case, I wonder why you choose not to stent it. Because I think the most difficult thing about the celiac artery is that you got a wire in, and then you can, so once you got a wire in, usually the stent can be placed inside. I mean, you can put a stent in. So if you have already reached that stage, why do you think you still not put a stent? Is there any problem with the stent, putting on the stent?
Thank you, and you are very right and far too smart for me. First of all, nothing is perfect, of course, and we know that doing a lateral angio doesn't tell you everything, and doing a lateral angio with a stiff wire inside the celiac artery may also blur the results. On the other side, with your question, you are right that if you have a stiff wire inside, how difficult would it be to pass over a 7 French sheet, guiding sheet, and then insert a stent. There is more to it than just the sealing and the good angio. There's also something that I truly believe that a celiac artery with a stent in the long term may not do well. And in those patients where you don't need to stent because the anatomy allows you to do it, then maybe for some patients it's better not to do it. And in addition, if you have to extend at a later stage, and you could go over that fenestration if needed to get a longer ceiling zone. But it's all weak arguments and it's all little pros and cons. So I totally agree with you.
Thank you.
Yes. Professor Verhoeven, Professor Chen would like to ask a question that if you leave the celiac artery unstandard, will you try to occlude it or let it remain as a perfusion branch?
No, thank you. And again, the plan is to keep your procedure slightly more simple in the anatomies where it is feasible. And the hope is that with an 8mm fenestration for the SMA that is being stented, the fenestration for the celiac should automatically fall into place. And if you have a decent portion of the aorta, and I listened to a few of the other talks, you know, we like to have 3 to 4 centimeters ceiling zone because a fenestrated graft should be durable and right from the first shot, so to speak. So if you really have good apposition of the other 3 fenestrations, in most cases, that fenestration for the celiac artery should fall into place. And if you have no endoleak, well, why do something more? You have an 8mm hole, you are against the wall, and this may in the long term do better than a celiac artery that is being stented. But we don't know. Again, I'm not humble, it's soft arguments. And we are trying to explain what we do and why, also for the centers that maybe do 4 or 5 of such cases per year, and understand the treatment algorithm to maybe keep it more simple for them. You know, we do more than 100 cases a year, and then it seems easy with the rooms and the team, etc. But we shouldn't forget that these techniques are also being done by people that do, you know, less than 10 a year.
Okay, thank you, Professor Verhoeven. I think it's a very exciting and interesting topic and session. And thank you, Dr. Leung and all the speaker. And I think we have overrun a bit. And thank you very much. And we probably close this session and start the tea break lectures. Thank you.
Artis Pheno enables you to step up your treatment workflow for procedures such as fenestrated EVAR. EVAR Guidance Engine provides assistance for your endovascular repair workflow. Preparing data for fusion imaging is easy with a single EVAR guidance software. Registration of the dataset can be done right at the table. Alignment of the preoperative CT image data with the angio system is fast and saves dose compared to 3D registration. During the procedure, just select the target vessel and let the CR move to the optimal viewing angle, quickly and without any radiation. Artis Pheno shows only the important landmarks instead of the entire volume. You can assess the results of stent deployment right away with the patient still on the table. Extra short scan times mean less contrast media usage. With support before, during, and after the procedure, you can save your brain power for stent deployment.
Can you hear me?
Okay, good afternoon and welcome back to this afternoon tea break session sponsored by Medtronic, and to address a very important topic, which is a continuation of what we discussed earlier this morning on whether we should use a chimney or on-table fenestration. We have invited one of the leading cardiovascular surgeons from Taiwan, Dr. Jimmy Chen. Jimmy is no stranger to this meeting. He is almost ever present in Aortic Asia, and he is currently the Chief of Cardiovascular Surgery Department in Tainan Municipal Annan Hospital in Taiwan. So without much ado, I'd like to invite Jimmy to give his tea break lecture. Please go ahead.
Okay, thank you, Professor Shen. I'm very honored to be invited this year again to join this prestigious meeting. And I learned a lot from the expert from this meeting. Today, I'm going to share some of my experience on how to do this chimney or on-table for some emergent complex cases. I have nothing to disclose. I think every cases currently with the development of the device, I think we can almost do with a total endovascular approach. Actually, we have a lot of different options for difficult thoracoabdominal cases. I think the most favorable and the most data come from the fenestrated and branch device. Also, previously, in the past 5 to 10 years, we have some data from doing the chimney device. And also, we learned a lot from the Brazil, Dr. Lobato, about how to do the sandwich T-bar octopus technique. And also currently in some area like Taiwan and China, sometimes because we have difficult access to the CMD device, so sometimes we need to do some physician modified fan or branch EVAR for our patient. So firstly, I would like to talk about some of the FEVAR and BVAR cases. So from the literature, we know that we have a lot of experience from the European about and also US about how they do these type TAA cases. And actually, from the data you saw here, the mean age of this cohort of patients is very old. And from the data published by Dr. Gustavo, actually, in their cases, the technical successful rate for this TVAR, this FEVAR and BVAR cases is 94%, and the 30-day mortality is as low as 4.3%. It seems very impressive. But if you look into the data, and you saw here, actually the 30 days morbidity and this major adverse event actually is as high as 30%. So you have to expect, you do have to deal with some of this 30 days morbidity when you use this kind of extensive debranching or fenestrating device. So the principal concept here, if you want to extensively cover this aneurysm, you have to avoid long standing, and you have to look at this paraplegia risk in this cohort of patient. And because this cohort patient is quite old, so you can see here, actually the 5 years freedom for intervention is only 50% in both group, both the type 1 to 3 group and the both type 4 group. Although we do see that the vessel patency here at 5 years is very good, it's more than 90%. But actually the survival at 5 years in both these two groups is only 50 to 60%. So it tells you that this poor patient actually is very old and fragile, and their life expectancy is not as long as we expected. We also have several experience with the off-the-shelf device, the off-the-shelf T-branch device. One of this patient, actually, we have been following him for some times, for 3 years now. And actually the patient, after we do the initial the T-branch, we do have type 2 endoleak, and then it's due to this type 2 endoleak from the right renal artery. So we need to restent, we need to intervention at the 9 months after the initial procedures. And this, as you can see here, this is the post follow-up of the CT for this patient. Actually, although as we measure, the size of this aneurysm does shrink a little bit compared to the preoperative status after 3 years, but we do have some problem with this source muscle hematoma that we suspect is due to the extravasation from this this still big aneurysm, although it's already almost thrombosed. So we did a pigtail drainage for him. Actually, we do suggest the patient to undergo another investigation to check whether we do have any problem, but the patient refused and he demand medical treatment. So this is the last CT that we did for him. The patient is still in the clinic, but for your information that in this kind of procedure, we do need to follow the patient every year so that we have to ensure the outcome is good. But the major problem is that the contrast median. So I think in this population, we have OH patient. Sometimes we have a lot of tortuous anatomy, calcification, especially the visceral artery ostium. So which that we don't like to do every standing for this kind of visceral artery. And also the outcome does improve in the literature because this device improve and also the branch stent graft do improve, this profile of the stent graft improve. But because I think if we have the CMD device as easier to approach as in the Europe and US, then we might have much easy control to this very difficult anatomy. But in Taiwan, we are very difficult for us to have a really CMD device. So it's difficult for us to rely on this, only rely on this branch or fan device, mostly from the Cook company. And I think in this cohort patient, if the patient is quite old, actually only 50% of 5-year survival that we can expect from this cohort patient. So to me, I think in some cases, maybe we should minimize the time to do the procedures, and also we should find something that might just solve the problem. So this is one of the cases that we did for these thoracoabdominal cases that actually we did a 4-branch chimney periscope, and then we have followed the patient for 5 years and 6 months. And the patient currently he's still doing well with no significant endoleak or aneurysm progression. And also from the data here, we know the problem with the chimney is that they have 10% of the endoleak in most of the cases. So for all around the world, I think here we can see the patency of the chimney stent is as good as the data we can see from the chin or the fan or the branch device. But the problem, I think, mostly with this chimney is the endoleak. So I think in order to avoid endoleak, if you really need to do chimney procedure, maybe you need to avoid more than 2 chimney stents in order to reduce the gutter. And then I recommend that if the visceral artery is too small, maybe less than 6 millimeter, maybe you should reconsider about really using the chimney for repair. And also avoid acute angle configuration cases. And at least I think if you just want to do the chimney, you need to have at least 4 to 5 centimeters of sealing zone to reduce this gutter leak. And also sometimes when the aorta is too big, you need to have a hybrid procedure. So to ensure that you have a very good, healthy sealing zone or landing zone for the patient. So we also have experience with the sandwich, because in some cases, which is very emergent that we don't have time for the off-the-shelf device, then sometimes we need to take something we have very familiar. So this is one of the cases that we did earlier, that we use octopus to treat these very difficult anatomy cases, which has a rupture aneurysm, and this patient actually survived for 1 year. And then after 1 year, the patient died of pneumonia, but the patient do survive the initial event. And we have also another patient here is a patient with chronic smoker and alcoholism, 58 years old. Actually, the patient is a Larish syndrome patient. Initially, we do the parasailing for him, but at 1 month later, the patient come back to the hospital and develop a rupture. We suspect myocardial aneurysm. And then for this very difficult case, because the abdominal part we already did with the parallel grafting, So in this patient, we designed this octopus in order to seal this bleeding because the patient come with a shock status. This is after the definite repair, as you see here. And then we follow up this patient until today for 3 years already. And then just come back last week with very low CRP data. And the patient, for him, he lost one of this graft, which is connect to the right common iliac artery, but the patient remained asymptomatic. This is found by our CT scan follow-up. And this is the configuration you saw here. Actually, the patient has survived from this rupture event. And this is one of these example that I give you that sometimes that in the emergence setting, we can still consider this kind of complex procedures. And some experience for the Chang'an Memorial Hospital in Taiwan. They did 12, sorry, here it's I think a 12 case, 11 cases. But in their data, they found that the major complication is still high. They have a 45% of major complication, including 3 deaths, 1 permanent paraplegia, and 1 temporary paraplegia. So in this kind of cases, I think you still be carefully select the patient because we still have to be aware of the complication. And we can see the data from the Dr. Labato and also Dr. Converbach. And from the data, they have a lower mortality rate, but actually they still have some branch patency problem, and those also the endo leak problem in the study. So lastly, I came to this physician modified untable fan branch. I think the reason that we want to use this because firstly, we want to reduce the risk of gutter leak. And then mostly the patient we choose is the emergent cases. And we want to minimize the number of kidney graft. And also because some patient the anatomy is not really suitable for the fan branch, and it's still feasible to do this untable fan. So we choose those kind of patient. And then I think if we fail, then I think the Cheney procedure to bail is another important thing to do when you fail this kind of untable fenestration. This is one of the case that I first noticed from the literature. This is in the 2014 from Singapore National Hospital. They have one cases which is ESRD patient and with a previous CABG and also the bacteremia with below the knee amputation. Actually, they treat this kind of myocardic aneurysm suprarenal type. They use untable fenestration using the Cook device. And then they do, initially after these procedures, they have a type 2 endoleak. But 6 months later, actually they follow without eventually the endoleak seal itself. So they follow the patient for 1 year before they publish the data. And in our experience, our initial experience with this PAU patient, that initially we have stent for the patient, but the patient suffered from the sign. This is also an ESRD patient, and because the patient suffered from abdominal pain, so we need to try to seal the sign. And for this patient, because it's very near the ciliatron and SMA, so we dig a fenestration for the ciliatron and SMA, and then we do some coiling for the residual flow that we notice. And then eventually we follow up the patient already for 2 years, and then we did not notice any recurrence or residual or any sign happen again. And then also we see the complete remodeling of the aorta after standing for 2 years. But this is the case that we experienced 6 months before, that this is a patient that suffered from this abdominal pain with a complex TAA. The patient is a 60-year-old man with a dialysis patient, hypertension, and this TAA has been found since 2015, but it was left because maybe it's because of anatomy in the other hospital, and then the patient visited us because the abdominal pain. So in the city, we found that the patient has 2 PAU over the mid-descending aorta, and also 1 large aneurysm over the thoracoabdominal area. It's measured 7 centimeters. This is the CT scan. Okay, and we have one big PAU here, and then we also have the TAA, suprarenal thoracic aortic aneurysm here. And for this patient, because it's a little bit emergent, so we did not wait for this branch device. So we tried to do our own branch device because this patient is hemodialysis. So we don't need to preserve the patient's renal artery. So we only need to preserve the celiac trunk and SMA. So I decided to do my own on-table branch. So we use a 8mm wire bond as our branch, and then we make a hole, a 6mm hole, and then we initially deploy this wire bond out on the table, and then we use a 6mm balloon to post-dilate, and then we make our 2 branch in the table, and then we use the Prolink to fix the inner branch to the stent graft wall. And then this is the picture then after we do some fixation. So in order to make it easier to cannulate. And then we need to, actually this stent is in the 22 French sheaths. And then after we use the wire bond for the branch, then we need to upsize the sheaths to 25 French in order to resheath this piece. And then this is the aneurysm that you saw here. Then we put because there is a PAU upwards, so we put this TVAR first, and then followed by this physician modified branch stent graft, and then we start to cannulate this branch. Initially, we think it's very easy from the above, but we have some difficulties. So we used to cannulate this branch from below, from the femoral approach, and then we use a snare to do the through and through wire thing. And then we regain the access from above, and then we try to cannulate both SMA and celiac trunk and finish these procedures with another 2 wire bond stent. And then the final operation time for this procedure is 240 minutes, and then we use only 60 cc of contrast medium. This is the final the picture that we have after we do this physician modified branch device. So this is the follow-up at the 3 months, and actually you saw here that the aneurysms are already thrombosed, that we did not notice any endo leak in this patient, and then we will still follow up the patient for enough time to make sure he has the good data. So sometimes we have this calcified ostium of this SMA celiac trunk that we don't want to do branch or fend. So in this kind of case, I just open a scallop, and then we just do the bilateral renal chimney. But because this patient he has a quite big chimney, quite big renal artery, so this is the patient. This patient he suffered from a juxtarenal PAU and large aneurysm. And then after these procedures, like you can see here, we did have a seal. So we sometimes modify this kind of procedure. So I summarize my talk today. I think we need to familiar with all 4 approach, because I think we have different patient demography, also the patient physical condition, also patient's clinical presentation, and also local health reimbursement issue. So actually, because we familiar with the all 4 approach, that we can manage to do most of the cases. I think these are not individual techniques, but actually they are tandem technical skill. So if you do need to have all 4 this kind of skill and technique and concept to do these TAA cases. And I think open surgery should always be the last ultimate weapon for a physical patient, because not all the patient is feasible for a big open surgery in this setting. Okay, thank you.
Thank you very much, Jimmy, for this excellent summary of all the techniques. I'm sure you're an expert of all of them. So I understand that you don't have any preference, and it depends on the situation and the patient's anatomy. We are actually a little bit behind in time. So is there any pressing questions that anyone wants to ask? I don't see anything online yet. Maybe I can ask you a quick one. Do you address the issue of whether coming in from the top poses additional risk of stroke? Have you ever actually had a stroke doing procedures from the top? always one of the concerns.
I think because I do listen to your talk about your concern about coming from above. I think I agree very much with you that I think the major issue should be the size of this stand that we use from above, and less manipulation. I think is will be the very much safer, and also I think concentrate on this maybe anticoagulation status, the ACT. I think is also any very important issue. In my experience, because I also do quite a lot of cases with this on-table fenestration TVAR currently. I do not have any cases that currently suffer from stroke. But I do notice that if the arch is very astromatic, or this supra aortic trunk is very calcified, or maybe full with plaque, I think in those cases we should avoid more manipulation. So in those kind of cases, I won't choose fenestration. In those kind of cases, I will choose chimney, because chimney is simple and quick. In those kind of cases, I would just put a wire, and then I'll just put a chimney stand and just do the chimney, because in my experience, I think the chimney over this arch pathology also have a quite good result. So I won't force myself to use a fan in those kind of situation.
Jimmy?
Yes.
Okay, I think in the interest of time, we have to draw this tea break session to a close. And thank you again for giving us this wonderful lecture. And we should move on to our next session. Hope to see you soon, Jimmy. Thank you.
See you soon. Bye bye.
Hi, welcome back to this last session of Aortic Asia 2021, and I'd like to welcome again my co-moderator, Dr. Peter Robles, live from Singapore. Hi, Peter. And so this is the last session of, I believe, a very good day. If you had joined us earlier today, there are many questions that was addressed today, and you will also find the answers in this very last session. So in this session also, we would like to welcome our invited speakers from Europe. Because of the time difference, they're just probably starting to join us live. So we would address this session, the techniques from experts, by starting from inviting our first speaker, who is Dr. Julian Wong. Julian is actually from Hong Kong. He spent some time in England as a consultant in NHS UK before he moved to Singapore, and he's now senior consultant and head of the Division of Vascular Surgery in the National University Hospital Heart Centre in Singapore. So Julian, welcome, and you're going to tell us about your experience of Cook Alpha thoracic stent, 7 years experience in NUH, please.
I can't hear anything.
Singapore, and he's now senior consultant and head of the Division of Vascular Surgery in the National University Hospital Heart Centre in Singapore. So, Julian, welcome, and you're going to tell us about your experience of Cook Alpha thoracic stent, 7 years experience in NUH. Yes.
Can you all hear me? Hello? I can't hear anything. Can you hear me? We can hear you. Yeah, okay, good. Thank you. Thank you, Stephen, for the introduction. Today I'm going to talk about the 7 years experience that I had with the Alpha Cook system from end of 2014, actually beginning of 2015 to now. I have no disclosure, although I'm proctor for Cook. I started to migrate to the Alpha thoracic system at the January of 2015. I was lucky enough to be one of the first few who can use the system. I'm currently working on our aortic database since 2017. Sadly, I can only share with you my personal series. I couldn't have enough time to work with all the 6 consultants' data, as now we have a lot of PDPA issue. Now, the reason I moved across to the Alpha system since 2015 was, first, it's one of the lowest profile. It has got very good trackability. It has a good pre-curve system, and it's ideal for zone 0 landing. Before that, I mean, in Singapore, we probably just had 2 systems to use, the Cook TX2, the Medtronic Captivia, and possibly the Jotec. But Jotec is a very recent player. I mean, after that, everyone has migrated to newer platforms. Cook from the 2015 gone into Alpha, Medtronic Navion, which has recently stopped. I only happen to have worked on the field. And the Jotec inner system will come in 2021, end of this year. Now, I have in the last, up to January of this year, I have operated personally on about 60 patients, of which 1/3 is emergency and 2/3 are elective. This will be a normal distribution. As you see, mostly are male. Interestingly, if you look at our race distribution in Singapore, on the elective, this is probably the right distribution from the population. But on the emergency, you can see our Malay population probably a slightly sicker, and most people come in as emergency. So what about our referral pattern of this 60 patients? Well, most of them come internally from ourselves. We get referrals from Tan Tock Seng, we get referrals from Khoo Teck Pot, and sometimes also Ting Fong Hospital. We had one private hospital transfer. I suspect the gentleman was running out of fund, and some from overseas and primary care. Majority of our patients, thankfully, at the time, I count them as smoker, but ex-smoker is not a smoker. So the smoker, the emergency patient, always a higher proportion. Diabetic, about 10 to 15%. Hypertensive patient, all our elective patients are untreated, and a quarter of our patients probably had renal artery disease, and some of them had stroke and probably Marfan. And our pre-op status for these 60 patients on the emergency, most of them had probably normal renal function. However, our elective patients, a quarter of them also had renal failure. Some of them are on statins. Not all of them are on statins. Some of these people are not all of them are on because they're probably allergic, and only 63% are on antiplatelets. And you'll be glad to know before our operation, everybody's systolic BP are well optimized before they go for surgery, whether emergency or elective. And as you see from the symptoms demographic of this patient, majority of them have active pain. Some of them come with a cardiac arrest and also some degree of stroke and spinal problem before we start, especially on the emergency patient. And the distribution of pathology that as we have is probably half of them are aneurysms and half of them are dissection, and a few of them are miscellaneous, especially in the elective. And a lot of these people had previous CVS intervention. If I bring you to look at the elective side of things, a lot of them had ascending aortic repair, root repair before they undergo our TVAR surgery. Now, this is the data, especially on the average age of the patient. On the emergency side, you can see they're slightly younger. Our proportion of straightforward TVAR on the emergency, about 70%. 10% of them will call the subclavian after we do the surgery, and about 20% will need an emergency bypass as well. On the elective side, on the TVAR, the patients, a lot of them, 60% of them are straightforward EVAR, 20% also have bypass, and only 20% will do the subclavian embolization. Interestingly, if you look at this side of the data, some of the emergency surgery is operated on the elective list. About a third of them will operate on the following morning, and we find an elective list to do it rather than do it in an emergency theater setting. And for the last up to year 2020, all my TVARs are done, with femoral access, and they are none of them are percutaneous. The status of discharge. Of the elective side, we had one person who died, but they were out of the 30-day mortality, mainly because this gentleman had unrelated cardiac failure and died 4 months later, after the original TVAR surgery. But on the elective side, the mortality is just over 10%. We have no readmission related to aortic surgery due to the emergency, but we had one readmitted, out of the 40 with an aortic-related admission. The average ICU stay was about 4 days for the emergency side and a little bit lower for the elective side. These are the final most important slides. As you can see, our 30-day mortality for emergency, this included mixed type A dissection with TVARs, some zero landing, rupture, aneurysm, transection. Overall mortality is about 10%. But our stroke risk is running about 15%. On the elective side, we had no 30-day mortality for the last 6 years, 7 years coming up to. And the stroke risk was about just over 10%. And wound infection was extremely low, and we had nobody who had any paraplegia, thankfully. And I just want to draw to you the other TVAR, probably the Melisano and also the Torcello. They are the studies purely on the alpha system. I think we are very similar in the NUX setting overall. Our intervention rate is, re-intervention rate so far is 0. And in my conclusion, ladies and gentlemen, the Cook Alpha thoracic system is very safe. They have comparable results with the other device. The reason I want to show you all of this is this is the capability of the database. I'm probably showing you about 60% of the database which I have set up since 2017. And we are working backwards to the last 15 years. And hopefully maybe next year, I can show you a lot more data. Thank you.
Thank you, Julian. Peter.
Thank you, Julian.
About 60% of the database which I have set up.
Thank you, Julian.
Thank you.
It gives me great pleasure now to introduce our next speaker, which is Dr. Peter Goverdi, who is an accomplished, eminent endovascular surgeon from Antwerp in Belgium. He's the inventor of the CRAP technique. He'll be talking to us about algorithms for aorto-occlusive disease. Dr. Goverdi is also a global ambassador for STEEL, the floating surgical table, and is a big proponent of radiation protection, which is becoming a big issue for a lot of endovascular surgeons now. Thank you very much, Peter.
Thank you, Peter, for the nice introduction, and good afternoon, everybody there. So I thank you again for this nice invitation, and I will try to restart my presentation now. So my algorithm for aortic occlusive disease. So start from the easy lesions to the extrarenal aorto-iliac chronic total occlusions. These are my disclosures. So my algorithm is actually based on one side, the very well known that the Task 2 steering committee overview of the lesions. On the other side, based on the SKY guidelines on device selection in aorto-iliac arterial interventions, and of course, based on our experience. So starting with the easy lesions, so we have Task 2 type A lesions. The unilateral or bilateral common iliac stenosis, it's mostly done just with bare balloon angioplasty, yeah, and then followed by either a bare balloon expandable stent or a bare self-expandable stent with postalization, yeah. Then the unilateral or bilateral external iliac stenosis, again, bare balloon angioplasty. It depends from country to country, then followed by a drug-coated balloon. And if needed, a self-expandable stent. I'm very restrictive in using stents in the external iliac artery. So then Task 2 type B lesions, short infrarenal aortic stenotic lesions. Again, we try to start with a bare balloon angioplasty. In case of soft plaque, we go with the self-expandable large diameter stent, and then post-dilate the lesion to a fair diameter. In case of calcium, use a balloon expandable large diameter stent. Mostly I use a covered one, sometimes a bare covered stent in case of the presence of visceral arteries that need to be spared. Then unilateral common iliac artery occlusions, of course, it's very easy, bare balloon angioplasty, and then followed normally a bare balloon expandable stent. And when it's extremely calcified, or when you are in a subintimal plane, the covered balloon expandable stent. So unilateral or bilateral chronic common iliac artery stenosis, again bare balloon angioplasty, followed by a bare balloon expandable stents or a bare self-expandable stent. So for one reason, I cannot go further. Then, in case of unilateral external iliac artery occlusion, bare balloon angioplasty with or without drug-coated balloon, and then with or without a bare self-expandable stent. So, in case of single or multiple stenosis, so 3 or 10 centimeters with external iliac artery involvement, but without involvement of the common femoral artery, again, bare balloon angioplasty. When we have a patent hypogastric artery, we treat the common iliac artery, the bare balloon expandable stent, and the iliac bifurcation and external iliac artery if needed. We cover with a bare self-expandable stent. In case of an occluded hypogastric artery, then the common iliac and the external iliac is treated with a bare balloon expandable stent, and if needed, the distal 2/3 of the external iliac artery is treated with a bare self-expandable stent. So in case of task 2, type C, so bilateral common iliac occlusion, so we have a bare balloon angioplasty again, and then depending on the plaque. So if you have the majority of soft plaque interluminal, we actually use a self-expandable bare kissing stent technique. When we have a mixed plaque constitution and still interluminal, we use bare balloon expandable kissing stents technique. When we have a calcified plaque or soft and mixed plaque, but going subintimal, we mostly use balloon expandable covered stents, and then a kissing stent, kissing stent technique, of course. So then going to the bilateral external iliac stenosis, again, bare balloon angioplasty, and then without drug-coated balloon, and then depending on the recoil or other problems, ended with an self-expandable stent. So then unilateral external iliac occlusions involving the origin of the hypogastric and or the common iliac artery, again, bare balloon angioplasty, soft plaque, self-expandable bare stents, mixed plaque, bare balloon expandables in the common iliac artery and the proximal 1/3 of the external iliac, and bare expandable stents in the distal 2/3 of the external iliac. Calcified plaque and soft and mixed plaque subintimal, like before, balloon expandable covered stents in the common iliac and the proximal 1/3 of the external iliac, and if needed, self-expandable covered stents in the distal 2/3 of the external iliac. So then in case of an unilateral external iliac stenosis and extending in the common femoral, common femoral is proximal to the deep femoral artery, less than 70 years, and up to moderate calcification, or when the patient is more than 70 years, and this is mostly the first choice, or in case of restenosis, we start with a bare balloon angioplasty, followed by drug-coated balloon, and then with or without a bare self-expandable stent. In this case, we mostly use Supera VMI stent. So, but in case the patient is less than 70 years old with severe calcifications, or when doing a hybrid approach, or when the common femoral artery, the deep femoral artery, and also the superficial femoral artery is involved, we mostly choose surgery as an option. So then the more difficult ones, the infrarenal aortoiliac occlusions. Yeah, so when they have a majority of soft plaque, then we do a double barrel kissing stent, which double barrel kissing covered stent technique, first with self-expandable and then followed by a balloon expandable. When we have mixed plaque, same as before, in the proximal part, you have soft plaque and distal part calcified. The soft plaque will be addressed with self-expandable closed stent within a large diameter. And then below that, we will start with syrup, with, of course, balloon expandable covered stents. When the proximal part is calcified and distal part is calcified, we do syrup long body syrup with a balloon expandable covered stents. In case there is some visceral arteries that need to be spared, for instance, the IMA or the renal artery, we do chimney syrup. And then when we have a small aorta to less than 10 millimeters, recurrent disease or some on the indications, we do surgery instead of an endovascular approach. So talking about visceral arteries, so when the IMA is open in a very diseased infrarenal aortic stenosis or a partial occlusion, when the IMA is less than 4 millimeters and the SMA is normal, then we can overstent the IMA without any problems. When the IMA is less than 4 millimeters, the SMA is stenotic, we can overstent the IMA after a PTA of the SMA in first or together session. When the IMA is more than 5 millimeters, the SMA is normal, or the SMA is stenotic, but after a PTA of the SMA, we convert the syrup to a chimney syrup. So it's the same actually for the diffuse disease of the aorta and iliac arteries. So it's almost the same, as you can see, as before. So in case of unilateral stenosis of the common iliac artery and external iliac extending the common femoral, also this is like in the other situation. And we go then for mostly a hybrid approach with common iliac, external iliac artery stenting, and then surgery of the common femoral artery. So, and then in the unilateral occlusion involving the common iliac artery and external iliac, is also as before in the combination of the occlusion of common iliac and external iliac. And then the bilateral external iliac occlusion is the same as the unilateral occlusion. And then finally, in the rare case of an iliac stenosis in patients with an AAA, not amenable to an endograft placement, again, the bare balloon angioplasty of the common iliac artery with a bare balloon expandable stent, or a covered balloon expandable stent, external iliac with a drug-coated balloon, and we try to avoid stenting. But of course, when we decide to treat the aneurysm, it is best to do the combination of both, of course. So I thank you very much for your attention.
Thank you very much, Peter. We'll leave the questions again to the end. So
I can give
for
you
the
the word
talk,
back to Peter.
I'd like to welcome our very good friend.
Thank you. Stephen, you're muted.
Oh, can you hear me now?
You're still muted.
Can you hear me now?
Yep.
Yes, thank you very much, Peter, for that algorithm, and we'll leave the questions to the end. So for the third talk, I'd like to welcome our very good friend, Professor Bijan Mudari. Good morning, Bijan, and welcome to join us in Aortic Asia. Bijan is Professor of Vascular Surgery at Guy's and St. Thomas Hospital and King's College London. He is one of the undisputed accomplished vascular surgeons in the United Kingdom, being a Hunterian professor at the Royal College of Surgeons of England, as well as in the Council of British Society of Endovascular Therapy. And currently, he heads a very busy endovascular unit on complex branch and fenestrated endografting in England. So for his first talk today, he's going to talk on managing difficult angulated aortic angulations. And we had some discussions earlier today on angulated necks, and I think Bijan, you give the definitive answer to all these questions. Please go ahead.
Thank you, Chair, colleagues, friends. Thank you for the invitation to join you at this excellent meeting. These are my disclosures. As this elegant study published in 2019 illustrated, there's a high degree of variability to the amount of angulation of the aortas that we treat. But what about patients who have had standard EVAR? You can see from these three publications here that the rate of severe aortic angulation is up to a quarter of these, and in 10% there is a high degree of suprarenal angulation. But does this angulation translate to poor outcomes? This series published in 2020 suggested that angulation of the proximal landing zone in EVAR had a weak impact on later instance of sac growth after repair. And if you look at the ROC curve that they generated, you can see that even a 43 and above degree of angulation was predicting sac growth in these patients who had repair. And not surprisingly, the rate of type 1A endoleak is more likely in patients who had angulated aortas. If you look at the Eurostar study, the suggestion is that there is a higher risk of type 1A endoleak with angulation again, and that this risk is twice that of those patients who aren't angulated. And again, the suggestion that if you repair outside the instructions for use because of this angulation, then you have a higher secondary reintervention rate. Well, there has been stent graft development to try and circumvent this problem of infrarenal angulation, and the Lombard AorFix is one such device that purports to overcome this challenge with EVAR. If you look at this publication pertaining to this device, it was used in 151 patients that had more than 60-degree angulation, 42 of these patients more than 90-degree angulation. And these repairs were compared to 67 patients that didn't have an angulated neck. And in this series, using this device, angulation was not associated with an increased rate of type 1, type 3 endoleak, or indeed an increased rate of device migration more than a centimeter. There was, however, a trend to a higher sac expansion rate in the angulated group, and there was an instance of 23% in stent fractures in the fixation zone. This is another device that is promising to lead to better results in patients with angulated necks, the Gore excluder conformable. And the promise is that the ability to reposition the device means that you're more able to use the full length of an angulated neck. And we at the British Society of Endovascular Therapy are running a registry where we are capturing patients that are repaired using this device in the UK, with the main outcomes being the amount of aortic neck length coverage and technical and clinical success out to 1 year. What is for sure is that in the face of angulation, then planning for these cases outside the operating theatre becomes of the utmost importance. And key to this is using multiplanar reconstruction software. This will help you to predict the route that a stiff guide wire will take, and it will allow measurement of perpendicular diameters in order to achieve correct sizing for the stent graft. What's also very important is that you work out the C-arm angles that are needed in order to open out the full length of the aortic length when you're in the operating room, because without that, it is likely the repair will fail and a type 1A endoleak will result. Apart from planning, are there any adjuncts that you can use in the operating theatre to circumvent problems? Well, this publication suggests that endo anchors may be effective. It's a study of 42 patients who had EVAR. You can see how the pre and post-op angulation changes with introduction of the stent graft. The study documented sac regression in most patients. There was an instance of ongoing neck dilatation, as one might expect, with an average rate of 3 millimeters on follow-up. But in fact, with use of the endo anchors in these angulated patients, there was only one type 1A endoleak. And apart from that patient, there was no other need for neck intervention. So not conclusive, but one study that's suggesting that endo anchors may have a use in angulated anatomy. And I think the other thing to bear in mind is in a case that is made very challenging because of angulation and where the patient is fit for open repair, that option must always be borne in mind. If an endovascular repair is likely to result in poorer mid to long-term outcomes, then open repair should be considered in the patient who is deemed fit for the procedure. So we focused on infrarenal repairs. How about pararenal and thoracoabdominal repairs? Well, angulation can also affect the descending thoracic aorta, as you can see here. And again, the angulation is illustrated by the course that the tumor wire is taking on the middle fluoroscopy image here. But it's quite dramatic how the anatomy straightens with the introduction of a stiff wire and transforming this into really an open repair and allowing that stent graft to conform to the angulation after the graft is deployed. So being able to predict what the challenge may be on a case-to-case basis is important. And what about in this scenario where the patient had already had a TVAR, the TVAR had pulled up, resulting in a type 1B endo leak, and he required extension of the repair down into the infrarenal aorta with a branch stent graft in order to re-establish a seal. Well, the supraceliac angulation here can make navigating the branches into the target vessel very challenging, and indeed, again, requires careful planning, judicious stent graft design, and endovascular know-how. There is a paucity of literature studying the effect of angulation in complex endovascular repairs. The Oderich group published on this year, where they studied over 100 pararenal repairs and nearly 200 thoracoabdominal repairs, comparing angulated and non-angulated cases. And they found, not surprising, that the main risk in the face of angulation is device malrotation and misalignment of the device rather than achieving a seal. The angulation made repairs more challenging. It needed a longer operating time and a higher radiation dose. But in fact, the only aspect of the repair over time that was affected adversely was target vessel instability. And this was associated with a suprarenal angle of more than 45 degrees. In patients that had this angle, there was an almost 6 times higher rate of target vessel instability. And that's not surprising. If you look again at this diagram, you can see that the angulation here is causing a bend in the mating stent, can cause dislodgement and endo leaks where the stent mates with the native target vessel. So is there any technology or aspects of graft design that can be leveraged in order to overcome angulation in these complex patients? Well, the answer is yes. And I just want to use this case as an illustration. You can see in this patient that without an infrarenal neck, that there is severe angulation. The graft incorporating 3 fenestrations might well have been a very challenging repair. So we decided to use an upward facing branch for the left renal vessel. And you can see here that that has achieved a successful repair. In fact, it was very easy to navigate and stent the left renal vessel, and this has circumvented the challenge of the angulation. So I'll leave you with 3 key messages. There is no doubt that aortic angulation increases the procedure complexity. In the face of a challenge such as angulation, patient selection and preoperative planning are all important. And there has been developments in technology that should be leveraged in order to make these repairs as durable, as feasible, and as easy as possible. So thank you very much once again.
Thank you, Bijan. We'll move on to our next speaker. It's my pleasure to welcome back Professor Eric Verhoeven. Eric is chairman and professor at the Department of Vascular Surgery in Nuremberg, having been in Groningen before and Belgium. He is a very accomplished endovascular specialist, having published extensively and also spoken to us before on complex endovascular intervention. Thank you very much, Eric.
Thank you very much for asking me to discuss this third option when treating complex abdominal and thoracic aneurysms. My disclosures are related to my cooperation with Cook, and I discussed inner branches with them in 2004, and I also listed the companies that provide the bridging stent grafts. So when we discuss fenestrated and branch stent grafts, this is what we have. Although on the left side, I must tell you that the 2 times fenestrated graft. This has become obsolete in our department. It's either triple or quadruple fenestrated grafts, and on the right, of course, a 4-branch device. And all combinations are possible. Now we know that fenestrations do well when the graft lies against the wall and when the takeoff is not too sharp. Usually they are addressed from below, in contrast to branches that are addressed from above, and do better when there is enough space between the graft and the aortic wall, and obviously the sharp takeoff of renal arteries, example given, makes it only easier. So the question is what to do with vessels that are less suitable for either option. And here you see a celiac artery where there is not a lot of room. It's a steep artery, so from below with a fenestration it's slightly difficult, and with a branch you don't have the room to do it. So this is the idea that I discussed with Cook many years ago, and you can see it from my drawing that there is a cylindrical part of that inner branch that will provide the sealing, and then a wider opening or exit or connection to the outer world towards the target vessel, of course, that also gives it some liberty in positioning. And on the right you see a modern version of this inner branch device. This has evolved over the years, and actually the arch branch device has the same inner branches, and obviously with Cook the outer connections, so to speak, are within the Z-stents, so they are diamonds instead of baskets that I drew in 2004. There are potential advantages. Obviously, there is no risk to squash a branch like in small diameters or angulated anatomies. You have the option to keep your main graft wider, which can be an advantage. And if you treat a type 4 thoracoabdominal aneurysm, you can start lower in the aorta and reduce the risk of paraplegia. And to a certain extent, you may hope that you will have an easier task to catheterize a target vessel, because you come through the cylinder from above and then everything is pushing you towards that target vessel. Here are a few examples, and you can see on the 2 red crosses on the right image that really the orifices of the renal arteries here fell nicely into the diamonds of the inner branches. This is the graft design. We use indwelling wires quite often because it's much easier to come from above when you already have a free entry, so to speak. And here is how it's done. We open the graft. The fenestrations are being catheterized. Thanks to that, the branches should be in a good position, and then it's fairly easy to catheterize and stent them, and this was the end result in this case. We treated a few specials, example given post-dissection thoracoabdominal aneurysms, a steep celiac artery, the blue arrow, not enough room for standard branches. And this was the graft with 1 internal branch or inner branch and 3 fenestrations for this patient. And you can see the same technique. You deploy your graft, you catheterize your fenestrations, and then you snare, you wire the indwelling catheter and wire, and then you come from above, and usually you fall correctly into the target vessel. This is another special, a failing old 2 times fenestrated graft with an endoleak type 1. So here we designed again a graft with 2 inner branches for the renal arteries that were obviously already stented. And the trick here was to open the graft only partially to allow for room and space, and then we catheterized the renal arteries, and then we opened the graft completely, catheterized the fenestrations, and then could stent everything without a problem. We published our early experience with these inner branches and have slowly expanded on our experience, but with some caution, and I will show you why. Now we've done 52 patients with 75 inner branches. Different reasons are listed there. Most of the time it's a combination of reasons. Interestingly, most of the grafts were grafts including both inner branches and fenestrations, and very few inner branches only, and I don't like them. In most of the cases, we used indwelling wires that facilitates the procedure, and technical success was fine. Inner branches were easy with an indwelling wire. Without an indwelling wire, we struggled because they are more difficult to orient than fenestrations and standard branches. And the target vessels, interestingly, when we had grafts in combination with fenestrations, it was a free entry almost. But in the inner branch only devices, we struggled more to catheterize the target vessel. And that probably has to do with the non-completely correct position. We had 5 occlusions out of 75. That's a little bit high, but there is no doubt a negative selection bias because these cases are all the difficult cases. They were all renal branches. Obviously, we know that renal arteries don't do so well with branches compared to those that are suitable for fenestrations. So that's another problem. And here, the details to look for the ideal stent graft, but it's not fair to blame the Atrium V12 because we used it in the beginning of our experience. And still must I say that we prefer the B graft plus now because it has a higher radial force and more kink resistance. Not a surprise also that the smaller vessels did worse than the larger vessels. That's a well-known fact. Here, a few images again. Looked good actually. It's still occluded, and then we had to recatheterize that, did an extra relining, and then thrombolysis for the clot in the renal artery branches. And this is another one where you can maybe see the angle, but more important, I think this is a point in the inner branch only grafts that when they are not perfectly positioned, you can see the blue arrow, then there is a kink there and a narrowing in the stenosis, and I don't think that is a good thing. So if you have a narrow aorta, only inner branches are not good. If you have a lot of space, it's not a problem, then you have a more liberal positioning option. So limitations and potential. Obviously, you have to think that your big diamonds are providing less sealing or less contact to the wall. So you might want to start a little bit higher in this design to have an extra sealing stent above the fenestration of the celiac artery. But on the other side, it has the potential for some off-the-shelf devices. This design for juxtarenal or suprarenal aneurysms, acute cases, because you can position your branches more liberally. And obviously you could think of a 4 inner branch graft with a wide body for more complex aneurysms. The one limitation in the manufacturing is important because the diamonds have to fit inside existing Z-stents. There is no banding or pushing away this Z-stent in the branches. There is maybe an additional risk in renal arteries. You see on the left a branch, a normal branch that is already a little bit angulated, but the inner branch, of course, provides a straight downward part and then a more severe angulation. So this is the reason why we prefer to use now bridging stent grafts like the B graft plus that have a higher kink resistance. And we shouldn't forget that nowadays we have more options like fenestrations from above. This was a case with a preloaded system with only one femoral access, where we did true vessels from below through the one preloaded system and 2 vessels from above with an indwelling catheter and wire, and that worked very well. So we have more options, and also for standard branches, if you have problems from above, you can use steerable sheets to do them from below, but that is also true for inner branches. So to conclude and mainly to answer the question, the tips and tricks, I think it's mandatory, or I would clearly advise to use an indwelling catheter and wire. I think use a kink-resistant bridging stent graft. For us, it's the B graft plus. Smoothen the transition node where needed. Use a self-expandable stent to extend a little bit and smoothen that kink at the end of the covered stent. And I think do not over-indicate the inner branches without a very good reason, because there are many options nowadays and we find solutions for every case. And in the end, it's still about finding the best solution for each case rather than having the most experience with either inner branches or other solutions. Thank you very much for your attention.
Thank you very much, Eric. Please stay behind for the discussion and questions. So we move on to the next talk, which again, we would like to welcome Bijan, Professor Bijan Moudary again from London. And his topic is going to be what is the evidence of spinal drainage. As you know, this is a controversial topic. I believe there are key opinion leaders who recently declared that you stop using it. So we'd like to hear your view on this important topic. Please go ahead.
Thank you once again, Chair, and I'm delighted to deliver this second talk in this session that pertains to the evidence around prophylactic cerebrospinal fluid drainage for patients who have extensive aortic repairs. And I'm going to focus mainly on endovascular repair, as this is where the controversy and the interesting aspects to discuss are. There is no doubt that patients who develop the devastating complication of paraplegia have a poor prognosis. And as this publication by Roy Greenberg 2008 showed, the mortality rate is high after both open and endovascular repair in paraplegic patients. And the prognosis has not changed over the ensuing years. What has changed, however, is the spinal cord ischemia rate pertaining to endovascular thoracoabdominal aneurysm repair. And these publications show that in comparison with the historic rates, these rates are falling, and reports suggest that they've fallen further in the years since these publications were made. So why has this happened? Well, I think it's because we are better at using a multimodal protection package when it comes to spinal cord ischemia. What's in this package is the fact that the surgery has become faster as experience has increased. There is a much more sensitivity to preserve the collateral circulation. We use strategies such as maintaining a high hemoglobin. Many of these repairs, extensive repairs, can be staged in order to not have a single ischemic hit on the spine. We are very attuned to avoiding hypotension. We can monitor the spinal cord. There are strategies that are under study, such as coiling lumbars and intercostals. And the question then is, where does spinal fluid drainage fit within this multimodal package? Just to address open repair in one slide, I think the evidence for prophylactic drainage after open repair is stronger. There's this randomized study and a big series showing patients who have CSF drainage after extensive open repair prophylactically, there is a lower instance of cord ischemia. And how about endovascular? Well, this publication this year illustrated very elegantly using a porcine model where open and endovascular intervention on the aorta were compared. The endovascular ischemic insult, it causes permanent hypoperfusion. And when the colleagues examined histologically the mechanism of open versus endovascular, they found that the endovascular damage was in the white matter of the spinal cord, so in a different area to that caused by open repair. So I think we are dealing with a different mechanism. So what is the evidence already published that can guide use of spinal drainage and prophylactic use in particular? Well, these colleagues last year did a systematic review. They found 8 studies that met the inclusion criteria, and only 2 compared cord ischemia rates with and without cerebrospinal fluid drainage. The incidence varied greatly in these studies, as you can see here, and the protocols were very heterogeneous and different between the different studies, so not comparable. And the conclusion of these authors was that the evidence is equivocal and we need better evidence. This is another review in the European Journal of Vascular Surgery, and it again states that the data is heterogeneous. The studies are mainly retrospective. We have no randomized controlled trial comparing patients who have prophylactic drainage and those that don't. The cord ischemia rate that's published varies hugely. And again, these authors documented that the majority of us use selective cerebrospinal fluid drainage. So then we fall on guidelines. What do the European and the US guidelines suggest about when spinal fluid drainage should be used? The overwhelming message again here is that it is prudent to use selective cerebrospinal fluid drainage. Well, that's fine, but how do we define the cases that merit selective use? So what defines high risk? These are some of the factors that are used to define it. Extensive coverage of the aorta increases the risk. One of the qualitative areas to determine risk is the number of intercostals and lumbars that will be sacrificed by aortic coverage, and that can define risk. Any perturbation of the collateral circulation to the spinal cord, i.e. the left subclavian artery or the internal iliac arteries, can also impact the risk. A previous infrarenal repair is thought to be associated with risk. And the one interesting aspect that I think many of us are fearful of is the thrombus-laden or shaggy aorta, which can cause very unpredictable paraplegia, and it usually occurs early or immediately post-operatively and is usually devastating and irreversible. So it's thought that the mechanism for paraplegia development in the shaggy aorta is due to microembolism into the intercostals and lumbars. And perhaps the usual risk factors for ischemia do not apply. And we're even more in the dark about whether CSF drainage in these patients has a role prophylactically or not. One thing is for sure though, in a patient that doesn't have a drain that develops postoperative paraplegia, time is critical. An expeditious insertion of the drain can save patients from permanent paraplegia. So it's very important that the institution has the facilities to do that if prophylactic drainage is not used. So with this in mind, what are the trends towards use of spinal drains? Well, I think this publication is quite informative. Nearly 3,500 patients having endovascular aortic procedures. This is SVS VQI data between 2014 and 2019. And again, this confirms that the spinal cord ischemia rates are falling. But the prophylactic CSF drain usage is static. But one interesting point that is noted is that if patients require a postoperative rescue drain in an emergency, then in this cohort of patients was associated with worse outcomes. So why not use prophylactic drainage for all patients? Is there a downside? The answer is yes. Although on the whole, drains can be inserted successfully initially, there is a complication rate up to 4%, as you can see by these publications outlined here. There is a fatality rate associated just with insertion of the spinal drain, and there is a relatively high minor complication rate. This is the snapshot of the St. Thomas's experience in the pre-COVID era. Just over 100 patients who had thoracoabdominal aneurysm repair, both open and endovascular in this cohort. You can see the cord ischemia rate and the paraplegia rate there. Prophylactic drain usage or not did not significantly impact the cord ischemia rate. Some of these patients were urgent, so this is a heterogeneous group. You can see that just over 10% of cases, an emergency CSF drain was needed. We use staging, as I mentioned, as in many centers, and this mainly for extensive endovascular repairs is either in the form of leaving a branch out, as you can see on the left here, that is then completed a number of weeks later, or placing the thoracic endograft first. And this is really our preferred strategy for most of the staging, and completing the repair in a second stage. We rarely use a CSF drain for the first stage, and you can see that in these patients who'd been staged, there were 2 cases of cord ischemia, both were temporary. Our drain usage has remained static in this snapshot. Generally, we don't use, as I mentioned, a drain for the first stage, and not for extent 4 or pararenal aneurysms. And you can see here how aggressively we use CSF drainage. We only do that if the patient has developed symptoms, maximal drainage up to 7 to 8 hours. And we clap the drain in the morning of the surgery, and in the morning of the post-operative day where we intend to take it out, and remove it 6 hours later once we know that no problems have developed. In our experience, drain usage can be associated with complications as well. You can see there's an instance of headaches, CSF leak, drains can block, but importantly, they can cause intracranial hemorrhage. So in that experience, we had 2 elective cases, one of subarachnoid and one of subdural hemorrhage, and in both instances, these were fatal in the patients. So again, thought needs to be given as to whether a drain is needed or not preoperatively. So what are the take-home messages? The rate of spinal cord ischemia has reduced over the years, but it does still occur. And when it occurs, it has severe consequences. As a community, we think the selective use of CSF drainage is prudent because complications can occur after CSF drainage, and some of these can be severe. The trend that's demonstrated over the past few years is that we are moving towards less use of prophylactic drainage, but we're slightly uncomfortable in that this is still not informed by good level evidence. And the evidence that will be required is a large clinical study that compares patients in a structured way between those who have prophylactic drainage and those who do not. And this is an evidence gap that is still missing. Thank you very much.
Thank you, Bijan, for the very clear and important talk. We'll take questions at the end. And it gives me great pleasure to introduce our next speaker, Professor Chung Dan Kan from the National Cheng Kung University Hospital in Taiwan. Professor Chung is also president of the Taiwan Society for Vascular Surgery. He will talk to us about mycotic aneurysm treatment. Professor Chung.
Thanks to have this opportunity to present this topic in this meeting. I'm Dr. Kang from TSVS, Taiwan. Why we need to discuss this topic? Even though many surgery experiences were widely reported on how they treat their patients with mycotic aneurysm disease, there's still no definite best strategy and no randomized trial on answering all of these questions. Consensus are agreed that the golden standard treatment for this disease is still the aggressive reset the infected aorta and debride the necrotic surrounding tissues and use the bacteria-specific antibiotics. But there are still some debate topics persisted, including on the method of arterial reconstruction. The graft material are also important. Of course, EVA is also one of the topics. Back to review these questions, we must know all of this study and the clinical experience are based on just from case series experience. That is why, till now, we still have so many unanswered issues for further exploring. The same as many reports, this paper from Japan mentioned that using open surgery or using endovascular surgery in treating mycotic aneurysm have the same operating mortality. But when open surgery was done successfully, some patients might die of postoperative complications or experience long-term debilitation. On contrast, endovascular surgery still may produce reasonable outcome when patient selection was correct based on activity level, nutrition condition, and the degree of inflammation. Back to the key question still is how to select the right patient done with right surgical procedures. Challenge 1 were what is the clinical manifestation and the mortality of untreated mycotic aneurysm. The classical of mycotic aneurysm is a painful pulsatile and enlarged mass together with fever or other systemic infection features. And this disease prognosis is strongly related with its location, hemorrhage, and septic status. This patient suffered from intermittent fever with Salmonella mycotic aneurysm, refused to receive surgery. He survived well till now with progressive enlarged pseudoaneurysm, no fever, no systemic infection. Lucky guy. But I still strongly suggest him to receive surgery. Actually, from previous reported data, the mortality of only medical treatment is high, up to 60% in 1 year. But if patient receives surgery, the survival rate is increased a lot. The open surgery even carries with high surgical mortality and morbidity. However, no matter it was done by in situ graft interposition or extra anatomic bypass strategy, it brings the hope of patient survival up to 80%. Challenge 2. Prosthetic graft implantation on infected area is a primary surgery or not. Extra anatomic bypass has inferior pattern rate, but it avoids the infected area. This patient received extrafemoral bypass with aorta ligation. Survival well with patented graft. Till now, 8 years. Mueller reported their surgical result and proved that the in situ reconstruction is a feasible option for patients. Our hospital surgical experience using in situ reconstruction with augmented flap also documented with good surgical results. NTU experience also agree that in situ graft replacement provide good outcome for these patients. Challenge 3. Does bacterial strain matter? Can this patient be delayed surgery to later stage and then receive operation? Most reported culture strain in Taiwan was Salmonella. From my previous study result, we can find near 1/3 of patients might be culture negative. Among bacterial strain, MRSA might bring the worst result, but due to the sample size issue, there is no significant statistic difference in my report. Ruptured or persistent fever at the time of operation were significant predictor for persistent infection after surgery. Therefore, if possible, treat patient with antibiotic first might be an option. NTU reported data also showed with 40% cultural negative condition, and 60% patient received antibiotic treatment first for over 4 weeks, then receive surgery. So maybe delay surgery to suitable time is possible. Schaffer reported only 40% patients needed to be treated urgently. The remaining patients can undergo elective surgery, so maybe we need to judge by patient's individual condition to decide the optimal surgery timing. Challenge 4. Upon open surgery, what is the best choice for after substitute? Homograft, special coated prosthesis, or pericardial tube graft? All kinds of substitutes have their own benefit and shortage. In recent years, in Taiwan, many surgeons advocated to use the pericardial tube graft for better bacterial-resistant results. But from our previous reported experience, we think even only use ordinary prosthetic graft still can bring good results if we can use augmented flap properly. Challenge 5. Can stent graft be used on mycotic aneurysm conditions? From many reported document results, endovascular therapy seems is a feasible choice for primary mycotic aneurysm. Challenge 6. After surgery, how long will be the suitable antibiotic usage period? No definite answer. All of the suggestion is coming from the experience of what we treat the emphatic endocarditis. The best answer might be need some randomized trial, but I still suggest to use at least 4 weeks of IV antibiotic and then lifelong oral antibiotics. However, most of patients might discontinue their medication by themselves around 2 years later. Challenge 7. What kind of adjuvant therapy we can do for these patients? As we mentioned, the simple way might be antibiotic soaking method upon operation. CT guide drainage is a good option. Open debridement by direct open suck or from retroperitoneal wound assisted by vacuum closed drainage also be reported. Challenge 8. When should we not just do endo strategy only? This patient suffered from GI bleeding and shock, found with large AAA. He received EVA for life-saving procedure. 7 days later, he received Isfolapa to repair the GI condition. Even survival, but 4 months later, he was found suddenly expired at home. This patient had a gastric cancer post-surgery found with aortic anterior fistula, active bleeding with shock post-emergence TIVA, received thoracoabdomen surgery to resect all infected tissue, now survival well and waiting for esophagus reconstruction. From my and many reports result, fistula formation is indicated with poor outcome. Therefore, whenever fistula formation was found, EVA might be a good bridge option. Then, definite reoperation is indicated. Challenge 9. Worry about no experience in performing open surgery. Nowadays, some surgeons worry about they don't have much experience on performing the open surgery and it's time-consuming job, so they don't like to do the open surgery. For reinforce the open surgical technique, last year we, TSBS, started to hold the first cadaver workshop to teach our society member for how to performing the thoracoabdomen surgery. The operation is like a real-life body surgery, and we have experienced teachers to teach a participant in every cadaver teacher's table. We have positive and good response of participants' disease familiarity, technical experience, and confidence level. This year, the new cadaver workshop will be held later. We will arrange more refined structural course for open surgery to educate our new participants. We hope next year, after the COVID-19 pandemic, everybody in this meeting can attend our cadaver workshop. Above is my talk today. Thank you for your kind attention.
Thank you, Dr. Ken. I'd like to invite back to the meeting again, Professor Stefan Haolong, again, another good friend of ours. Stefan needs no introduction. He had a prominent career in Lille as one of the world's forefront endovascular surgeons before moving to Paris, where he is appointed Professor of Vascular Surgery and Chairman of the Aortic Center at the Hospital Marie Langelong in Paris. And he has published extensively on his many innovative and world-leading experiences in treating aortic diseases. And he's going to expand on the topic of branch EVA from the groin using steerable sheaths. Stefan.
Hello, my name is Stefan Haolong. I am a professor of vascular surgery and head of the Aortic Center here in Marie-Langelong, which is part of the Groupe Hospitalier Paris Saint-Joseph. Welcome to our hybrid room, which is a GE Discovery IGS-7. We will perform a complex case today using all the features of our hybrid room. And let me show you a couple of images from the case. It is a 68-year-old woman which has a large 65 millimeter type 5 thoracoabdominal aneurysm. I'm going to slowly scroll through the images to show you that the proximal landing zone will be in the mid-descending thoracic aorta, and the distal landing zone will be below the renals here and above the IMA. Okay. So once the percutaneous approach has been performed with a ProGlide system on both sides, we now get the discovery over the patient. So we switch from the open or percutaneous mode to the endo mode, and we are first going to register the fusion mask. So for that purpose, we will do an AP fluoro and then a lateral fluoro. Donc vous l'avez mis en route. And I need to position the patient with the spine in the middle. So AP fluoro, switch automatically to a lateral view. So this is a lateral view, and we position the spine in the middle. So this requires table height to be at 14 approximately. Now from table side, vas-y, fais-le. Justine is going to register the red image, which is the image from the spine from the pre-op CT, on top of the fluoro image. So first on the AP view, and then she's switching to the lateral view. And you will see that this process will last just a couple of seconds. Parfait. So once we're happy with the bone registration, we switch to this aortic view. This is just the outer line of the aorta, and you can see the blue circles are the origin of the target vessel. So the beginning of the procedure will be to try and access those very challenging target vessels, which are the celiac trunk and the right renal, to pre-stent them. And so with the fusion mask, I can position the table and the gantry, and also you can see on the fusion mask. So I have inserted a 20 French sheath in which I'm going to advance the a 16 French aptus sheath. Now we're going to switch to a celiac trunk best working position. So Justine is going to select from table side that best working position, and the system will automatically position itself, which will be RAO 72 degree. Now we're doing no fluoro, and I know that I need to get my table down to nicely position the my table, and to position the celiac trunk origin in the middle of my image. So I'm going to slightly increase the image size. So this is a digital zoom. It doesn't require performing more radiation. Okay, parfait. Elle peut respirer. So you see that we are actually not bad with our fast fusion registration, but we're going to fine-tune that. And this is what Justine is now doing, again from table side. And this is now perfectly matched. You can see the origin of the celiac trunk, the origin of the SMA are nicely positioned. So I think we are now inside the celiac trunk. So I'm going to advance my catheter and then shoot a small angio. Wow, it's very tight stenosis. Let me shoot a small angio to check where I am. Il faut surtout pas que tu lâches, hein? Well, not an angio actually. I'm just going to do a fluoro. There you are. Tu vas storer, s'il te plaît? I can store this fluoro from table side. So I'm going to try and advance a B-Smooth 718. So a balloon expandable cobalt chrome stent inside the origin of the celiac trunk. You can see here it tracks well, so it has a very nice profile. I'm going to move that slightly higher. Tu peux le tenir comme ça, s'il te plaît? And now Justine is going to open the stent. Vas-y. Very nice. Et tiens ça, s'il te plaît. Et tu dégonfles. So you see on the review mode that the stent is nicely positioned just at the origin of the celiac trunk, and we have reopened the celiac trunk. So I'm quite happy with this first step. So I'm going to get rid of the Rosen wire here. And now we are going to straighten the abscess sheath, and we're going to go down and try and access the, tu peux enlever ça, the left renal. Again, a collimation is performed on the fusion mask in order to really focus on the area of interest. And here Justine is slightly enlarging the image, and then to advance into the renal artery. So let me check that it's the renal artery here. I really have no doubt, but I prefer to double check. So this looks like a renal artery. Tu peux storer, s'il te plaît? I'm going to advance a Rosen wire, and then I'm going to shoot an angio and decide whether I need. I see that what looked like quite a significant narrowing on the pre-op CT is actually not that bad. So I'd rather not stent, not pre-stent that renal artery, because then it might be might become more difficult to advance the bridging stent once the endograft will be in position. So I will not do anything more on this renal at this stage. So I'm going to start releasing the endograft. Vous m'avez fermé ça, non? So the celiac trunk has opened at 1 o'clock, the SMA at 12. The right renal artery should open at 9:30, and the left renal fenestration should be at 3 o'clock. So I need to do some slight rotation so that I position. You can see at the bottom of the image the two lateral markers of the left fenestration at 3 o'clock. There we are. Let me see if I can track my catheter over my Terumo wire. Yes, we can. So I'm advancing my bridging stent inside my 6 French sheath into the left renal artery. The best working position for the celiac trunk, and advancing now the system automatically into a 72-degree RIO, which is supposed to be the best position to access the celiac trunk. Elle peut respirer, merci. So I think that if we position the bridging stent inside the previous stent, I think we're perfect. Slowly advancing the bridging stent through that kink. So Justine will, c'est bon, je vais prendre. Justine will inflate the B graft plus to 10 atmosphere. Tu peux nous donner un ballon de 9,2 sur porteur long, s'il te plaît? So it really looks good, and we have approximately between 15 and 20 millimeter of bridging stent inside the target vessel. So I'm very happy with that. Going down and then rotating again clockwise to position the tip of the sheath, hopefully in front, merci, of the SMA fenestration. Now we are through the branch, you can see, and I'm advancing my catheter, and I'm going to get now the abscess sheath at the level of the branch. Voilà. The wall, you see, I know exactly where I need to go because I have this marker contour of the origin of the SMA. You would think that I cannot miss it, but remember, we are in the middle of a very large sac. Now we are in the SMA. I'm putting the aptus sheath through the branch in order to be able to advance the 790 sheath into the SMA. Okay, no doubt that I'm in the SMA. Peut respirer, merci. I'm gonna try and advance again slowly in the bridging stent, which really tracks well. Slowly. There we are. How useful those markers are. I know that I'm a bit short into the target vessel, so I'm going to right away position a second bridging stent distally, which is something in information you would not have without the fusion mask. Okay, that's perfect. Sometimes you need luck, and I think looks pretty good. Let me double check where I am. Well, this seems to be the right kidney. Now, Justine's going to deflate the balloon, and I'm going to advance the sheath back inside. Rotation. Perfect. So we are now looking at the 3D CT, the cone beam CT that we just acquired. And as you can see here, we have a very good, satisfactory image quality to check the endograft and the bridging stent. So the celiac trunk here, the SMA now, the right renal artery here, and then the left renal fenestration. And now I'm going to move to a sagittal view. And I can see that my bridging stents are very nicely positioned. And you see right away I have a 3D image of my reconstruction. I can see the nice overlap here. I can see also the nice overlap in the celiac trunk. The nice position of the stent protruding inside the aortic lumen for the left renal fenestration, and a nice anatomy of the right renal bridging stent. Now finally, just to double check the position of the fenestration, you can see that the renal fenestration really looks good, and I see my stent protruding in the aortic lumen. So we're done. Very happy with the result.
Okay, thank you, Stefan. It's a really amazing talk. We move on to our final speaker for today's session. I'd like to welcome back Professor Eric Verhoeven from Nuremberg, who'll tell us about an insight into the German FIVA approval for bridging stents. Thanks, Eric.
A very good afternoon. I have been asked to discuss the FIVA approval study with bridging stent grafts from the company Bentley. My disclosures are obvious. I was part of the early launch group of the B-Graft Plus in Germany, and I'm a consultant for Bentley, but not only for Bentley, also for Getinge. And I obviously include Cook, as I've been working with Cook for more than 20 years. So I'm going to explain you why we got interested in the B-Graft and the B-Graft Plus, and then go to the approval study in Germany. This is a timeline of this covered stent that was reworked completely to now have a new B-graft peripheral that can also be used for fenestrations, and a completely new graft, which is the B-graft peripheral plus, that is designed to be used in branches. The B-graft plus, as I say, is a completely different graft with an extra layer. It has a sandwich design and makes it very strong and reliable to be used in branches where there is a gap to bridge. So why did we get interested? Well, the first impression for a surgeon is always important. I was also convinced by the testing by the company. Our first clinical experience confirmed our ideas about this new covered stent. And finally, also the logistics. Here you see the performance with regard to kink resistance, which is very important both in fenestrations and branches. Here the radial force, which is exceptional when you look at the B-graft plus, which is the blue column. And here the first clinical experience where we found out that the visibility was fantastic, but also the logistics, as this bridging stent graft comes in all diameters, but even more important, in all lengths, which means that we have the short ones, 22, 23, we have the intermediate ones, 27, 28, which is important in fenestrations, and then the longer ones, 37 and 57. Here, a few images to demonstrate the positioning, deployment and flaring of the B-graft in the left renal artery. And here, the same in a lateral view in an SMA, and the final result on the right. So it would be fair to say that we used the B-graft initially mainly in the 27, 28 millimeter length, but now we also use them in the shorter lengths. In total, we used the B-graft in 162 patients with 318 B-grafts in total. We had a few technical issues with positioning. You have to get used to a new covered stent. We needed a proximal extension to have a good sealing in the fenestration in one case. And we had this little problem with stent migration in 5 cases. We've learned to do this with the B-graft because the inner side is the metal. What you like to do is when you deflate the balloon is to advance the ANL sheet over the balloon inside the stent again to guarantee the insertion of the flaring balloon and the angio catheter. So we had a few initial problems with that I wanted to mention. Here is a little example where we positioned our graft a little bit too far inside the fenestration and decided to add another more proximal one immediately. And this is the advancement of the sheet. We wanted to add another one here because we were not 100% happy. And this can create problems, of course. And here the stent graft was pushed out, but fortunately, the second one was easily positioned and deployed. We had 2 occlusions, only 2 occlusions in total in 2 left renal arteries. One was clearly a transition problem that we should have solved with a self-expandable stent. I'm also showing you a few images of the B-graft plus, and you will see in my conclusion why. Here you see that the B-graft plus is adapting to the anatomy very well, first in the celiac artery and then here in the SMA. And here the same, a B-graft plus in an inner branch for a renal artery, and I will discuss inner branches in another presentation. This is a B-graft plus in a branch device, and again you see that it's kink resistant and adapting to the angulation of this vessel. And here post-op CT in this particular patient where we had the inner branch for the right renal artery and the IBD also for the right iliac. So in total, we used the B-graft plus in 91 patients, both in TAA and in IBDs, 167 in total. We also here had a few similar problems, one disconnection due to the advancement of the sheet that was easily solved. And we had 3 occlusions, 1.8%, and one in an IBD and the others in a renal artery. And I mentioned that transition problems can occur. You have to watch this, and you have to be liberal in using a self-expandable stent to extend and smoothen the transition zone. What is the problem? Well, the problem is that whatever bridging stent graft you use, it's off-label. And we were very keen on trying to get an on-label indication for the B graft and the B graft plus, and that is why we embarked on this study. It's a physician-initiated trial, but obviously it is absolutely supported by the company Bentley, and it is the aim to get on-label indication for the use of the B graft in fenestrations. It's prospective, it's a single-arm, multi-center study in Germany. You can see the centers listed there. We want to gather about 100 patients with about 250 B grafts. And the objective is to evaluate the safety and the performance of the B graft covered stent in FIVA. The primary endpoints are obviously a efficacy endpoint, which is a technical success and a patency at 12 months, and a safety endpoint, which is the absence of procedure-related complications and bridging stent-related endoleaks at 12 months. This is not a surprise. If you look at the secondary endpoints, well, there is a big list here. I don't want to mention them all because they are the usual suspects in these types of studies. So to conclude, I'm positive and grateful to Bentley because they are the first medical company that are now supporting a physician-initiated trial to finally achieve on-label indication for covered stent in FIVA. As I mentioned, we are talking here about the B graft study in FIVA. The first 7 patients have now been included, but in parallel to that, we are also doing a B graft plus study in BIVA or for branches. And that study is also running with Martin Austerman from Münster as the PI of that study. Thank you very much for your attention, and I wish you all a very great Congress.
Thank you very much, Eric. So I know we are overrunning a little bit, but we do have some time for questions for a very exciting session. Before we do that, can we do a quick group photo? Can we turn on the... Yes. So thank you for staying behind, everybody. Is it done? Right. Okay, so we can, who wants the first question? Eric, can I ask you a question first because you're still there. So what is your view? You know, we listened to your talk on the inner branches and the requirements, you know, and I can see that many of those branches were actually single branches combined with fenestration. So how do you see the market for the future for an off-the-shelf inner side branch device like the T branch with current limitations of diameter?
Well, thank you, Stephen. And obviously, we have so many options nowadays. We can go from above, we can come from below, either for fenestrations and branches, as Stefan very nicely showed. So you have multiple options. You have the option of combining fenestrations and branches. So we need to find the best solution for each individual patient. I think the strive to have off-the-shelf devices will go on. It's an important one, but not at a too high cost of diminishing the durability, because then we don't help the patients. Marcelo Ferreira has discussed an option with 1 fenestration and 3 inner branches. I discussed an option with 2 inner branches for the renals, a fenestration for the SMA, and a double with scallop for the celiac. These are all potential devices that may work well in these complex cases when they are acute. but you have to be open and honest about the limitations, and you have to look at them and not just hope that everything will be fine. And I think I hear and see that far too often. When somebody chooses an option, suddenly that is the best option, and he forgets the safeties and the limitations of that option. And I'm trying, I'm getting older, I'm trying to be more balanced and cautious in everything I do and everything I propose, especially in presentations and meetings, because I think we have an ethical role to play there. So yes, of course, an option, but we need to work it out very cautiously, and we shouldn't forget all the other options and balance them.
Anything to add to that, Bijan?
Really eloquent answer. Hello, everybody. Greetings, friends. I'm just pained that I can't be with you in person. I think I would echo that. I think it comes down to flexibility in graft design and leveraging that. And now we've got lots of tools in the armamentarium to do that. But also at the same time, and I'm getting a bit older as well, learning when to say no, and when actually doing this kind of repair, despite all the options that we've got, is not in the patient's best interests. And I think the next 5 to 10 years will be all about a personalized approach to how we treat these patients with aortic aneurysm. So, which patients to select for repair in the first place, and then given all the knowledge that we've accrued over the past years, which solution we think is going to work best, and where possible, use the solution that we've been tried and tested for 10, 20 years. And if you have to deviate from that, then make sure there is a good reason to do it and that there's evidence behind it.
Yeah, so one of the solutions to the angulation is to say no, is to avoid them. I suppose there are cases that you would definitely not do all those maneuvers that in very angulated aneurysms. Is that correct?
Yeah, and I think it's still difficult sometimes to predict how that will behave intraoperatively. So, I'm sure we've all had this. Some cases where you think this is terrible angulation will have a lot of problem, actually straightens out very nicely. And, there are maneuvers that we use now through and through wires, etc., that can circumvent that. But I think, angulation can be evil. And I've got a low threshold in patients with severe angulation who, again, as I said, are candidates for open repair to have them, have that preferentially. But in a lot of cases, they're not. And I think then it comes down to a conversation between you and the patient to say, look, this is to some extent unpredictable. But also, as I said, to leverage again, the flexibility in graft design. So, use branches instead of fenestrations where possible, because branches are more forgiving in angulation. And I've found in a handful of cases that where you can use an upward facing branch where you can't use an inner or downward facing, that's worked in the face of angulation very nicely. So again, it comes down to a personalized approach.
Vijana, I want to ask you about your selection in your protection for spinal ischemia. Now, I've also, like you, I'm doing less and less spinal drain. However, the last 7 years, I think recently, I think last year in COVID, I have one spinal ischemia, and I put in one of the endospan, and I didn't even touch the T8 level, and the guy ended up having a spinal ischemia, which up to date, I'm still perplexed about it. He's a heavy smoker, similar, you said the shaggy aorta, which I agree with you. And probably even when I scan him, his anterior spinal artery are totally patent. And I think your thing about, you talk about the spinal ischemia on the TIVA is a different ball game compared to open, and I totally agree with you. But the selection, I'm still very perplexed. When we do this, selection of who to prophylactically put in a drain, I'm still very perplexed in this. Can you give us some more guidance?
Yeah, thank you. I mean, I think the evidence is lacking basically to objectively guide the selection. And we've all had these cases where, the patient wakes up, paraplegic, and actually it's not the highest risk patient that you would perceive. So how do we guide selection of spinal drainage? Well, I mean, there are cases that are equivocal, but there are cases that are clearly high risk. So, total aortic coverage, any perturbation to the collateral circulation, I think there are some people now that would even not consider a spinal drain for the higher risk cases, but I'm not one of them. I mean, I think in a high risk scenario, you are better off with a prophylactic drain. How do we answer the high risk question? I almost think you need a sort of algorithmic approach using tens of thousands of scans and clinical cases. This is where that sort of big data science approach is probably useful, because you're not going to answer it even in the traditional multi-center work that we do. It's just not, it's almost like an orphan condition. It's something that occurs relatively rarely, so you need a huge volume of data to answer what is high risk. But until then, what do we do? I think it comes down to the expertise in your center. So, we're putting less drains in, people are becoming less used to putting drains in. You need to focus all that experience into, a few of the people who put the drains in so that they remain expert at it. And if you can't get it in quickly, if there's a problem, then consider prophylactic drainage for the high-risk cases that you're not going to be able to assess properly post-operatively, or that are high risk. That's our approach. Do we have a perfect algorithm yet? No.
Thank you. Can I ask Peter Govandi? Thank you for your algorithm. I just wonder how you feel about cover stents in very small Asian patients, whose external iliac artery could be just 6 millimeters or less. Do you think it will work the same?
Yes, I expected this question. I try to use as much as possible cover stents, but there is indeed the restriction of size. Yeah, and especially I know in the Asian people, the sizing can be very small, especially for reconstructions with the iliacs. In my experience, going lower than 6 millimeter will jeopardize the deconstruction. It means you will have a higher risk of kinking of the stent due to the movement of the aorta, especially in the common iliac artery. In terms of the internal iliac, sometimes of the hypogastric 5 millimeters is feasible, but lower than 5 millimeter, I would use then self-expandable stents because they are thinner. So you will have less material inside the aorta, inside the artery. So you will not jeopardize the diameter of the vessel.
Thank you. Last question here from the audience to Julian is that you have a 7.5% stroke risk for the elective cases. Why is that? It seems to be a little bit high. And these are standard alpha cases, or those would be including complex ones?
Those three are actually complex who involve debranching previously. The landing zone was mainly zone 1. Actually, the 3 cases, I actually went and looked into it, and they were very minor stroke. But for the sake of the collection of data, I still, they had full recovery. One of them had paradoxical AF, and I think about 7 days later, he had a diplopia. And because of the diplopia, 7 days is an emboli probably from the heart. but it's still included, sadly, in the system. Another chap had a confusion, day 10, on rehabilitation on the ward, and he also had a microemboli, probably from a shaggy aorta. And both, two of them completely recovered. The third one was also another complex debranch, previously ascending aorta, and then the landing zone has to be at about zone 1. So all these that's why the 7.5%, 3 patients out of 40, which also I did not expect. These 3 people, we done all the things we can, and normally when I do the TVAS, especially above zone 1, I get the ACT to about 250 to 270 and make them quite wet, but still they suffer. So, I mean, I'm just being honest with the data.
Questions? Peter? Robert? No? We can't hear you. You're muted, Peter. Yeah.
Thanks. I'm unmuted now. This question of Peter, again, just follow up on Stephen's question about sizing. How do you actually size in a particular calcified iliac for your iliac stenting?
Yeah, I try to see what is the available space that can be reached when you do a PTA. So it's not. I think it's not wise to try to gain the same diameter as the more healthy part of the aorta above and mostly above the lesion. So we try to gain, especially in the infra-renal aorta, on the patient. Sometimes it's lower than the average healthy diameter of the aorta. So I try to see in front and try to calculate what could be the possible diameter that we can gain with the calcium.
Okay, thank you. If I may ask a question to Eric as well about the inner branches. I don't have much experience on this, but looking at the new CryoLife JOTEC thoracoabdominal grafts, these are using inner branches. Do you have any experience with those grafts?
No, for fenestrated, thank you, Peter. And for fenestrated and branched, I stick to Cook, and that's my decision. I've worked and developed with them, and I think they are still far ahead of many other companies. I think we need to welcome the other companies to jump on this board and to play this game. But again, would I be cautious and not try to jump too quick? Because then you make mistakes, and we've seen a few already, and then designs that didn't work. And we should cautiously look at what is out there and what we can achieve with other grafts. And I don't mind the competition, but I haven't prone to jump to other companies because I'm very, very happy with what Cook is offering me for my patients. But I'm very open about it.
Okay, thank you, Eric.
Welcome.
Okay, so thank you all. I think it's time reluctantly to draw this meeting to a close. I believe we had a very fruitful, very long day today. It's now 5:30 here in Hong Kong. So I think the best today is to see all the friends again, although it's virtually. Really looking forward to have you all together, maybe next year, face to face. And we still have tomorrow half day, so I think Bijan's going to be there tomorrow to give a talk. And then also thank you all for participating and making this a success. Bye-bye.
Bye.
Thank you.
Bye. Thank you. Bye.
Thank you. Bye.
Bye.
Bye-bye.